surgeries for common pathologies, trauma, arthritis, ligamentous injuries around the elbow, etc., which I am sure all of you face in day-to-day practice. The conveners for this program, Dr. Harshad Argekar, Dr. Satish Mutta, and the Secretary of the Bombay Orthopaedic Society, Dr. Ashish Fadnis, are here, and they have assembled a fantastic program and a fantastic starcast, and I'm sure we all are looking forward to going through it. Can I have the PPT on? Before we go on, it is my proud duty as President of the Bombay Orthopaedic Society to introduce Bombay Orthopaedic Society to all those of you who don't know much about it. But what is special this year is that the Bombay Orthopaedic Society has turned 60 and is celebrating 6 decades of excellence in academics. Orthopedics, it is in Mumbai that orthopedics essentially began in Mumbai, in India. One of the first orthopedic surgeons in Mumbai was Dr. Argekar, who in 1936 established the first orthopedic unit at the Bijaywadia Children's Hospital in Mumbai. And in 1942, he set up the Department of Orthopedics at the famous KEM Hospital in Mumbai. He was subsequently honored with an honorary fellowship by the British Orthopaedic Association. In the founding years, 1965, when the Bombay Orthopaedic Society was established to promote academic excellence and collaboration among orthopedic surgeons and spread the new message of orthopedics, a newly formed subspecialty. The first president was Dr. Argekar and secretary was Dr. Ellen Vora. Over the years, the Bombay Orthopaedic Society has grown, and there have been a number of people on whose shoulders we have stood proudly in order to grow and in order to achieve what we have achieved over the last 60 years. I'm sure you know a lot of these familiar faces are familiar to you. Legends in orthopedics, Dr. K.T. Dholakia, Dr. K.V. Chaubal, Dr. D.D. Tanna, Dr. Ashok Johari, Dr. Anand Joshi, and many others. In the early years from the time it was founded, BOS used to have a bi-monthly clinical meeting, and twice a year we would have a CME program which would run over 3 days. In 1966, we started with WIROC, the Western India Regional Orthopedic Conference. Over the years, BOS grew rapidly. We started having bi-monthly clinical meetings and bi-monthly master series continuing medical education programs. BOS started running a lot of courses because there was a demand for learning. We would run courses. At one time, we were running almost 27 courses per year. Now our courses have evolved into something very spectacular, flagship courses which run over a period of 1 week. We have a bi-monthly postgraduate teaching program, fellowships and observerships for all those around India who would like to come to Bombay. We have fellowships and observerships. You can find details of this on the website of the Bombay Orthopaedic Society. BOS is 60, and where do we stand today? BOS is an academic powerhouse. Directly or indirectly, we have influenced more than 1/4 of all practicing orthopedic surgeons across India. But our legacy is very strong. But with young, dynamic members, our future is even stronger. So what is the way forward? The way forward for Bombay Orthopaedic Society is to innovate, to educate, to collaborate, and to elevate orthopedic care for the benefit of our patients. With this in mind, in this Diamond Jubilee year, the Bombay Orthopaedic Society started what is called as the BOS Worldwide, a forum to build bridges with societies across India and across the globe, share knowledge, experience and expertise with each other. We've started a number of programs which include the worldwide webinars, the outreach programs, the current Relive Surgery Symposia, monograph series and fellowship programs. The worldwide webinars are held on the second Saturday of every month. We just finished one on unstable shoulders, and in the next month we are going to have a webinar on difficult elbow trauma. I'm sure you will learn a lot from this. Do not miss out. Details of this are available on the Bombay Orthopaedic Society website. We are going through a live shoulder elbow surgery symposium today, and there is going to be a shoulder elbow course which is concurrently running along with this, where delegates from across India spend 7 days with leading shoulder elbow surgeons in India, in Mumbai. They visit the operation theatres, they actually go and assist these gentlemen for surgery. There is a they attend today's live surgery symposium, there are cadaveric workshops, there are sawbone workshops. All of this is over 1 week, so that when you go back, you feel that you have learned something concrete in shoulder and elbow and would like to go back and start practicing this from the day you go back. Next month we have a BOS basic spine course. Again a similar program, 7 days of intensive training in spine through lectures, through case discussions, visits to ORs, sawbone workshops and cadaveric workshops. So BOS has a full schedule, and I look forward to people from all across India to come over and join us for our programs. We also have a deformity course, limb deformity course, which is there next month in February. Again, details are available on the website, and later on in March we have a basic ankle foot course which I'm sure you all will all love to attend. So with that, let's move on to the main part of the program, and let me invite the convener of the show, Dr. Harshad Argekar, to come over and take it over from here.
So good morning everybody, welcome to Mumbai. Thank you Dr. Gautam for this kind introduction, and thank you INTAS for arranging this wonderful meeting with everybody. So I hope everybody here is online and and everybody can see me. What we are planning for today is 12 surgeries. All of them are Relive surgeries. Some surgeries will be by me, Dr. Pradip Nemade, Dr. Prasad, Dr. Prashant, Kamble, and Dr. Sangeet, Gawhale, and Dr. Mihir, Patel. So it's a mix and match of surgeries. We have tried to keep it so that the general orthopedic surgeons or the occasional shoulder surgeons will be able to follow what we are trying to tell them, and the surgeries will be easily replicatable at their center. So what I'll do is I'll start with my first surgery. I'll be taking on a multi-lock proximal humerus nail. Now, as we all know, PHILOS has been the kind of gold standard for any proximal humerus surgery up to now. But since the last 4 to 5, I would say 3 to 4 years, we've been shifting to this new humerus multi-lock nail. So that's the case which I will be showing you a real-life surgery of. This is a valgus impacted proximal humerus fracture in a 68-year-old gentleman who had a history of a domestic fall. That's the pre-op, and after that is the post-op, but I'll go directly to the surgery now. Entry. Ideally, this is not a guide. I won't show you the instrumentation because that's another 30 minutes. I'll just show you the X-ray analysis. The 17th of March 2025. We are at Cooper Hospital. My name is Dr. Harshad Argekar. We are going to do
instrumentation. If this time
humerus fracture for a 61-year-old male. The fracture is on his left upper limb, left shoulder. And what we are going to do is a multi-lock proximal humerus nail. So let's look at the x-rays first. So this is the x-ray, this is a recent view. The patient is about 3 weeks since injury. He had other medical issues, so he couldn't be operated earlier. So you can make out, this is the humeral head and it is tilted in valgus. The shaft is gone medially. There is a trochanteric fragment. There is some amount of soft callus which is seen. In the lateral view, the shoulder is in place, it is not dislocated. The fracture distal shaft has gone slightly anteriorly. As was expected, the proximal fragment is tilted posteriorly and in varus. So we need to correct that when we are doing the surgery. Now if you look at your CT scans, the transverse cuts can make out the humeral head is well rounded, there is no split. There is a fracture line at the level of the greater tuberosity. The lesser tuberosity seems to be intact. So this appears to be a 3-part fracture. The sagittal reconstruction more or less tells us the same thing. There is a fracture line here. It may be extending to separate the greater tuberosity. You can see that the distal fragment is tilted. It's gone into slight valgus. And this valgus is what we need to correct. We need to align the shaft. The articular surface is intact. The notch between the greater tuberosity and the articular surface looks okay. Where the rotator cuff is inserted, that area looks good. It doesn't appear to be broken. Our entry point is in the articular surface. If you align the shaft and you draw a straight line from the shaft, where it intersects the articular surface after reduction is your entry point, because the nail is a straight nail. The 3D reconstruction tells us the more or less the same thing. There is a valgus displacement and there is a slight posterior tilt of the proximal fragment. There is slight comminution on the lateral side. The greater tuberosity looks okay, but we'll come to know during the surgery whether it is separated as a separate fragment. The lesser tuberosity is definitely intact. It doesn't appear to be broken. In fact, the greater and the lesser tuberosity appear to be more or less in place together. That's the bicipital groove where the biceps tendon is supposed to go in. The proximal end of the bed, the head end of the bed is raised to 45 degrees. We've kept a pillow below the knee so that the knee stays a little relaxed. We'll be operating on this side. My Siam is on the opposite side and my Siam viewer is here. You can see we've already taken an AP view that is showing us everything completely. The arm is to be draped free, this entire, so that no fluid from the table or the bed or from your surgical field goes down. That's the long edge. Put a third sheet. We use 3 sheets, one on the bottom, one on the top, and the other one over the head, and kind of separate your patient out from what you have. So take one stitch, just dermal. If you want, you can use staples also to get this done. I prefer to use a stitch so they don't go deep and generally don't leave scars also. So rather than towel clips, we use drape stitches so that they don't come in the way. Otherwise in the Siam, the exact place your towel clip handles are seen. So drape stitches are always better. This is the arm. You've draped it freely so that it is completely mobile. I'm feeling the coracoid process here. That's the coracoid. That's the margin of the clavicle. That's the front of the clavicle. This is where it has become the acromion. That's the acromion. That's the posterior border of the clavicle over here. So this is the acromion. Okay, that's the humeral head. So my incision is going to be anterior to the anterior angle of the coracoid. This is the anterior angle of the coracoid. That's the acromion. My incision is going to be here. Give me a ruler if you have a. Yeah. So as I marked it before, approximately from the tip of the olecranon, 4 centimeters, between 4 and 7 centimeters is the expectation of the axillary nerve.
All right. So the second part. कुठे गेलं रे? wait. बंद कर. हाँ, number 3. Full screen.
Take an incision.
So you split the deltoid between the anterior and the middle raphe.
These are the deltoid. What we have taken an incision on is the fascia of the deltoid. So
And that directly exposes the area where the rotator cuff is.
So that's the joint fluid.
So you go through the muscle
line with my
of
incision.
the supraspinatus.
Take a smaller cannula. Okay. These are the fibers of the rotator cuff. Okay, these are the fibers of the rotator cuff. It's inserted into the greater tuberosity. The greater tuberosity doesn't appear to be fractured. Okay, I'll just go through here and then find the joint. Give me. Hold this, sir.
In the depth is the humeral head.
So that's the humeral head. I don't know if it can be made out. Can you see? Varun, this there? If I go inside, shoot please.
And yesterday Dr. Pradip talked about reduction maneuvers.
Tuberosity. I can now feel separating whatever callus is there just to get
So put an artery or a spike
separating out.
and just lever the
Align
distal
that
fragment
into
out.
from the valgus alignment to the neutral alignment. Okay, shoot. All right.
So reduction is direct because you're going directly into the fracture
So that's
site
the
and
neutral
reducing it.
alignment. The humeral head is now facing the glenoid scilotendinous junction or the bone tendon junction. This is the shaft here. Okay, I have freed it out and what I can see here is the biceps tendon. Okay, this is the biceps tendon. This is the bicipital groove. Here you have the lesser tuberosity. It is intact. This is the greater tuberosity. That's the fracture zone. On this side, I don't know if you can make out on the video, but here is the shaft. It was encased in fibrous tissue and callus, which I have managed to free now, so that now my shaft has come out more laterally and I can align it better with the proximal humerus. Now I'll just take an ethibond, number 5 ethibond, and that's the tendon and that's the bone. So at the bone tendon junction, I'll just take an anchoring stitch so that I can then use it. Okay, 1 and maybe 2.
So there's a standard
Manipulate my proximal
posterior anchor
Okay, shoot please.
so they can manipulate
So it's
the
not gone deep, but I'm
tuberosities
going deep enough
inward
so
and
to
out.
get good anchor.
So this is another step which I just want to pause here. When you reduce the humeral head, it's mobile. It keeps on moving up and down anterior and posteriorly. So what you should do is ideally fix the humeral head directly to the glenoid. So your now humeral head stays stable in one position. This is a temporary fixation. You will remove these wires at the end of the surgery, but then you have a base on which you can then build up the entire thing. Even when you're doing a felar split, if the head is a shell and it keeps on moving, you can do this. You can just impale it to the glenoid so that now the glenoid is, the humeral head is stable on the glenoid, and then you can build up your remaining fixation. Of course, the wire should be in such a position that it doesn't come in the way of your nail or
This is
plate.
the anterior part, this is the posterior part. I'll go some.
Now that's the entry. Your entry has to be at the apex of the sphere which you see.
In this case, my entry is not exactly at the apex. I've made an error here. My entry is slightly anterior and that has caused the head to fall back a little posteriorly, but just keep it on the apex.
Here, make a blunt entry using the tip of the key entry is, and if you project it down, it should. So that's the sleeve to protect my rotator cuff.
There is a hollow mill which will core out the entry point.
As expected, the
Ensure that there is enough bone between your fracture site and your entry point. Sometimes this communicates, so if it does communicate, it's not a problem. We just put a K-wire in this area, just put a K-wire so that your nail doesn't migrate laterally, it stays medially. But if you keep about a centimeter gap between the fracture end and the articular surface, then this communication will not happen. And the drill which is in the instrument is a hollow mill, so that has to be sharp. If it is blunt, it will just blow out. If it is sharp, it will cause a nice hole and you will get a nice bone plug also. That bone plug you can use as a graft.
Give me the guide wire.
So here you can make out the entry should have been slightly more on the posterior side,
Right side
not exactly at the apex.
B, followed by C, which is an anterior-posterior lock, followed by D, which is a transverse lock.
Now if you just see the nail has got threads in it. So when you put your locking screws, the locking screw locks inside the nail, so there is no toggle. The screw stays very stable inside the nail. In the AO nail, the original nail, these holes have plastic bushings on it. So they have even a tighter fit. This is the Indian nail, it doesn't have a plastic bushing. So the fit, there is slight toggle, but in the AO nail there is absolutely no toggle.
Then E is an upward lock. Screw.
So nowadays all holes are labeled as A, B, C, D, E starting from top going distally. A and B are the first two holes. C is an antero-posterior lock for the lesser tuberosity. D is again lock for the greater tuberosity. E is an upward lock, the calcar lock, and then F and G are the distal locks for the proximal humerus.
E is the calcar lock, which goes upwards and goes from the shaft onto the calcar. F and G are still locks, whereas the C is an AP lock. Now this screw will go here. There are threadings in the nail also and on the screw also. So once I pass the bolt inside, the toggling becomes very less. Ideally there is a bushing here in the A.
This is a 7 millimeter nail. AO comes in 8 millimeter.
Is 5. So I'll go 2.5. You have to push it 2 in, then my calcar screw may not. So that's about it. In the lateral view, we just take entire thing internally, including my proximal fragment, take a shoot. The nail is a little more anterior. So that's how deep my nail is.
So the nail should be below the articular margin.
So you can make a,
say about 5 millimeters.
Position. That's my subchondral area. The measure here. So you can see that the screw head is situated here. Now I'll put it a little more inside because I feel this is a little more prominent. So I'll put it inside and check on CM that it is not going in deep, too much deep. Shoot please.
So there are two drills for this proximal 4.5 locking bolt. One is for the shaft and the other one is for the conical part of the proximal end of the screw. Now that conical drill you may not use in all cases. If the bone is soft or porotic, the conical part will go on its own because it has got a cutting edge and it will make its own path. But if you find that the bone is too hard, you can do a double drill like you do for a PFN, the lateral cortex drill, and the entire, the main shaft drill.
Now if the anterior cortex is too strong, there is also an over drilling for the conical portion of the screw to sit inside.
Now all these screws have got a screw and screw lock which I will be showing you now.
So I'm pushing it with rotatory motions so that it's absolutely on bone. Now take a picture. Okay, give,
Now here you have to be very careful because this is the area of the axillary nerve. So you have to don't put it blindly, take a wider incision, dissect it out using artery, see that you are on bone, you bear the bone of periosteum and then put your sleeve inside so that the axillary nerve
the other one
is
also.
not affected.
Nice.
The distal lock is standard, it is at an angle of 25 degrees to each other, it goes through the jig and absolutely percutaneous.
Artery.
We are not worried about the distal lock, there are no major vessels or nerves there, but in any case you always use an artery to separate the muscle and go directly on bone.
Doesn't get diverted by any soft tissue coming in the way. Throw कर देना बेटा. So the sleeve goes here,
So that's the screw in screw.
directed posteriorly.
The screw in screw is always directed posterior and medially because posteriorly we have a strong bone in the humeral head. So the direction of the screw and screw is always posterior.
Yeah. 38. So I'll put a slightly smaller screw length because my screw initially was 40, the first screw. So I'll put slightly smaller screw length. Sure, without. Cut.
That's a 3.5 screws
With a dash reduction.
which will go in the 4.5 outer screw. So that creates a V configuration for the screw, they lock into each other, so the back out is not there, plus the screw is threaded in the nail, so the chance of back out is absolutely minimal. So that's
There is a slight posterior tilt of the proximal fragment. If my entry was in the correct place,
then you can use holes in the screw to suture the rotator cuff back. Since in this case the greater trochanter was not severely broken, there is only one stitch, but you can use similar stitches for the lesser tuberosity and gradient. Simply you close the rotator cuff interval which you opened.
is avoided when you put in a nail.
The insertion of the rotator cuff is not at all
Start
affected.
mobilization early, impingement is much less. You don't need to worry too much about whether the phyllox plate is too proud or whether it is too deeply seated inside. This gives you a direct intramedullary placement of implant and very little implant on the surface. If you are careful technically, then there is no impingement. Now,
For any proximal humerus surgery, the greater and the lesser tuberosity sitting in place is a very, very important part. If that tuberosity escapes, then you have a problem as far as the stability is concerned. I'll just show you the instrumentation. It's a little big video, but since you asked for it, I'll show
There
it.
is a smaller guide wire and it has
not
got
that
a
big.
stopper over
Okay.
here, which will not allow it to open it for your guide. And then you can use it to manipulate anterior, posterior, whichever way. You don't need to protect your rotator cuff, and then you have a proximal.
That's the hollow mill.
So this is the hollow mill, which will go and will ream out the humeral head. It will core out the when this comes out, the guide wire should also. So next, we can directly use the nail. So that this is the proximal portion of the nail. It has got a bolt. So the nail comes in various sizes in the device. So this is how it locks.
Right and left nail are separate and they are
One
not,
is simply
it's
just
not uniside.
this side. There are reamers available, if they are available, which you can use to ream into the shaft, but you hardly, after you made your proximal entry, you can pass in the guide wire and manipulate 0.5, 5, 7.5 and 10 millimeter. This shows us how deep the nail is inside the humeral head. You generally would keep it about 5 millimeter deep. So 0 say 1, this is 2.5 and this one is 5. Sometimes put this, the calcar lock, it might so happen that the nail stays to. So now this goes and attaches to these two knobs and there is a single bolt which will lock it in place.
Right and left jig is the same one, you just turn it over. See to it that the side
a zero
marked is one which is facing you.
marker which tells us exactly where the tip of the screw is. It has got a 2.5 marker, it has got a 5 millimeter marker, and it has got a 10. It just tells us how deep it is. This should skirt the greater tuberosity, and it should ensure that it is just on the articular surface. This will ensure that the nail is sunken 5 millimeters. The threads in the normal interlock nail, it has to be threaded in. It threads in on both sides. That gives it pull-out strength. The nail will not allow this bolt to come out, and because it is threaded, it acts as a kind of angle lock also. There is no,
Sorry?
there is minimal toggle. The second one, which goes from posterior to anterior. That's okay?
So there are 3 locks on the greater tuberosity and 1 lock for the lesser tuberosity.
tuberosity.
The lesser tuberosity lock, you use only if the lesser tuberosity is intact.
Starting from the top.
Small and shattered and you use it, it will just break apart. So that time just use threads, don't use an IP lock in all cases.
So A, B and D are lateral to medial, C is anterior to posterior. This is the E lock. E lock is the one which is at the calcar. So this is not a locked hole, this is a normal 2 locks, 1 and 2. Okay, they are in different planes, so they will provide rotational stability to your nail. Small opening on this in this area. In the screw itself there is a small opening. This is for the screw device to go in. The screw device locks this bolt in place, and it prevents the backing out by its V action. So you got a wider piece of angle goes posteriorly, so that there is a small offset here. It is not exactly in the center. This offset goes where our screw is going to go. Okay. So now where this offset is, there is a marking also, which tells us where the screw is going to finally be seated inside. If this is pointing front, then your lock will go in the front. If this is pointing in this direction, lock will go anteriorly. If you are pointing in this direction, lock will go posteriorly. Sleeve for the lock. So it just goes on the top, and it has got a toggle. Okay, now remember where you put in it, and in that same direction you tilt it. So if you put it anteriorly, you tilt it anteriorly. If you put it posteriorly, tilt it posteriorly. If you tilt it too much, it will come out. So you just have to make a small tilt here. Okay, and then there is the sleeve. This is the sleeve for the screw. This is the sleeve for the drill. Now it goes inside. You have to press these two ends together and then push it in place and leave it, so that now it locks in position. Then you use a drill bit for the 3.5 screw and just drill it all the way. If the thick bone, you drill it subchondral. If it is a thin bone, you can drill it halfway. It's a self-tapping screw, so it will go in on its own. Tuck. See that? It will go through the sleeve and it will lock it in place. That anterior jig is to be used if you are using the anterior-posterior lesser tuberosity screw, and the other use of the anterior-posterior jig, guide wire.
So you can use this to know if your calcar screw is going exactly where it is. It's like a projection for the AP view of the C-arm. So your E-lock, which is the calcar lock, you can just see whether it is at the proper seated depth before putting the screw using this jig, but then you have to put that jig separately.
One in this oblique direction and the second one in this oblique direction. This is standard. It is very broad. This is 6.5. Sometimes in cortical bone, you may not be able to push this inside if the bone is thick, and that will drill only the lateral wall. So it will drill for this conical part. It will only drill the lateral wall. The stopper will not allow it to go beyond a particular distance, and this distance will match with what is there. Section guide, which you can use from the proximal humeral. So this distal part will guide where your wire is going to go.
This is a device for humeral shaft reduction. So I haven't talked about the shaft nail because we were not mandated to do that. So that's for the proximal humerus nail. Any questions, any doubts, anything you want clarified? I'm here for questions.
If there is a combination of the GT,
काय करू? Dr. Sharad's question was if there is a combination of the GT. If the GT is separated apart and it is comminuted, first thing is you have to use your ethibond stitch or fiber wire stitch to get it back together in place, and you put it in the normal anatomic position where you expect it to be. So you hold it there. If it is not sitting in place, use your sutures to tie it in place. And then you pass in your nail. Your reduction is done. The humeral head is impaled to the glenoid, so now it is in place. You reduce your GT on top of it. See to it that the articular surface is slightly above the level of the GT. That is your standard criteria for reduction. Then you pass in your nail, and through the GT you have 3 locks. So they will go and impale whatever big fragments are there. If it goes through the comminuted area, it goes through the comminuted area. But since you have already tied a stitch, you can take multiple other stitches and tie the entire fragments into one mass. See that they are not dissected out of the soft tissue. Otherwise, you will have a fragmentary GT.
but you showed one suture going through the screw head. So when you are using screw in screw, does that?
No, it doesn't come. That screw in screw and the threading for the sutures are separate. The threading, there are four holes from which you can put in the threads, so you can go in any of the 4. Plus, if the threads are too deep in or the holes are too deep, you can tie one thread to the other thread, so as to get it entirely encased.
Thank you, Harshad, for a very elegant demonstration of a very new technique, which I think interlocking nail for the proximal humerus is just being introduced in the last year or two in India and still has not gained popularity. I open the presentation to the audiences across the country. We would be glad if you have any questions to answer them. Let me start the ball rolling by asking Harshad, which is the ideal fracture to treat? Is a 3-part or a 4-part proximal humerus displaced fracture a good fracture to treat with an interlocking nail?
So if you are doing this for the first time, you are trying to learn, then I would suggest you start with either a 2-part or a 3-part fracture. People have used this for a 4-part fracture also. Definitely your first case should not be a head split or a dislocated humerus. All these cases are not to be dealt with a nail. There you use your standard Philos plate. So to answer your question, a 3-part or a 2-part fracture should be your first 4 to 5 cases where you are doing this surgery.
Question from Navi Mumbai, Dr. Sanjay Dhar, please go ahead.
Hi, good morning. Thank you very much for allowing us to be part of this. So excellent surgery by Harshad. Just few questions, like you partially answered already. In a 3-part fracture like this, what advantage did it give to you over a normal Philos plate? You could have done it. The fracture was uniting.
Yes.
It was already
Yes.
2 weeks. Why
Yes.
would you try to disturb it?
Yes. So it's a very good question. I would try to disturb it because the fracture is not well reduced. Though it is healing, it is not well reduced. The head was valgus impacted. The greater tuberosity was higher than the level of the articular surface. Such patients, if you try and heal in that position, you mobilize, the tuberosity will impinge on the acromion and patient will have restricted abduction.
No, my question is, what advantage?
I am coming to
give you over a
that.
Philos?
Yeah. So that first was why operate, and second is what is the advantage. So you look at the size of the incision, you look at the ease of surgery, and you look at the preservation of soft tissue around the fracture site. Now, of course, when you do a Philos, you get proper reduction, you get your plate in proper place, you will get equally good results. I have nothing against the Philos. But once I started doing the nail, I realized that though Philos is a surface implant, I had to make a lot of adjustments to see to it that my plate is neither too up nor too low. That has to be done where you're putting in a nail, and I'm opening from the anterolateral side. My tuberosity is right in front of me. It is an exact anatomic position. My elevation of the articular surface, I'll be seeing end on, and once I've impaled the articular surface to the glenoid, my humeral head stays stable, and through a small incision, minimally disturbing the rotator cuff, I can put my nail inside. Plus, even if there is a kind of osteoporotic bone where in a phyllos, the medial void, the void or in the metaphyseal area below the humeral head, you sometimes have to fill with an allograft or an autograft or bone substitute, because despite of having screws, the head can still collapse. Now, when you're doing a PFN in a proximal humerus, the advantage which we have said is it prevents medialization of the shaft, it prevents collapse. So similar advantage you have with the nail here. The nail by itself is blocking the humeral head from coming out laterally, or you have a collapse of the humeral head, which is sometimes seen with the phyllos. You have penetration of screws inside the joint. This will act as a blocking device to prevent that from happening. So the philosophy or the thought process by which you use a PFN, the same principle you can apply over here.
Can I have one more question?
Yes, please go ahead.
Yeah, so in a case, I think again you answered it partially initially. So when you have a combination of the greater tuberosity, while you are
Yes.
putting a nail from the center of the head, apex of the head, it
Yes.
tends to lateralize.
Yes.
Is there any trick what you could find out in your experience?
Yeah, so there are a few cases where I have penetrated that small bridge of bone and my nail has come laterally. So the trick is to know that this can happen and get adequate valgus of the humeral head and keep a bridge of bone between the two. If it breaks, then your chance of the nail migrating laterally between the trochanter and the fractured fragment becomes high. Here you have to consciously push it medially. But the advantage is, since you're seeing the entry point end on, unlike in a PFN where it is more close, here everything is visually confirmed. You can do a proper reaming and push the nail medially. You can put in blocking K-wires also. On the lateral side, you can put in K-wires vertically or parallel to the nail so as to block it from coming on the lateral side. And that's the way you can try and avoid the nail coming laterally.
Right. Thank you. Any other questions from the audience here?
So one question.
Yes, please go
I
ahead.
am talking from Nagpur.
Yeah.
Good morning. It was a very good demonstration. I want to ask if at all, due to some reason, we have to remove this implant.
Yes.
How easy or how difficult it is?
It is not difficult at all. In fact, one case, even in the last month, I had to remove it because there was the nail was a little proud and it was causing an impingement on the rotator cuff. There was a technical problem in that issue. The patient was quite unhappy with the nail being proud and she was constantly having pain. So I had to remove it at the end of 4 months. But in 4 months, I had enough callus, enough healing that I was confident enough to remove the nail without having to put anything else. So once you open your incision along the original incision, your rotator cuff muscle you split, it is sometimes difficult to identify the entry point because it is covered by fibrocartilaginous tissue. At that point of time, you have to use your Siam to judge where the apex of your nail is. So it's a judgment. You know you put your entry point at the highest point of the articular surface. So now you just have to decide whether it is more medial or more lateral. With the Siam, you will be able to judge it. So put in a wire there, check on your Siam, see you're in the right place, and then use a drill to make a small hole there, and then you will be able to see your implant very clearly. In the patient where I had to remove, since the nail was proud, it was quite visible for me, so I could take it out directly. But in other cases, you can use this. You just put in a K-wire at the apex, whether it is slightly medial or slightly lateral will depend, and on the Siam you can find that out and then take it out.
And
Thank you,
regarding the
Harshad.
interlock screws can also be removed easily.
Absolutely, they can be removed easily. They are covered by fibrous tissue, but again, you need to use a Siam. You may not be able to visualize it. You need to use a Siam to locate where they are. And on that basis, you will be able to take it out. It's not difficult. It is easier than what you would believe.
The risk of injury to the axillary nerve when trying to remove the
Yes,
screws?
the risk of injury to the axillary nerve is there because The E-lock, the lock which is the calcar lock, is the one where it can injure. But as I said, in order, before you put in the screw or remove it, use your artery to dissect out all soft tissue and use your artery to create a plane. The axillary nerve is more closer to the muscle than to the bone. It is not on the bone, it is more on the undersurface of the muscle. So if you dissect out soft tissue gently, you will be able to free the nerve. But of course, it's a blind procedure. There may be a possibility that there might be an injury to the axillary nerve. But since you are taking an anterolateral incision, even if the axillary nerve is injured by chance, you will lose only the anterior 1/3 of the deltoid. The posterior and the middle part of the deltoid is still intact. So abduction will be there. Maybe there will be a little bit of loss of forward flexion because the anterior portion of the deltoid is affected, but it is not affecting the overall movement because there are other flexors of the shoulder also.
Yeah. Any other questions from the house? Lovely. Thank you, Harshad, for a wonderful demonstration.
Thank you.
While we wait for Dr. Nemade to come up with his presentation. Yeah, one question.
Good morning,
Yeah.
Dr. Zaveri, sir.
Yes, good morning. Where are you?
I'm Dr. Hemant Jain from Jodhpur.
Yeah, good morning, Hemant. How are you?
So one more question I have is,
Bolo na.
are we able to easily do the distal lock through the zig, or we have to do it freehand sometimes?
No, never on the free hand. For proximal humerus fracture, the jig works very well. You don't have to do it freehand. The jig will 100% give you a lock all the time. The instrumentation is
About the
excellent.
distal lock, sir.
Yes, I'm talking about distal lock of proximal humerus nail. There is also the long humerus nail. This is a short nail for the proximal humerus. There is another nail for the shaft of the humerus where the locking is freehand.
Okay.
You are talking about the proximal humerus fracture, the locking is through the jig. All locks. But for the long humerus nail or the nail which is used for a humeral shaft fracture, then the distal locking is not through the jig, it is freehand.
Okay.
Sudhir, last question.
Yeah, there is a intramedullary device before this that just unique came.
Yeah.
I think this has got more option in fixing the fracture in multiple directions.
Yeah.
That implant is quite difficult to take it out.
Yeah, the just unique I think is now no longer used. I think it's completely failed.
No, Sanjay Desai is using it left.
No, he
right.
stopped using. Now he's putting wires in the proximal end humerus fracture.
Okay.
Okay.
All right. Thank you very much, Dr. Harshad. That was wonderful. We now move to the next presentation, and that is by Dr. Pradip Nemade, and he is going to show us a proximal humerus plate.
That all right. Good. मस्त देखा। वो भोगदा सब हील हो जाता है ना।
पूरा हिल हो जाता है। वो एकदम तुम अच्छा से मस्त ऐसा ब्लॉक ग्राफ निकलता है। निकल के पैटर्न में डाल देना।
नहीं तो टाटा का ग्राफ भर देना।
हाँ?
टाटा का ग्राफ भर देना।
हाँ, वो भी बस।
इसमें पूरा तेरा सॉफ्ट टिश्यू काफी अच्छा रहता है।
So,
फटाफट हिलेंगे।
let's discuss the proximal humerus fracture. So, this was a 30th male and he had this fracture dislocation of the proximal humerus, and probably it was tried to be relocated, and during relocation he had probably suffered a proximal humerus fracture, and at that point later he was presented to our hospital, and that was the CT scan done, and we can see that the head is lying anteriorly below the coracoid, and the GT is into the fracture gap there where the head was supposed to be, and the shaft is there, a fracture line that is running anterolaterally to posteromedial, and this is after the subtraction, and there we can see that the proximal humerus has a substantial bit of medial beak, very typical injury pattern, a spiral injury pattern there, and we can see the CT scan where we can see that the head chunk is pretty good enough for us to fix this fracture. There doesn't seem to be any glenoid or a coracoid fracture, and here we can see that the head is locked against the anteroinferior glenoid here, which kind of makes the reduction difficult especially if anyone is trying to reduce it without anesthesia. So message is that, we have to do it under anesthesia with proper relaxation. So, of course, I'm not going to speak about the position and the draping, which was very well covered by Dr. Argekar in the last talk. Just two salient features. I want to do it in a supine position without any attachments, just plain supine position. Try to see that the C-arm is coming from the opposite side, so the patient is positioned as central to the position table as possible, so that the side bar doesn't come into the way of visualization during C-arm. That is number one. Number two is I do not want any interscapular pad in between the two scapula. The reason being that it kinds of open up the shoulder, it kind of make the pectoralis tight, and we don't want that. Rather, we want it to be lax so that we get a good relaxation. The second and the third point that we want to do is that we do not want the elbow to fall into extension, because that will tighten the anterior deltoid, and that will kind of make the retraction of the deltoid more difficult. Again, it will tend to put the fracture in extension. We are trying to fix it. So it's very important that you put up kind of a support below the elbow, so that the elbow remains at the tummy or if not anterior to it, so that the anterior deltoid remain relaxed. So simple thing, simple table, patient central, elbow support. These are the three things that we need to take into account when we are positioning the patient. The incision is the line joining the coracoid, which is marked as a circle there, to the bicipital tendon. More often that we want to take the incision laterally, assuming that the deltoid goes like that, but the deltoid fibers are much more central, and the cephalic vein is exactly below this skin incision. If we follow this skin marking, a line that is joining the coracoid process till the bicep tendon, we cut the skin and subcutaneous tissue in line with the incision, and then we can buzz some of the bleeders, and we can just go deep down and we'll find the cephalic vein just below that. I would want to do it in the distal part of the incision, because there the muscles are well differentiated and loose areolar tissue is lax at that point, and the cephalic vein is center of the arm at that point. Proximally the course might be little variable. Sometimes the cephalic vein will dip inside the muscle, get lost there, but in the distal part of the incision it's really nicely popped out, and we'll see a fat streak there, and we can see that the cephalic vein is just below the skin marking. If we take the incision away from the skin marking, which as in commonly being done, then we have to raise the skin flap, and then to find the cephalic vein will be a problem. So now we dissect the cephalic vein. The loose areolar tissue needs to be cut on the top of the cephalic vein, and then the question comes is whether you want to take the cephalic vein laterally or medially. So it really doesn't matter much, but as a simplistic way or a reductive way of saying is that where there are the least tributaries that you need to buzz off, we need to take the cephalic vein in the opposite direction. So we see that the lateral tributaries are much more than the medial tributaries, so it is easier to go on the medial, dissect the cephalic vein on the medial side. So that's why we can try to take the vein laterally, and that is what is my preference, unless in certain cases where here I can find that it is easier to take medial because of the lateral tributaries. But more often than not, I will try to take it more laterally. That is how we are going to do a cephalic vein dissection, medial and lateral.
Internal memory, but
Okay.
पहले तो यही करते थे।
Saphenous.
So that is the cephalic vein. We go, and in this case, as you see, it was easier for me to take medially, so I had taken medially, but you can take whatever. I prefer to take it laterally. Okay. Now the second most point. Now once we do this, we can just we have to take care that we do not want to create any false plane in between the pectoralis and the deltoid. And now, if is more often than we are not, we must have assumed, we must have seen that this entire mass is one mass. Which sometimes become difficult to find a plane. The trick is to go on to the coracoid process. go on the top. So coracoid process is like a pillar, on the lateral side is deltoid, on the medial side is the pectoralis. So if you try to make the plane distally, then we make a false plane. So simple thing is to go proximally, palpate the coracoid process and just run your finger down and you will have in a perfect plane. And the plane is much more oblique than it is central. So that thing we need to observe when we are doing the exposure. So that's how we do. Now the second aspect of this surgery is, and the difficulty that we face is the deltoid retraction, because the deltoid is a very bulky muscle, and sometimes the anterior part is very bulky and it attaches onto the humerus on the anterior and lateral aspect. And what trick we need to do is we need to take your thumb there, take a thumb, and just run it along the lateral shaft, and you will feel a very cracking noise as you elevate the anterior insertion of the deltoid from the femur. Do not use any instrument. The best instrument is thumb, which create an obtuse angle there, and just run your finger. As you have seen, I am just run my finger all the way down till the mid shaft, and then that will release the anterior insertion of deltoid. It will make the field very, very clear for us to dissect. Then we run our finger below the pectoralis to find out the entire extent of the bursa, and there is sometimes the kind of hematoma in the bursa that we need to take care of. मेरे से आ रहा है? अच्छा. Then the bursa needs to be cleared off. And here we need to find out the exact margin of the coracoid process, the coracoacromial ligament, because if you don't clear the bursa, then this distinction becomes very blur, and then you will not be able to kind of expose it properly. So that's why the bursa needs to be cleared. Sometimes it is easy just to swipe off the bursa, but sometimes you really need to take it off. You keep on dissecting and this thing. So this is how we are going. So then we take off the clear of the fracture, and then now is the point when we are going to take the bites into the GT. So the issue is that the GT sometimes is dipping down way posterior superiorly. In this case, it is lucky that it was just there anteriorly, but sometimes the GT is dipping way posteriorly. So what we need to do, we want to follow this technique called as walking along the GT. So we take the suture in whatever is visible part, pull it, go beyond, release that, go beyond, release that, go beyond. So while doing that, we can reach all the way posterior to the GT. See, and what I am doing, I am taking a suture, retracting that suture, and go few millimeters beyond. Again, I will release that suture and go few millimeters beyond. Rather than pulling it with the instrument, we just pull it through the suture. This is called walking along the GT. And then now once we go in a very nice tendinous portion, we have a nice, good hold on to the GT like that. Like the reins of the horse, we got a nice hold on to the GT. Now the next step is to identify the bicep tendon. So I'm identifying the biceps tendon now. So these are another sutures on the posterior part of the GT. That was the LT. This is the posterior part of the GT. And then we identify the bicep tendon. So this is the bicep. At this point, the camera orientation is slightly changed because the cameraman has come from the opposite side. So now, just to reorient, this is the lateral side. This is the medial side. And then we can see that we have this bicep tendon over there, and we can see that the bicep tendon is going in the fracture side. Now in this case, the bicipital groove was intact, so I had tried to preserve the bicipital tendon. But more often than not, we need to sacrifice the bicep tendon and cut it. So we can see that the bicep tendon is with this fragment and the groove is intact, entire bicipital tendon is intact. So I thought I should give it a try to preserve the bicep tendon than cutting it. So as I talked yesterday, the main reason, one of the main reason why this fracture become difficult to reduce is because of the nodes that get formed because of the facial continuity of the supraspinatus and the subscapularis. So that's why releasing this rotator interval is a key. So once you find the deltoid, the bicipital tendon, it is easier to release the rotator interval. So what I am doing now, I have released the rotator interval and separated the GT and LT. Now once you have separated the GT and LT, what we can see here, 1 minute, this is extremely important how to reduce it, because otherwise one would want to do a subscap tenotomy, but that is not required. So I'll stop here, 1 minute. Yeah, this is the picture that we want to see, that this is where we can see the glenoid. This is the glenoid and this is the head, and we can see that gap that is there in between. So our instrument, we need to find the angle between that glenoid and the humeral head, the cartilaginous gap in that angle. Now one might want to pull this glenoid, put some KY, shank spin and maneuver it. It kind of lead to a lot of bone loss. The main way of going it is to go around the cartilage of the head and try to push it back, because that will take care of the rotation, and the jump distance clearance is easiest with this maneuver. And for that we need to go into the gap between the glenoid and the humerus that is visible most of the time superiorly, sometimes inferiorly in case the beak is not there. So my instrument is going there proximally, and see I am trying to go around that portion there and try to kind of pull this. This thing is giving pull, and I am trying to maneuver that gap from there into that gap over there. So you keep on pulling and keep on kind of reducing it, and at one point it will just 1 second it will just pop out. See, I'll just show again. Yeah. And then once the jump distance is cleared, it will just pop out, and we are around the cartilage, so the cancellous bone loss will not be there. And see, it just in 1 second it will pop up. Once it pops up, everything will fall in place. Then from there it is like a very simple proximal humerus surgery, because now we have the head is back into place, and we are able to even preserve the bicipital tendon, which is not a case in every case. Means if you are having issue, there is no point in kind of sacrificing the bicep tendon. So once that is in place, so that is the bicipital groove. I have tried to relocate the bicipital tendon into the bicipital groove there, and then I would want few sutures to pass to kind of reconstitute the bicipital tunnel. So this is how the bicipital tunnel is reconstituted, and now the bicep tendon is going to remain with that head fragment there. So these are the few stitches just to kind of reconstitute the bicep pulley, and now the tendon is going to remain stable once the bicipital pulley is being reconstituted. Okay, so that is how the bicep. Now we have a head fragment, a GT fragment, and the shaft. Now next thing is to reduce the head and the GT. And now as you see, we can release some part of the pectoralis major. It does not cause much of a problem if you stay very, very lateral to it. And now we can see everything is falling in place. We can see nice 2 fracture lines there, gap there, and then we can just try to reduce it directly with the clamp. And I'm reducing it with the clamp. And that is how the reduction goes. And then we can check with the C-arm that moti everything is falling in place. This is workable position from where we can start our reduction and further this thing. We can fix it with 2K wires. These 2K wires will start from the bicipital groove, and one go inferiorly and one go proximally, and you can see that the GT is falling posteriorly, and seeing as if it is in the crater. One might see, oh, why the GT is down when the supraspinatus is up. It is because the GT is not down, it is falling posteriorly, and we need to get it back in place. But yes, this is the position from where we can start. Okay, so this is fixed, and now I'm trying to position the GT into the crater, the hillside part of it, and with that suture trying to maneuver it into place. And you see the GT is much more posterior than it appears. It goes, the infraspinatus is a very strong muscle. We are under the impression that the supraspinatus is pulling. No, supraspinatus is weaker muscle. More stronger muscle is the infraspinatus, which pull it posteriorly. And then that GT is being put back in place, and then we can try to see how it sits. And now it is sitting like that. Okay, but you can still see that the GT is still dipping down, and that is because of the loss in the crater. Now what I am trying to do is elevate and align the lateral aspect of the GT so that it kind of mobilizes and pull back into the crater. So I am trying to reduce it. It is still falling in the crater, and now I am lifting it with the artery, you know, and getting it aligned and holding it with the suture and try to see to it that it is staying in place. Now I have just put that K-wire, with that K-wire also lifted up and trying to go there. So now we can see that the GT, the roof is kind of maintained now, and we can see a normal looking proximal humerus. The whatever soft tissue is now being put back in place, and we can even further try to reduce all these things, whatever kind of displacement there. And then we can just simply tie everything with the suture, just tie everything, so that now everything is going to fall and get buttressed below the plate. And this is what is our picture before we are going to put a plate. So mota-moti looking, the humerus is looking nice, this is looking, there might be some small fracture gap there because of might be small rotation, but yes, this is a position where we can try and put the plate and do further things with the plate. And that's how the just increase the playback speed here slightly. Okay. Yes, so that's where we are. Yeah. So what we can do is we can, right before putting the plate, we can take these sutures in the plate, because later on passing this suture in the plate once the plate is fixed becomes very difficult. So you can take a fiber wire sutures and lightly tie it into the plate before you kind of put it onto the bone, and that is how the plate is secured and keep small tags, and that's how we put it there. And it should, and since why K-wire is there, it's not going to go further proximal. So we fix the plate, and at all level we try to fix it with K-wires and do 10 to 15 degree external rotation, and we plate that. So the first screw which we put is always if you see this screw, this is a canceller screw. Now this is why this is a simple canceller screw is, more often than not the head may fall like that because the plate will stay proud. So we want to pull entire proximal part of the plate. That's why the simple screw go there, the plate sits flush there. That's why this should be the canceller screw, preferably a solid screw, which those people do not give. So in this case I have put a cannulated screw, but the solid screw gives very good hold to kind of compress. And the one that is put, then I am very sure that my plate is sitting nicely and I am not going to get plate related impingement later. And so that is one. Then we put a distal screw, that is a unicortical screw. So now this is the screw which is a unicortical screw, or maybe locking screw. Now why this screw? Because then I can remove the plate fixing K-wire, rotate my humerus in either direction and check that everything is sitting nicely. We are not violating the other cortex in case we have to revise that screw. So that's why a simple unicortical screw, just to put the plate, check it. And then we put, once our final position is okay, we try to put another screw. Now in this case I was worried little bit about that gap, so I try to put another partially threaded screw to kind of compress it for whatever it's worth. And then once the position was okay, we try to fix the screws there. Just go forward with this part. This is just a screw part, and this is the it. And this was workable. And then the suturing of the GT. So This was the picture here. Now look at this picture just before that. We can see what is happening here. This is on AP it was looking good, right? But in lateral, not so good. Means it's not bad, but we can see that it is kind of falling there. There's too much flexion there. So what we can do, since we have put a simple screw there, we can remove that screw and kind of put and remove that screw here, and with the bone holding try to kind of realign it, and now it is looking much more better than what it was before. And this was later packed, and then we have completed the further fixation. So this is at the end of the fixation, but we can see the GT is still not good, so we have to tie it off. So we clamped it, and then all the sutures we kind of in the clamped position we tie, and entire GT and LT and all the these things are tied in that position. So this is at the end of the tying, and then we tie the rotator interval also is closed, and then we close the skin and subcutaneous tissue in the way it was kind of open, and that was the picture at the end of the post-op. We can see that the GT is sitting nicely there, and since it is locking screw, they are like kind of being held there. The posterior part is also kind of sitting there, and we are getting nice picture over there, and that's the post-op X-ray of this patient. Thank you so much.
Pradip, what is your post-op protocol?
So the post-op protocol of this patient is gravity eliminated range of motion. So I do not put them in the universal shoulder immobilizer. I put them in an elbow pouch because that the patient kind of relax little bit, and with the pouch they can do mobilization. Now first 3 weeks extremely important in terms of range of motion. We do not want to do this. We do not want to achieve the range of motion like this in first 3 weeks. What we need to do is just achieve the external rotation. Because to reach here, we need the anteroinferior capsule to be stretched. However, reaching here in first 3 weeks is very difficult because of post-op pain, lot of activity going there. Reaching here is not a problem, all the structure are getting laxed here. Only structure that is getting tightened here is the anteroinferior capsule. And the very easy way to stretch the anteroinferior capsule is external rotation. So I will just try and do external rotation in erected position, which is very simple for the patient to do. So first 3 weeks only external rotation, and whatever movement they can do with the elbow pouch just to prevent adhesion like that. So only 2 things for the patient: do gravity eliminated range of motion as much as possible and do external rotation. So this they can do by even holding a doorknob and turning themselves like this. Very easy exercise. And once that is achieved, once we have got, let's say 60 degree, 70 degree external rotation, final result at the 6th week it is there. We don't need to worry about this.
Fantastic. We open the presentation to the house. Any questions here from Bombay on this wonderful demonstration? Yes, Satish.
You said something about, you said you would run your thumb down the shaft of the humerus to erase the anterior deltoid.
Yeah.
Why do you need to erase that? If at all you need the lateral deltoid for the plate, why anterior?
No, the lateral deltoid is not a problem. It is the anterior deltoid that is the problem, because see, these are anterior fibers from here. If you are retracting, we are not retracting the lateral fibers. The retraction of the deltoid, the anterior fiber which are coming from the clavicle to the anterior aspect of the humerus. These are the fibers which are going to come in the way of retraction. The lateral fiber are here lax.
No, the lateral insertion comes in the way of your plate, so you need to erase a
You
little.
do not want it for the plate.
Yeah.
Plate is anyway much more proximal to the deltoid insertion. For the ease of surgery, we need it. Now one might argue that I want to abduct and that will relax the deltoid. No, it doesn't relax the deltoid. In fact, the anterior fiber become further taut in case you abduct. Okay? And you may extend it, it can become even tight, because that's where the struggle starts. So for the ease of surgery, you need to see proximal humerus right in front of you. Like that. The moment you elevate, the deltoid insertion is V-shaped. Like this. So the lateral most fibers are actually distal most. The anterior fiber, so if you run down your finger, it very nicely, gracefully get elevated and fall back in place. No patient ever will have any time later decrease. They heal beautifully. And it is with the periosteal attachment. So that's why you are not supposed to use any instrument or cautery. Just take a thumb, run it down. Now assume this is the lateral aspect of the deltoid or humerus, and your deltoid fibers are inserted at a very acute angle. When you put your thumb, here it creates obtuse angle and the fiber become like this and get elevated just like that. And just with the thumb, it's so cracking noise, so gracefully elevated, we don't need to use any instruments.
Right, any questions from across India?
Hello.
Yeah, Jodhpur, please go on.
Dr. Pradip, good morning. Hello, Dr. Harshad here.
Hello, sir.
I would like some tips from you in head split fractures. Especially, we get sometimes kernel plane fractures in the head. So, what will be your tips for them?
Okay. So the head split fracture, there are two ways of managing the head split. With your permission, can I show a small video? Yes. Yeah.
Please go ahead.
Yes. So I am just showing the head split fracture. Just a minute. So the philosophy of, if you see, if you kind of compare the head split fracture of the femur and the humerus, how they are different? Because the humerus, the femur, the acetabulum kind of contain the humerus, and it kind of automatically reduces the femur fracture, but that is not the case for the humerus fracture, because the glenoid is pretty kind of the shallow, and it doesn't give that kind of thing. Can you play this here? So look at this video. Now look at this video. If you kind of see this humerus in a cadaveric video, the humerus is an osteotendinous unit. The glenoid and the rotator cuff, the humerus and the rotator cuff is kind of forms the kind of acetabulum. But for that, we need to have the rotator, the tuberosities laterally, because that's how they will give you under tension. When the rotator cuff is under tension, it kind of automatically give that kind of buttress to reduce the head split fractures. Now, the traditional way of teaching, of reducing the head split fracture is you expose it, you do a subscap tenotomy, and kind of see it under vision, reduce it, and fix it with the articular level, and then put Herbert screw and fix it. But if you follow this philosophy, now I'll show you just one or two simple case. If you pull the tuberosity laterally and push the head medially, they get automatically reduced. Look at this head split fracture. Okay, this was the head split fracture. We pull the tuberosity laterally. This is the head split fracture. We pull the tuberosity laterally, and this is the K-wire in the head, and push it medially. Look at this K-wire here, just for the head, and then my mixture is pushing it medially. So pull the tuberosity laterally, push the head medially, and the entire fracture get reduced without even doing the subscap tenotomy or rotator interval release. Another fracture, valgus head split. Similar way, if you do it, pull the tuberosity laterally and push the head medially, it will get automatically reduced.
So there is no need for an interfragmentary screw.
If the plates are holding the fragments, you don't need to. If you feel that the plate screw are not holding that fragment properly, then you may add and fortify it with one or two interfragmentary screw, but they are not needed.
So there is a question, does that answer your question, Jodhpur?
Yeah, another case, see, look at this, we do not release anything.
This is an important tip we got, sir.
And look at this, I have not done any rotator interval release, nothing, and we can get a head split fracture perfect anatomical reduction by following a simple philosophy of converting the osteotendinous unit of glenoid into a structure that behaves like acetabulum.
So which head split fractures would you fix, and which head split fractures would you say that they should be replaced?
Okay, so we had a talk yesterday. So type 1, type 2, type 3 fractures can very well be fixed, number 1. Type 4 fracture also in young patients should be fixed. Only in elderly people where the fractures are like that, this is not fixed. So this cannot be fixed, they can be replaced. So to put it in a simplistic reductive manner, fixable fracture should be fixed, unfixable fracture should be replaced.
Yeah, Chennai, you have a question to ask?
So I want to ask in some sort of say immediately reduce the medial metavasal sleep. Should we work on reducing it like using a joystick or this is acceptable?
Your voice was big muffled. Can you clear?
Can you repeat the question, please?
Because I couldn't comprehend it.
The head, the medial metavasal sleep, the medial part of the head. So you need to work on reducing it or you can accept these reductions.
Okay, so we try to not mess up with the medial sleeve because that is the only place where we can have blood supply left in cases of fracture dislocation. But if you see that me releasing some part of pectoralis minor, then the upper part of that beak is even visible, which is good enough guide for you to put a clamp and assess your reduction. But we do not really want to go all around it, put a clamp all almost there and kind of denude and devascularize that area. Just enough for you to have able to put a clamp and assess the reduction. You do not want to go medially. So we want to work through the fracture site. If you want best results, we do not work around the fracture site, we work through the fracture site.
Right.
Hello.
You won't use any joystick to the varus or valgus the head. So you won't put some surgeons use a technique wherein we use a shank screw to move the joystick the head varus or valgus.
Very rarely it is required. As I said, if you go into that angle between the glenoid and the proximal humerus, just jump off the head, everything falls back in place. You do not even require traction. Maybe little bit, just to kind of a clamp, some prying maneuver to get that few millimeters of crisscross into place. Otherwise, we do not require traction also.
Yeah, Ahmedabad, please go on.
Very good presentation. I have.
Sir, there is an echo. We can't hear you very well.
स्पीकर बंद कर क्या इधर जो मेन स्पीकर है बंद करेगा तो इको नहीं होगा
Hello. Javeri, good morning. Rajnish from Gwalior.
Hello, sir.
Javeri sir, your voice is very high, so we are not be here to clear.
सही से तो बोल ही नहीं रहे. Anyway, ग्वालियर वाला बोलो. You have a question from Gwalior?
Yes sir, definitely question will come very soon.
Okay, Ahmedabad, please ask the question.
Why should we sacrifice this bicep tendon? Usually we do tenodesis below the biceps notch. It preserves the full function of the bicep.
Yeah, so the thing is that yes, we sometimes the split in of the bicep tendon is right to the bicipital groove. Now in this time, to reduce the two tuberosity together in a way to form the bicipital groove, put the bicep tendon into that groove and switch it, at times become difficult. See, our prime aim of the surgery is to reduce the proximal humerus because that is what is going to give the disability to the patient. But in case, like in this case, if the bicipital groove is with one of the fragment completely, then we should try your best to preserve the bicep tendon. Shall it comes in your way of reduction, maintenance of reduction, then there is no point in preserving that. You can tenotomize it and do a soft tissue or a hard tenodesis in the groove or with the pectoralis major, which is a very well described procedure. For arthroscopy, we do it day in day out. That is not a problem. But if it is preserved, we must preserve it.
Yes.
So one question from Nagpur.
Yes, please Nagpur, and then we go to Jodhpur for the next question.
Okay, Pradip sir, some of us, we feel that the first screw which we put is the calcar screw, since it maintains the valgus as well as its position is very important. But you told that you put the uppermost screw first. So please, can you clarify on that key, which helps more?
Definitely, that's a very good question as to what sequence of the screw we should put in the proximal humerus fractures. Now, if you see the calcar screw is an interfragmentary screw, because you know the fracture is almost always oblique. The calcar screw starts from the intact cortex of the lateral fragment of the distal fragment, and then it goes into the calcar. So, in case the reduction is perfect, you don't want to do anything to the reduction, then yes, calcar screw putting first is not a problem. But sometimes we still need to do some maneuverability even after putting the plate. In those positions, calcar screw will prevent that kind of maneuverability. So in case you fix proximally first, distally first, little bit of tweaking of reduction in the middle part is still possible if you have followed this proximal and distal kind of the fixation. But yes, if you think that yes, reduction is perfect, plate position is perfect, plate is hugging the thing perfect, no problem, we can put the calcar first, no problem at all. So to answer the question, in case you aim to maneuver the reduction even after putting the plate slightly, then you can put proximal and distal first. If everything is very good, fantastic, then yes, any screw first is not a problem.
Okay, thank you, sir.
Jodhpur, you had a question?
Dr. Devendra ji here. Your primary bone grafting indication in case of medial hinge.
Medial comminution. Medial comminution. If there is a medial comminution, that is, if you do not get a medial cortico-cortical contact, then we need to put a bone graft, and that bone graft I would like to have cancellous block than the fibula. Because I want to buttress it against the cancellous bones of proximal humerus. I do not want a hard bone or a hard metal or like a cage to buttress against the soft cancellous bone. So I would always prefer a Nichols graft or a kind of a denuded tricortical iliac crest graft rather than putting a fibula. The primary indication is medial, cortico-cortical contact is not there. In case we have big white, does not matter. If you have medial and peripheral contact is good, and plate is there laterally, we do not want to bone graft the white, neither I want to put it with a foreign material like Genex or anything that causes much harm than the good. I think the white in cancellous bone does not matter. Two things has to be important. One is the head in the humerus, the hole of the screw in the humerus, and medial cortico-cortical contact. Of course, the reduction needs to be good.
That's wonderful. Thank you very much, Pradip, for a fantastic presentation, and I think it's answered most of your questions. But anyway, Pradip is around through the day, and proximal humerus fracture is such an emotive fracture that everybody has questions. Bhopal, do you have a question? If so, unmute yourself. Yeah. Please go ahead, sirs. Dr. Gupta, please go ahead. Your voice is not, we can't hear you.
Can I ask a question from Ahmedabad?
Yes, please go ahead.
Please go ahead. Ahmedabad, please go ahead.
भोपाल का भी आ गया आवाज.
आवाज आ गया, भोपाल का आवाज आ गया.
Yes, can you hear me?
Yes, now we can hear you. Gupta ji, please go ahead.
Sir, as he said, he is doing the surgery in supine position.
Yes.
Some people does it in propped up position. Which is the best position?
So it's surgeon preference. Of course, it is a well given fact that whatever your comfortable position, you should do it. My kind of way of doing it in proximal in supine position is by ease of Siam. Anesthetists are very happy in supine position, and I can maneuver it in the way I want. With the propped up position, in putting the Siam in that awkward position is problematic. Anesthesia again, the need of a special kind of the table for that. All those things I think is a issue for me, and by far I have never faced any problem because of supine position. I like the supine position best.
Yeah, Ahmedabad, please go on.
Dr. Praveen Saga from Ahmedabad. Very nice presentation. Congratulations, first of all.
Thank you.
Just about the bone graft, you mentioned about your preference for a tricortical piece bone graft, but in case we have to use
like a space filler kind of cancerous bone graft, at what time do you recommend that we put the bone graft? Like when you are doing a provisional fixation with wires, or through a little window after you've done your final fixation? What do you normally do?
So as I said, for a wide filler cancerous bone graft, I really do not advocate, because the failure of proximal humerus fracture are most of the time mechanical and not biological. So cancerous graft are not a solution to our foolproofing our failure of fixation. It is the structural graft that is required. Now the structural graft, that's why I do not use just a wide filler cancerous graft, never I ever use it. But in case somebody wants to use it, they can do it. If the window is available, you can do it even after the fixation. But if the window is not available, if you feel that the window will be closed after putting the plate, then you can put it after the provisional K-wire fixation.
Right. Does that answer your question, sir?
So, the thing is, very frequently, like even in this particular case, the final radiological picture that we saw was a bit different from the reduction we got from K-wire, and that is frequently the case with proximal humerus, because we get almost anatomical alignment with wires, but when you put the plate, the screws and all, it will always shift a little bit. So putting the graft, especially the tricortical graft, is sometimes challenging as to when to put it, because when it's provisional, sometimes the graft isn't stable enough, like when before we put the wires. And I have kind of struggled with that sequence many times. That's why I asked the question.
Okay.
I think that's a fair comment. Thank you. I think Pradip has answered that question. Thank you, Pradip. I think we'll move on. We are running a little late now. And I invite Dr. Harshad Argekar to speak on managing lateral and clavicle fractures.
So I'm going to talk on fracture of the lateral end of clavicle, and we can extrapolate the same philosophy to the AC joint disruption also. There are a few slides of introduction, and then finally I'll go on to the video. So get this full screen, please. So the lateral end clavicle fractures, or the distal 1/3 lateral clavicle fractures, are significantly displaced only if the coracoclavicular ligament is ruptured. So this surgery for the lateral end clavicle as well as the disrupted AC joint should be directed at reforming the coracoclavicular ligament or reforming the force of the coracoclavicular ligament. It should not be directed to the AC joint itself. The AC joint by itself does not contribute to that stability as much as the coracoclavicular ligament, whether it is a fracture of the lateral end of clavicle or whether it is the AC joint disruption. So in any case where you are suspecting the coracoclavicular ligament rupture are the ones which require surgery. All other cases can be absolutely managed without any kind of surgical intervention. A disrupted AC joint, which is grade 1, will not give rise to any functional disability apart from a little bit of cosmetic issues, and they can be very well conserved. Just manage the patient with a sling for a few days. Once the pain is reduced, you can allow mobilization. So such fractures where you see a small flake of bone on the inferior side, this is where the coracoclavicular ligament is attached and the entire thing is kind of avulsed out because the medial end of the clavicle has gone up and the lateral end is held in position at the AC joint. So this bone will always jut out under the skin, and this will never come down whatever you do unless and until you get this small flake of bone healed to the medial side. You take proper cephalad views to see the amount of displacement, the stress views if you require to unmask any AC joint disruptions which may not be apparent when you are doing non-stress views. K-wires across any joint is always a no-no because K-wires can break and they can cause problems if they migrate at vital areas and can give rise to a lot of problems. You never fuse the AC joint also because the AC joint is an essential mobile joint when you're doing full abduction. The scapula and the clavicle rotate about 15 to 20 degrees at abduction, and therefore it should never be fused. You can excise it, but then you need to reconstruct the medial, the non-excised part. If you treat lateral end clavicle displaced fractures non-operatively, there is a higher rate of non-union, almost 33%, and they take a long time to heal, and they will always leave a cosmetic bump. In operative treatment of lateral end of clavicle, if you operate them well, you will always get 100% healing. The meta-analysis, which went through all the various methods of fixation of lateral end of clavicle, the least complications are, of course, with non-surgical management, but on the surgical side, the least complications will occur if you use non-implant fixation for the lateral end, and that is using the coracoclavicular stabilization technique. Previously, we used to use a BOS screw, which was from the clavicle to the coracoid, but that again makes this construct very rigid, and the mobility or the flexibility of the clavicle and the coracoid is lost. The BOS screw used to come out, or at sometimes it breaks or causes fracture of the coracoid or the clavicle. So rigid stabilization of coracoclavicular joint is not to be done. What needs to be done is a flexible stabilization. Now, hook plate, I am absolutely against this device. Don't use it for any other fractures. I feel it is unphysiologic and it causes more problems than gives solution. All hook plates have to be at some point of time removed. We all know the complications with that. I will not go into details. We have now newer plates which have multiple locks on the small lateral fragment. But again, these plates are subcutaneous. Not all patients are comfortable with them and they have to be removed. And the newer plates, if you see, not just the locking screws, they also have a mechanism by which they will use a suture, pushing the plate down on the coracoid. So ultimately, what works is this part, this central part, and not the entire plate. So the plate becomes really superfluous, and the technique of fixation should be directed only towards stabilizing the coracoclavicular area or kind of reforming the coracoclavicular ligament. So that's what I'm going to show on these two videos. First video is going to be under coracoid through clavicle fixation, where I take a anchor below the coracoid process and through the clavicle. And the second technique is using the tight rope which goes through the coracoid and through the clavicle. So that's the displaced fracture. You give B chair position like you would do for a proximal end of humerus. You are operating from the shoulder end, that's the skin marking. And what I used to use initially is Ethibond and Merceline tape. Now I have shifted to fiber tape and fiber wires. But Merceline tape I find is really strong. It's an excellent suture material. However, nowadays Merceline tape is less and less available. Johnson is not manufacturing Merceline tape. They are more into now fiber wires, which are fiber tapes, which are much more lucrative and more expensive. So they are marketing that. And another important device which I use for this is this mixer. Nowadays I've shifted from mixer to this Satinsky's clamp, which is a double angle clamp, which gives me a better hooking angle on the inferior surface of the coracoid, and these are the fiber tapes and fiber wires. Straight needle with a nylon loop helps me to retrieve the sutures. I'll show you how that is done in the surgery. The only scary or vital structure in this area is the axillary artery, but if you note its distance from the coracoid, it is quite a long distance, not hugging the coracoid like what we are led to believe. Especially when you adduct the arm, the axillary artery is absolutely away from the coracoid. It's only an extreme abduction that it comes close to the coracoid. So anyway, this surgery is done in an adducted position. There is no need to abduct the arm. So the axillary artery is nowhere close to the coracoid. So this is under the clavicle and under the coracoid and through the clavicle. That's the fracture. The coracoclavicular ligament is disrupted here. That's why the surgery, that's the fracture zone. That's the AC joint, that's the acromion, the spine of scapula, and the coracoid. So this I have shown with a horizontal incision. You can take a vertical incision also. Your incision is on the anterior side of the clavicle. You are going in the interval between the clavicle and the coracoid. Don't take it directly on the clavicle, take it slightly anterior to it. Then what you expose is the deltoid. You subperiosteally erase the deltoid from the anterior surface of the clavicle and raise it down as a flap. Only erase as much as is required to see the coracoid. To sharp dissection, push the deltoid fibers downwards. The superior surface of the clavicle, you can do an extra periosteal dissection. Keep the periosteum intact on the superior surface of the clavicle. You directly are on the fracture. What you can see inside is the fracture line. That's the fracture line. Blunt dissect it anteriorly so as to identify the interval between the coracoid and the clavicle. That's blunt dissection anteriorly. What I feel is the coracoid in the depth. It's not very deep, it's about 1.5 centimeters or 2 centimeters below the clavicle. Whatever deltoid minimum you need to remove or erase off, you can do that. You will resuture everything back. Now that's the window on the lateral side of the coracoid. It's dissected bluntly. Just palpate the superior surface of the coracoid and go medially and go laterally, touching the bone. You can use an artery forceps to do that, or you can use your finger and make a plane there. That's bluntly dissected. As the arm is adducted, the artery is nowhere near your dissection. So this is the medial end of the clavicle. Now I have put a periosteum below it so as to act as a stopper for my drill bit. This is a 3.2 drill bit which we use for our 4.5 screws. Is going to create a tunnel on the medial fragment of the fracture. That periosteum is just to ensure that my drill bit doesn't over penetrate. You can use various methods to prevent your drill bit from going through and through beyond the second cortex. Similar drill on the lateral side. You can use a drill bit with a stopper or a measured drill bit and just drill about 14 to 16 millimeters. That should go from the dorsal to the ventral cortex of the clavicle. This is just to ensure that I've completely made the hole on both sides. I'll be using this linen loop with a straight needle later on, and this is just to ensure that I've gone through and through. That's the Satinsky's clamp. It's used in cardiothoracic surgery. It's a vascular clamp, but we have kind of borrowed it for our coracoid hook. The mixer also you can use, but mixer is a single angle, so sometimes it's difficult to retrieve the suture material. With a mixer it is easy. So from the lateral side, you can pass it on the medial side, hugging bone, or you can use from the medial window to the lateral window. So that's the end of the clamp. You can see it very clearly. This with the mixer you need to make it a little more angled. With the Satinsky's you can put it more in a lesser degree of an angle. That's the fiber wire going from lateral to medial side under the coracoid. And we create a sling. You can use either double wire or double fiber wire, or you can use a single fiber wire also. So this will create a sling under the coracoid. It mimics mimics the direction of the coracoclavicular ligament, so it is kind of reinforcing the coracoclavicular ligament. That's the Marceline tape. Why use two suture materials? Why Marceline tape and a fiber wire? Both of them, why not just one? The Marceline tape is really strong. It gives an extreme strength to your reconstruction, but it has very poor knotting properties. You can't really knot a Marceline tape and tighten it like you would do for a thread. So the fiber wire is used for its knotting properties. It will give me a good knot hold, so the first tightening is my fiber wire, and the Marceline tape is tightened second so as to get better strength. So this is how I retrieve the Marceline tape and fiber wire. The straight needle with my thread is pushed. The thread is retrieved below. And then I simply railroad it, the Marceline tape and the fiber wire. And the 3.2 drill hole which I have made is enough diameter to get both of these out. Even double folded, they come out very easily. Just ensure that the thread doesn't break. Just use a thick thread, and that's the Marceline tape which is coming out along with the fiber wire from under the medial side of the clavicle to above on the medial side of the clavicle. Now another thing which I use in this technique is I don't tie the knot on the dorsal surface of the clavicle. I tie a knot under the lateral end of the clavicle. So I will now push the medial retrieved suture under the lateral end of the clavicle. I'll show you how I do it. We do it by this reverse railroading. So first I will use the same technique which I use on the medial side, but rather than using the originals, the sutures, I will thread in another linen loop. So that's another linen loop through the first loop. So now I have a loop below, going from below upwards, from below the lateral clavicle to above the lateral clavicle. So that's the loop, and with this loop I will take that medially retrieved suture and then pull it so that it comes now below the lateral end of the clavicle. So it's the same end of the suture material which I am moving in two directions. Because the Marceline tape knot is thick, I don't want it impinging on the subcutaneous tissue and skin. So the knot is below the clavicle, so it's not felt by the patient at all. So that's retrieved both. So it's making a kind of 360-degree loop below the coracoid and across the fracture site. Now it's just a matter of first tightening the fiber wire, the fiber wire suture material. So that will give me the knotting strength. And since it's an oblique fracture, the fracture tends to shear off. That shear can be prevented by passing a vicryl thread like a circlage across the fracture. So this towel clip is reducing the fracture. There is enough space to go around the clavicle. So that's tying the fiber wire. It's a number 2 fiber wire. This is in a double loop, so it's number 2 done twice. So it has got good strength. Plus the Marceline tape will act as an additional stabilizer and additional strength to your fixation. Marceline tape knotting is not as good as the fiber wire, so you need to take 6 to 7 knots to prevent it from slipping out. It's a simple technique. You just need to identify medial and lateral end of the coracoid, easily go across it, hook your suture material. There is no implants used, no metallic implants, there is no question of removal. The scar, if you take a vertical scar, it is more cosmetic than a horizontal scar. The fracture absolutely stabilizes. Like I said, in this case, it's an oblique shear injury. So just one vicryl thread, this is an absorbable vicryl thread. If there is a small flake of bone, you can thread your vicryl to incorporate that flake of bone, and it will just pull it up under the clavicle and just knot, make a small knot there so that that oblique shear fracture is now neutralized. This fixation is strong enough to permit mobilization on day one. You can see interrupt, the entire thing is absolutely stable. Keep the patient in a sling for 24-48 hours till the pain is relieved. An elbow pouch is good enough, and then start underarm mobilization from day 1 or day 2. We don't allow abduction for about 15 to 20 days, that's about 3 weeks. After 3 weeks, all movements as far as range and strength is concerned is allowed, and heavy activities we don't allow for about 6 weeks, and then patient can resume all duties, all activities. I have been doing it for the last 15 years. I had a 15-year follow-up in one of my first patients. He had just come about 2 months ago, completely all right. You will see there is absolutely no sign of the fracture. The reduction is really good and the fixation is quite stable. Okay, that's the post-op picture. So if you don't want to go under the coracoid, or you feel a little scared going around the coracoid, you can go through the coracoid also. So that's the next video which I'll show you. That's this is done just about I think last year. We had used a tightrope. So now with the tightrope available, the procedure becomes even more easier. It's a similar type of fracture. There is a displaced lateral clavicle. There's a flake of bone inferiorly. There is a more than 100% displacement. So definitely requires fixation.
With a fracture of the lateral clavicle.
I'll skip the initial part because that is the draping and painting like in the previous one. But here I've taken a vertical incision.
More cosmetic, and here what we have planned was problem. It all done. Give me a mic. I can feel the coracoid completely. So give me a right angle. Now this is the fascia covering conjoint tendon. Conjoint tendon is below, but this is the fascia which is covering the coracoid. Now take another right angle and just put it here. This is the visualization. Sister, give me an artery. This is the coracoid. Then we go. Just peel off the fascia from the coracoid. The entire coracoid becomes exposed. This is a soft tissue bridge between the two. This is a portion of the deltoid itself. We can release it so as to see it properly complete. These are the coracoid. They are separated out, attached to this piece of bone and separated from.
You can actually see that flake of bone. You can see the coracoid ligaments attached there.
We will also try and suture this to each other. So now this flake of bone will heal to the medial coracoid or medial clavicle, and that will provide your long-term stability. Your short-term stability is here, then you just go on the coracoid and just find this window here. Okay, that's medial to the coracoid. If you have a mixture is a curved clamp, or you have a Satinsky's clamp, which is a double curved clamp. easily goes on the medial side.
This is just for demonstration for making the medial and lateral window. In this surgery, you don't require to go to these windows because you are going through the thoracoid.
This is going all around. I can feel it on the other side. From the medial side, I'll just pass here. And now you see that. This is it.
So that's the mixture which has come out from the lateral side.
If I have to pass one button system which you are going to use, it is already loaded on the handle. This is going to go inside from the...
That's a tight rope which you would use in an ACL reconstruction or a ligament reconstruction for the ankle. It has two endo buttons.
On the surface, superior surface.
One will go on the dorsal surface of the clavicle and the other one will go below the coracoid.
And it has to get compression. Now to pass this, we require two instruments. One is a guide wire and one is a cannulated drill which comes as a part of the set.
So here you require a C-arm.
My aim is to see to it that this medial end and my coracoid are in a straight line. So I'm just marking the area where I will be putting a drill. So my drill is going to be here. Okay, so because this is in straight line with my coracoid. Now I'll be passing my guide wire from here through the soft tissue into this one. I'm getting enough chunk of bone between my fracture end and where I'm passing I'm between the anterior and the posterior borders. Okay, I'm not going to go blindly. I just drill hole through the both cortices of the clavicle. So I see where my guide wire is coming out. There is no vital structure in between the two.
So this needs to be done with the help of a C-arm so as to ensure that you're going in the right plane.
That's where
Or you be very careful while drilling between the coracoid and the clavicle, don't be blind. So the guide wire goes from the clavicle into the coracoid, so that's the first shoot. And then I'm feeling the guide wire in my finger, ensuring that it is in the coracoid. So that's sitting on the superior surface.
I'm not fully penetrating the coracoid.
And then going through the coracoid.
I'm giving a resistance. That's it. Space.
So I can use kind of right angle retractor,
As a buffer.
use it reverse so as to kind of protect my soft tissues underneath it. And then on the guide wire, I'll be using the drill bit. So that acts as a protector, preventing my guide wire from migrating inside.
On the foot field.
Once I do the drill, the guide wire will come out along with the drill itself. And then you seat the endo button like you would do any other. It goes across, you check on the C-arm, and when you pull back, the button will flip. So this is less technically difficult than when you're passing the suture material. So that's just tightening it.
We just put the whole thing together.
And now the endo button is on the dorsal surface of the medial clavicle. Remember, there is nothing going across the fracture here. We're just pushing the medial clavicle down to align with the lateral fracture pattern. Again, I have used the vicryl thread here just to enhance my stabilization going across. Because it's an oblique plane fracture, you can just use a vicryl and get a tie so that the fracture in the AP plane gets aligned well.
In its place, that will give me a good AP alignment. You can use Ethibond, you can use fiber wire, you can use fiber tape. I'm using vicryl over here. Once the alignment is good, healing will take place. See that? Okay, now we'll check on C-arm and then we'll tighten this so as to. Okay, so we'll tighten this.
Okay, so those who are used to tightening the fiber wire with, you use an artery and go around and then really pull it tightly. That endo button really pushes the medial fragment down.
alternative.
The entire thing stabilizes absolutely
The endo button is moving.
rigidly.
See, now the endo button is not moving. It was moving initially. Now there is a good compression between the two. The endo button has stopped moving.
Can still tighten.
AP and superior inferior movement is minimal. That much movement will remain. It's not will make out.
So now when you use the artery and then
Fracture
tighten
is
it,
completely
it still
still
gets.
The coracoclavicular ligaments are also there. Final line. I'll give you a poster for that. So that's the coracoclavicular ligament. The plate of bone we have taken in the visceral sheath, so that is back in place. The coracoclavicular gap is completely gone away. The coracoid, the clavicle is aligned to the lateral end, the medial clavicle. There is hardly any or no anteroposterior movement. Superior inferior, again, because of final tightening, it is completely stable. If you feel it is unstable, you can pass in a wire from the acromion and going across, but here it is absolutely not necessary. This reconstruction is enough. You can keep him in sling for about 2-3 weeks and then start mobilizing him as his comfort is increased. So that's the deltoid which we had initially split. Just take the two together, suture it, and then suture this portion of the deltoid back to the posterior soft tissue structure. So everything is closed and everything is subcutaneous. Once we close the skin incision, as you can make out because of vertical incision, it is cosmetic also.
So that's the post-op, if you can see. I'll show you again. That's the post-op. It's completely aligned to the lateral fragment. There is no fixation across the fracture site. The lateral fragment is held to the acromion with the AC joint. You're just pulling the medial fragment down and aligning it to the lateral fragment. Only thing across the fracture site is that vicarial cerclage. So these are some cases of the same. You can see post-op, you can hardly make out that there was a fracture. This was a displaced fracture. You can hardly make out anything. If you don't want to use either this tightrope, you can use a suture anchor also. It will give a similar kind of construct. Only with a suture anchor, the problem is you can use only one fiber wire. So the strength may be a little low, but that's the follow-up. This is about 3 months. It's completely stable, and patient is cosmetically happy. There is a skin, nothing there in the skin and subcute. You take a vertical incision, your scarring is also much better. Similarly for AC joint, the same principle applies for AC joint disruption. Pull the displaced clavicle using the coracoid, pull it down and align it to the lateral side. You can use additional fiber wires across the AC joint, but keep the fixation flexible so as to reduce it. In the AC joint, a type 3 you will reduce it to type 1, but that is okay. You don't need to make it absolutely zero. A little bit of displacement is acceptable because it's a flexible mobile fixation. In chronic cases, you need to use tendons. If it is more than 3-month dislocation, then just the fiber wire and Marcelline tape may not work, because that time you require to augment the biology, and in which case your palmaris longus or the hamstring tendon, the semi-T can be used. All right, thank you very much. So the first multi-lock which I showed you, can we get that? I didn't show you the post-op X-ray, I just showed you the intra-op. I'll just show that post-op once, and will be open for questions for this presentation. Multi-lock. Okay. I showed you the pre-op, and that's the post-op here. I told you my entry is not exactly in the apex. That's why the fracture fragment is tilted posteriorly. Where am I? See, it's tilted posteriorly because my entry was not at the apex. Ideally, my entry should have been here. When the entry is in the apex, then you are exactly in line with the medullary canal, and there is no tilt of the fragment. Here there is a tilt because my entry was a little off. Any questions on the lateral clavicle fixation?
Sir,
Yes. Yes, sure.
Jodhpur.
Yes, sir.
Sir, in the first video you showed, the
Yes.
questions here from all of us, we
Yes.
lost the sequence, how you pulled the sutures. Can you explain some from diagrammatic
Yeah, I know it was a little confusing and the video is edited so as to see, but if you really want to I'll just draw the diagram here.
इसके ऊपर focus.
Yeah, it will be helpful for us for diagrammatic.
उसका marker है. So can you see this board?
Zoom करना.
Yes, sir.
So what I will draw is the medial end of the clavicle. This is the fracture line. This is the lateral end of the clavicle. This is the AC joint. Okay? This is the AC joint. Here you have the coracoid here. This diagram you understood? This is the right side clavicle of the patient. Okay? So now I have passed my Marcelline tape and my fiber wire below. Okay?
Yes.
Now with a 3.2 drill bit, I have made two tunnels. One tunnel is here, one tunnel is here.
Okay, sir.
Okay? Now I will pass my straight needle with a linen loop. I pass it from here. The linen loop comes below the clavicle. Understood this? Now this portion I will loop here and pull it out.
Pull it out.
That you understood? So now the thread will be pulled out here.
One end of the tape is here. Got it.
One end of the tape is here, one end of the tape is still here. I have not extended it, it is here only. Okay? It's a long tape, I have just drawn a small one. Now, this same thing I will pass on this side.
Yes, sir.
Now I have a loop here. Now in this loop, I will not put this end of the Marcelline tape. If I put it, I can pull it out and both will come above and then I can tie a knot here.
Yes, sir.
But if I tie a knot here, the knot will be subcutaneous and the Marcelline tape knot is very thick, it will cause irritation. Okay? So now once I have passed this one below the clavicle, I'll use another linen loop and I will use it in this and pull the linen loop up. So now the linen loop is here. Okay? Understood this part? The other end of the linen loop is below. If this is open, this is closed. Now this portion of the Marcelline tape I will thread here.
Okay.
And then pull it down so that this Marcelline tape and fiber wire comes below.
Okay, got it, sir.
Understood? So now I will tie my knot here.
Okay.
So the knot is below the clavicle. It is not felt subcutaneous. When a surgery is over, my tape is absolutely flush to the fracture side. There is no knot here. All the knotting is below. Understood? If you don't want to do this, you can use this, pull it up and tie the knot on top also. But I feel this is more physiologic and it is less less irritant on the soft tissue.
Got it.
Right? I hope I've cleared this up.
Yes, sir. Thank you.
Thank you very much.
So can you explain for the AC joint?
For the AC joint, again for the AC joint, you just, if this is the acromion and the displaced clavicle is here, okay? Your coracoid is here. You pull this clavicle down using the same technique. Your clavicle comes aligned to the acromion. Now, you can use a similar fiber wire which is going across, it's coming out through this hole. You tie it either through drill holes or to the soft tissue on the outer side of the acromion and make a knot here. So, whatever soft tissues are here, you take threads and you suture it back, but this reconstruction is not important. Important thing is that the clavicle should be pulled down to the coracoid. Once you do this, this will become okay. Through the same tunnel you can pass in multiple threads, no? You can pass in 2 or you can pass in 4 also, and you can use that to hook it around. But basically, no, this AC joint reconstruction is not important. This reconstruction is important. Once you pull it down, this alignment will remain. It may stay loose also. If you have soft tissues, you can repair it around it. But my aim is to pull the clavicle down to the coracoid. Once that happens, whatever happens lateral to it is not important. Okay, any questions?
What is the difference between suture anchor and or a fiber tape? What is the difference in the strength of both?
Yeah, so a fiber tape and Marcelin tape is definitely much more stronger than a number 2 fiber wire. But if you are using only a fiber wire on a suture anchor, there is only enough room to pass one fiber wire through the suture anchor. You can't pass 2. They will not allow it only. So that is a small disadvantage of using a suture anchor. Your fixation is not as strong as when you go around the coracoid. You can't use in 2 suture anchors there is not enough space. Only one suture anchor you can use.
There's a question from someone here. Please go ahead.
Dr. Laksh from Jodhpur.
Yes, Dr. Laksh.
Sir, what should be the distance of the hole which we drill in the lateral end of the clavicle from the AC joint?
So it should be adequate. I mean, that's the best answer which I can give. There is no measurement because every size of the lateral end of clavicle may be different. So it should be adequate so as not to penetrate into the fracture zone. Should be away from the fracture zone by about at least 3 to 4 millimeters.
Sir, one question.
Yes.
Sir, in the osteoporotic bones,
yes,
with the elderly patients,
yes,
what precautions should be taken while using this method, and what should be the cutoff age that after that age you're not supposed to use this?
See, as I said, this surgery is not a mandatory surgery. The only problem which AC joint disruption or lateral and clavicle fracture give is cosmetic if there is a wide displacement. In an elderly individual, they will more likely to have a mid-shaft clavicle fracture than a lateral end clavicle. But if they do have it, you can use the same technique. Now, there is no real negative side to using it in an osteoporotic bone. If you are using the tightrope, the wide surface of the endobutton itself will prevent crushing of bone. But the threads, if you tighten it tightly, there can be some bone crushing, but that can be alleviated by determining the force which you use to tie the thing together. The Marcelin tape, in fact, spreads the force over a wider area. So chances of Marcelin tape cutting out or Marcelin tape causing crushing of bone is minimal. Most of the time in elderly patient, if you feel it is very, very osteoporotic, frankly, I have never operated on them because most of them can be absolutely conserved. This surgery is generally done for a young, active individual.
There's a question from MGM Kamote also. MGM Kamote, they don't have a camera, that's why. You can go ahead with your question.
They are muted.
Can you hear us?
They are muted.
Yeah, in the meanwhile, we'll talk question. Yes, please go ahead.
Yes, go ahead.
Mumbai, hi.
Yeah, if
Hi,
the
my name is
lateral
Rohit Sani. I
clavicle is
just want to
severely
know the
comminuted-
transcoracoid technique. How do you, if you get a split, coracoid split, how do you manage the coracoid split?
So if you get a coracoid split, go under the coracoid. Don't use the transcoracoid technique. Go below and hook around the coracoid, the base of the coracoid. If it is intact, then you can easily hook around it. Or you fix the coracoid with a screw like you would do in an otherwise fractured coracoid, and then you go below the coracoid or through the coracoid as required. This is a rare situation where you have a lateral clavicle fracture, AC joint disruption and a coracoid fracture altogether. Frankly, I've never had
Talking
this
about when
issue.
you're drilling the coracoid, you get a split, not in like a primary.
That's a surgical iatrogenic complication. If you have had it, then I would suggest that you go below and across the coracoid. If it breaks completely and separates into two fragments, then, as I said, you put in a screw because the coracoid is visible to you. You put in an AP screw on the coracoid and then go below it. So I have never had a fracture of the coracoid while drilling. If you drill it very carefully, slowly, there is no reason why the coracoid should break unless you've been a little rash and negligent.
The question from Nagpur.
Yes. The pec minor when you're going around the coracoid.
The pec minor around the coracoid, since you're going to the base of the coracoid, there is no muscle which comes in your way. So what you see is the fascia and the dorsal surface of the coracoid, and then you go from the base on the medial and lateral side. No pec minor or no conjoint tendon are disturbed.
So there is a question from Nagpur.
Thank you.
Yes, Nagpur, please go ahead.
Yeah, if the lateral and clavicle is very comminuted and you have small fragments, so would it all preclude, tightening of this because the tape and the suture would essentially go between the fracture?
That's a very good question, but the answer to that is very simple. Look at what we have done for the AC joint disruption and look at what we have done in the case of the tightrope. We have not put anything across the fracture site. The tightrope is pulling the medial clavicle fragment down to the lateral clavicle fragment. So you can absolutely ignore the fracture. Just pull the medial clavicle down so that it is aligned enough with those comminuted lateral fragments. You need not go across the fracture site and hold them together. If anything, you can use a vicryl circlage, keeping the soft tissue intact on these comminuted fragments and tie them up together. So the important thing is not is not that you have to go across the fracture site. Important thing, the medial clavicle has to be pushed down or brought down to the level of the lateral fractured fragment. So the tightrope, you see, we have not gone across from the medial to the lateral fragment at all. We have just pushed the medial fragment down. I hope that answers your question.
Yes.
Yeah.
Is MGM Kamote ready? You can unmute yourself. I want to see if we can unmute them from our side. No, we can't. We can't. Abhishek wanted to ask a question.
So, since you have easy, nowadays is the fixation devices have come in the second technique that you showed. So now do you resort to first technique in your cases? If yes, then how do you decide?
Now I have shifted to the tightrope. Last 4 or 5 cases I have done using the tightrope. It's easier, faster, and since I've gotten used to it, I found it a little better than going across the coracoid. But if you don't have access to tightrope or financial issues, going across below the coracoid is also good. I find it difficult to buy Mercilin tape now. Mercilin tape is now very rarely available. I think Johnson wants to take it out of the market and push their fiber tape in its place.
And do you ever excise the lateral end of clavicle and then just fix the coracoid or no?
No, I have never had to do that. But yes, if there is existing AC joint arthritis, there is a theoretical possibility that you can do that, excise the lateral end of the clavicle if it is AC joint symptomatic.
So one more thing I wanted to ask. Now we are going through 2 cortex of clavicle and then again 2 cortex of the coracoid. And you are drilling a wire and then a drill over that. So is there any chance of getting these, because these wires are flimsy, the guide wires, chances of breakage or how to prevent that? Or
yeah, that is a good question, but what we get with the tightrope set is its own guide wire and its own drill bit. So this is supposed to be non-reusable. I used that one guide wire the first time for that particular case and the drill bit also once for that particular case, and then it's supposed to be discarded. It comes as a part of the whole set. So if I'm reusing my guide wire, chances of breaking are high. If I'm using the guide wire for the first time and a single use, then chances of breaking theoretically are not there. If you reuse your guide wires, then they have already had metal fatigue and they can break. But if you're not reusing them, you're using them for the first time, then the chances of it are very, very low.
Someone from Ahmedabad wanted to ask a question.
This is Dr. Praveen Sada from Ahmedabad.
Yes.
So first of all, thank you for a wonderful demonstration, and this topic is particularly close to my heart. So if you permit, I just add a couple of points to the questions people have asked. There was a question about coracoid split during surgery. So I had a case long time ago, and you can put an anchor in the base of the coracoid. It's a nightmare scenario. I hope no one ever encounters that. But one bailout option is to put an anchor in the base of the coracoid like a remnant, and you can use that to reconstruct. The other points that I wanted to make was about Mercedes tape. I have been using fiber wires, and like you, for the last 15 years, I have not put a single plate on lateral clavicles. One advantage that I've seen in fiber tape is that it's quite rough compared to the Mercedes tape. So it gives that much more access for ingrowth of fibrosis, which gives inherent stability. So in case if we ever have to take out the thread due to knot irritation, the ligament itself will remain stable in the long run.
Yeah, so if I'm tying my knot below the clavicle, there's no question of me revisiting for knot irritation. If you're doing this for a long time, I would suggest just switch over to putting the knot below the clavicle from what I showed you. You will not need to remove it ever. Okay, we'll move on. I think that's enough questions for my talk. Now we call upon Dr. Pradip Nemade. Let him say, then we can make. Ask the question.
What about osteolysis of the endo button?
Osteolysis under the endo button. Yeah. So these endo buttons I've been using for the last 2 years only. I've never had an osteolysis case up to now. Maybe 4 years or 5 years down the line, if I do get, I'll tell you what I did.
Okay, so let's discuss the clavicle, which is by very superficial, horizontally located long bone. From the ease of access, it's pretty easy bone to access, but since it is a very curved bone and a twisted bone, can be an issue while fixing it. So this is a case, floating shoulder case of a 26-year-old man had a road traffic accident, and we can see that he had a glenoid and neck fracture and a comminuted clavicle fracture. A floating shoulder injury, which is an indication of fixation of both. The clavicle also is a 4-part fracture, so that's where I would like to do a plating of the clavicle fractures. And this is what we need to see from the front, and we can see that there are 2 butterfly fragments. One is from the posto-inferior area and one is from the anto-inferior area, and then 2 main fragments of the clavicle that are seen. Now before that, before I go on to the video, I want to make it a point, because this is an old video where I had kind of sacrificed the supraclavicular nerve. That is not a message which I want to give, so that's why I show another case. The case of a 22-year-old similar looking fracture, where we have to make sure that we need to preserve the nerves. So these are the suprascapular nerves which we want to preserve, and then we kind of fix this fracture with the plate. So similar fracture, but after preservation of the nerves. हैंग हो गए एक मिनट जस्ट नहीं this is hanged. Computer is working, the projection is hanged. Just a minute, I will restart the PowerPoint. This computer has got hang, so. So the almost similar looking fracture where we need to preserve the nerve and then kind of fix it with the plate like this, and we need to keep the nerves till the end of the surgery, and then we can fix it. In this case we had added bone graft also. So we can see that in each and every case we can preserve the nerves, but this particular video being old, we can see that in this particular video the nerves are not preserved, and that was not the message I wanted to give. That's why I showed those cases. So going on to the live surgery of that. So again, I want to do this in a supine position. Anesthetist will give block, and I in this case rather we would want to give a interscapular pad, because that will kind of open the shoulder and that will aid in your reduction. So when we are doing the clavicle surgery, in those cases we want to put an interscapular pad, because that will put the shoulder apart and that kind of reduce the clavicle fracture. So these are the CT scan. So we take a horizontal incision across the length of the clavicle. You can mark the clavicle, and then you can take the incision along the length of the clavicle. I would want to infiltrate many times this area with the saline adrenaline solution, because that area is pretty vascular, and wait for some time for it to act, and then that will give you some initial hemostasis. So we take the skin and subcutaneous tissue in line with the this thing, and what we see now is the inferiorly will be the pectoralis major, and there superiorly will be some fiber of the platysma medially that are coming there. So we need to take incision little bit inferior than directly onto the clavicle, and we want to go make a slight superior flap and go into the upper edge of this, and we don't want to go into the muscle fibers. There we palpate the clavicle and go on to the edge of the pectoralis major, which is attached onto the medial part of the clavicle, and laterally the deltoid. So we go on the superior aspect, and we just cut in linear way. We don't want to use periosteum at this point. We just go linear way along the clavicle all the way, and we try to elevate the tissue posteriorly and slit light bit anteriorly at the fracture site. We can keep on palpating the fracture. All we need to do is only the circumferential elevation of soft tissue only at the level of the fracture. We do not kind of skeletonize the clavicle, put two ends out and put bone holding like that. We want to keep as much soft tissue attached to the clavicle as possible. That's why we just go linearly along the way of the clavicle, and once we know where the fracture site is, at that level only we want to go all around. And the purpose of keeping that anterior flap is that at the end of the procedure it nightly covers the plate, and the superior fascia is much more yielding to come over than the inferior fascia when it comes to the closure of this one. So that's how we want to use, we expose the fracture site. Playback speed I will slightly decrease because this is little faster. Okay, so then we expose the fracture site, and we can see that is the distal fragment, and there is the medial fragment, and once you have put an interscapular pad, automatically gravity assisted traction is there, and then we kind of moti reduce it, because just with the traction it kind of falls back in place, and you can very easily approximate the fragment. The arm needs to be drape free, because in case you want to maneuver it, many of the times you may have to do a little bit of external rotation and abduction to give that lateral kind of excursion to the shoulder to aid the reduction. Otherwise it is just a simple positioning. The necessary distraction on the fracture fragment will be achieved, and you will be very easily able to approximate the fragment. The problem will occur when there is a circumferential comminution. The best way is if it is two-part fracture. More severe than that is that at least one surface of the clavicle is approximatable, and then you can get the orientation as to what is the anatomical orientation of the proximal and distal fragment, to which you can kind of approximate the butterfly fragments. And the most difficult would be when we have circumferential comminution, and then the proximal and distal fragment has no direct communication with each other. So now when we are exposing the fracture, we need to take care that we are not devascularizing the butterfly fragment. So as like the proximal humerus, we need to work only through the fracture site and not around it. So once you see the fracture, you try to go in the fracture site directly and try to clean it out. And you see this bone holding clamp, these are not the normal bone holding clamp we use. These are the pointed bone holding clamp that will go through the tissue like a towel clip. These are the special bone holding clamp, very sleeky and kind of bone holding clamp. You don't need to kind of elevate the soft tissue to apply it. It will go through the soft tissue and hold the bone, and by that way you can easily approximate it and try to kind of get it in place. Now once that part of the fracture is approximated, we can try to see where your butterfly fragment is sitting. Now I am exposing the anto-inferior butterfly fragment just enough for me to get that cortical margin visible, so as to see that how it can fit into that position. And now we are trying to make the place for the plate. So we need to have adequate exposure anteriorly and posteriorly. So laterally the clavicle become flat, and there where the maximum problem malposition of the plate will occur, because one may put the plate too anteriorly or too posteriorly. That's why it is very important to have the adequate anteroposterior dimensions of the clavicle defined, and for that matter you need to expose the superior surface, and you might want to use two needles. One put anteriorly and one put posteriorly in the distal part of the clavicle, to know the anterior and posterior dimensions of the clavicle, in case you don't want to kind of elevate the soft tissue from that side of the fracture. These are the locking plates which can sit onto the soft tissue. We don't need to kind of denude the soft tissue, but yes. And then the second part that we need to know that this is a twisted plate. So laterally the plate comes on the superior aspect, and anteriorly, medially it comes on the anterior aspect. So we can maintain the periosteum of the pectoralis major muscle, and we can put a plate on the top of that medially. So that is how we are giving, trying to see that our plate position, how many screws we are going to get laterally, and how many screws we are going medially. Adequate length of the plate can be applied. Now once we are done this, again same clamps can be used to go all around the fracture site and holding the plate in place and holding the reduction in place, and these are automatic clamps. The big one which we use for radius ulnar fractures cannot be used here, because that will lead to soft tissue stripping. And we need to be careful about where the neurovascular structures are. In the middle part, they are around 7 mm, 1 cm away in a resting position. But once you are dissected out, that tend to fall a little bit behind in a supine position. But still, we don't need to be very rash around there. So that's how we are trying to put the plate into fragment, again putting one clamp across the fracture site to get the adequate extension. I was not really happy with that, and then again try to reduce it. Probably I want to fix it temporarily with a K-wire, because that plate positioning and everything, I was not happy. The fracture was getting displaced when I'm putting a plate. So now I want to fix it temporarily with a K-wire. So that was temporarily put a K-wire, and then I would like to reapply the plate again. So again, not all patients have the clavicle curve the same. So sometimes you may need to bend the plate a little bit, and in that way stainless steel plate may kind of score better. So that's why I keep both the titanium and stainless steel plate on table, because the titanium plate are very difficult to bend, but stainless steel, if you want, you can bend it a little bit. So again we have tried to get the plate in situ, Now we can put a plate little bit away, but that may create some impingement on the skin. So that's why it is very important if the plate sit flush. So that's why you can do contouring. Now once the plate, we are happy with the plate position, we can fix temporarily with screws on either side. If it is perfectly, then you can put locking screw directly, or you can always use a unicortical cortical screw so as to make the plate sit flush, and then rest of the screw you can put locking. Sometimes I would even drill a cortical screw in the locking hole so that I can replace that later with a locking screw. That's how we are fixing the fragment on one side with a with the screw, and then on the other side. Now one must take care about the length, selecting the length of the drill bit. We can make sure that your drill bit is just positioned. Use it on a chuck mode rather than a quick connect mode, because then you can adjust the length of the drill bit, and you can see here I have made sure that your drill bit is just 18 millimeter length available. So even if you kind of shoot it, you do not perforate too much and will not damage the underlying structure. So you can see it is just enough to penetrate the second cortex without any damaging. So that's why I want to use it on a chuck mode rather than using on a quick connect mode, because that is much safety wise much better. And then at that end we fix with another this thing, and then once our position is fixed, then we can put all other locking screw, and then that plate fixation is confirmed. As I said, the medial screw will go in little bit antero to posterior direction, and the lateral screw will go into superior to inferior direction, and we need to use exact dimension screws. After that, fixation is complete. So this is the lateral screw. We fix the component, and now our fixation of the plate is complete. We can really approximate the area very well nicely over the plate, so that the plate will not be subcutaneous and will not cause problems. We can see that the flap is nicely overlappable. Now comes the area of fixing the butterfly fragment. So depending upon whether the butterfly fragment is a part of only one fragment or both fragment, you can fix it either in the beginning or at the end. So in this case, the butterfly area is a fragment of both these things, so I want to fix it at the end of the plate fixation. Or sometimes it is only part of one fragment, then you can fix it with that fragment, convert it into a two-part fracture, and then fix the fragment like a two-part fracture. So now I am just gently kind of exposing the butterfly fragment, just enough without devascularizing it much. I am just elevating the medial side a little bit, and then again using pointed clamps, try to reduce it. Leave all the traction, otherwise with the traction it may just denude the area. So just pull the fragment, put the fragment, and then I am trying to approximate it, and in this way we just need to keep on trying slight permutation combination and clamp adjustment, and in this position we can see that the fragment is sitting nicely in place, and we are happy at this point, and we can fix now it with the butterfly fragment. With the this thing. So now to handle the soft tissue, we can use the suture into that soft tissue rather than directly handling. That will kind of help in mobilizing the fragment without devascularizing it. So in this way we are fixing the fragment with 2K wires, and I am trying to fix it with a lag screw. So initially I tried to fix this fragment from the top with the lag screw like this, and I was not happy with that fixation. So I removed that screw, and then we drill it from anterior to posterior direction. So this is it. Now I am fixing it from the anterior to posterior direction, from fragment to main, from a butterfly to the main fragment area, and that's how it is drilled. We drill the outer cortex first, and then the other fragment, tap it. I don't want to use a self-tapping mode of the screw, because that sometimes pushes the bone fragment too much. So that's why I will tap it. When you are putting the lag screw, I always tap, and then at the end of this thing, I fix it with a screw with a washer, and that is how we fix it, the washer. So once it is done, thorough betadine lavage can be given, and then we close the fascia. Now facial closure is extremely important. We need to make sure that entire soft tissue kind of overlaps it. Even if the pectoralis fascia which is lax, we need to kind of make it double breasted. That is also okay, not a problem. But we have to make sure that the muscle is overlying the plate, that will prevent the plate being subcutaneous. That's how the entire fascia has been closed, and we can see that the entire fascia has been closed and the plate is completely buried under the this thing. And see, look at that. That's why we have taken the incision inferior to this, because now the facial closure is superior and your skin closure is inferior to that. So it's not directly communicating there. So even in case there wound issue, the plate will not get exposed. And then we continue the skin closure like that, and then we can use either stapler or we can use these kind of a monocryl sutures. Coming back to the post-op X-ray. So this were the post-op X-ray of this patient. He had a glenoid fracture also, so the scapula fracture also, that was fixed. And this is how the skin heals. It heals beautifully, both the scapula and this wound. And that was the end of it. Thank you so much. Any questions for this?
So any questions anywhere for Dr. Pradip? You showed a wonderful demonstration of fixation of clavicle. Ensure that your soft tissue dissection is minimal so that your healing is optimal. Satish, you had?
Yes.
So, who's asking? Chennai, yeah, go ahead, Chennai.
They are muted.
You're muted, sir. Can you unmute? Chennai, can you unmute? Sanjay Dhar wants to ask a question from Navi Mumbai.
Yeah, thank you. Pradip, since clavicle is a membranous bone, the periosteum is not there. So, and usually we see combination, there are butterfly fragments there. So how important is the soft tissue, whether you should denudate, and because how important is bone-to-bone contact in such situation? So many times we see there are multiple butterfly fragments in between, so which you want to preserve their soft tissue attachment. So how important is the soft tissue dissection in these cases? Because the failure will be a disaster in such cases.
Absolutely, sir. As we say that a clavicle never gives very rarely will give a union issue as far as it remain close and conservative management. Only certain indications where we need to fix the clavicle, and in case we have to open it like this, then we really do not want to devascularize those small fragment. And in those cases, if that fragment gets devascularized, then it may give a problem for healing. But yes, if the mota-moti alignment can be possible and you can want to do a bridge fixation kind of even without kind of handling those fragments also, that is a fair option as long as your reduction is good. Because if you are using a plate, then I think it is better to reduce it well, because plate fixation without poor reduction will fail.
So Chennai, your question?
So, it's a nice presentation. So I was thinking like, you mentioned about the contouring of the blade, So somehow I felt the lateral clavicle plates of titanium sits better than the titanium shaft plate. Have you...
I 100% agree with you. I 100% agree with you that the lateral clavicle plate, which are the 2.7 screws laterally, and then they have the curve medially, they sit much better than this thing. The reason being, which I feel is that, as I said earlier also, the S-shape curve of the clavicle and whatever the radii of those curvature may be different for different patient. The twisting of the planes may be different for different patient, and this plate which I have shown may not fit well in this, because this is a standard plate and not all clavicles are same, so they may not fit. But I share your observation absolutely that the lateral plate sits much better than this kind of plate.
So we'll take question from Gwalior and then from Ahmedabad. First Gwalior. Gwalior first. Yeah.
Good morning.
Good morning.
I have a question regarding the open function and fixation of clavicle. How often you come across the supraclavicular nerve, and if it is not seen, so how do you explore it? Before the
Previously I wouldn't used to bother much about this and used to directly go through there, because that's an old video. You can see this. Maybe last 10 years I purposefully dissect it, and I had a good video, but somehow I couldn't find out. The way of dissecting is that once you go to the skin and subcutaneous tissue, you take the scissor or any dissecting instrument and run it, spread it in a superior inferior directions. So the nerves are not there in the platysma, so we can clearly go through the platysma. Just below the platysma, whatever facial layer is there, just above the periosteum and below the platysma, if you dissect, you will clearly see the supraclavicular nerve. The biggest one is the medial one. Now sometimes you get a distal fragment branching nerve also that can be seen. But once you see the nerve tissue, which is very specifically distinct than the fascia, you can with a very sharp kind of a scissor dissect it proximally and distally, so that you have adequate length of the nerve that is there available for you to maneuver in case you want to retract them medially or laterally, and that way we can prevent this nerve getting injured. There sometimes are a menace in reducing and managing the convoluted fragments, but yes, that's otherwise clavicle fracture exposure is simple, like skin to bone, if not being the nerve. But the nerves being there gives adequate challenges for us to enjoy the surgery.
Good. Just one thing, Harshad, I would like to add. Yes. Recently in the meetings, I have seen that pre-operatively they get ultrasound marking of the nerves done, and the sonologist marks the nerve with a marker which does not go with scrubbing. It gives you a fairly good idea, and you can actually save the nerve.
So that's one more technique. So we'll go to Ahmedabad and come back to Gwalior. Let Ahmedabad take its question.
part of the question.
That the anatomical plates which are available in the market, they usually do not match. And we also showed that these.
I couldn't get it. Can you please repeat?
Yeah, so just little slowly and
the sound we get is little muffled. So go please.
Slowly ask a question.
The anatomical plates which you have shown usually do not match with the curvature of the clavicle. So my question is, any other option, whether you suggest use of thinner and smaller plates for the clavicle fixation or orthogonal plates in dual plane, superior plate and inferior plate?
Okay, so this problem was worldwide faced by every one of these. This plate was brought in by Synthes, and other people tried to kind of emulate the same design. But again, because the same reason which was said earlier, this plate had little bit issue in contouring. And even if you see my video, I was trying too much to kind of put it back in place. So the newer designs, which are they are less twisted, and they have 2.7 screws and they do not have combi holes. Those plates which I have seen that case earlier also, right? The one which I showed, the newer design that sits much better because they are not, the twisting is not much. So those feels much better, but we can always have a recon plate, locking recon plate or simple recon plate ready, and we can always use it, and we have seen phenomenal result with that plate also, those two plates.
So Pradip, there is another part to the question, if I understood it right. He is asking whether you can use thinner plates in orthogonal, dual plating.
We can use it. I think that call can be taken intraoperatively. If we are using this plate, single plate will suffice. But if you are using kind of a more malleable plate and you feel that one plate will not be stable enough, you can always add the second plate.
So Ahmedabad, the question is answered. So Gwalior, you had a question again.
Gawhale had a question. Yes, sir, go ahead. We can hear you.
Question, how often you, in cases of the non-union, established non-union clavicle, you used to use the bone grafts?
Always. All case of non-union, always bone graft. I always use everywhere, almost everywhere, and other than the hypertrophic non-union of the extremities, I use bone graft everywhere. So in the clavicle, 100% bone graft. I don't know, means I don't want to, it is sometimes maybe an overkill, but I definitely don't want to revisit the area and regret it that I have not put it.
So I think standard practice, if you have a non-union established, especially membranous bone graft, absolutely is must. Any other questions? Dr. Sudhir?
If in the last case you showed you had a scapular fracture also.
Yeah.
So out of this, which will you tackle first? And the positioning of the patient.
Yeah, so if it is a two-part, so that's where we are discussing the sequence of fracture fixation in a floating shoulder injury. In case it is a two-part clavicle fracture, where I know that if I am fixing the clavicle well, reduction is very easy. I will almost always use a kind of plate in a floating shoulder patient. So with a two-part clavicle, I fix the clavicle first, and sometimes the glenoid will fall back in place, and I have done at least one or two cases where I have not fixed the scapula. But in case the clavicle is comminuted, then I will go and fix the scapula first, and then revisit and fix the clavicle.
So Abhishek, you had a question?
So a lot of times you see that there are long comminuted fragments and positioning the plate is a problem, as we discussed. So in that scenario, can you downsize the implant, and what is the minimum screws that you would accept?
Yeah, so minimum is 3 on either side. Minimum is 3 on either side. One of the case I had put 2, but minimum 3 on either side.
So you want to put 3
screws? 2 is
screws?
compromise. We have done it, but that's a compromise. Whenever it is possible, we have to use 3. And if the fracture is too lateral, then we have that lateral plate which takes 6 2.7 screws. So I have too less a threshold to use a lateral clavicle plate because that have too many screws.
Yeah, so laterally you have that option, but medially?
Like if the fracture is in the medial 1/3 or even medial 1/4, that is the problem. Fortunately that injury is rare. What we can do is, in those cases, use the opposite side lateral plate and cut it and use it. That also I have done. Opposite side lateral plate can be cut and used there. Fortunately, medial 1/4 clavicle fracture are rare.
So like we have to fix the glenoid first, and then we are planning for clavicle, then what position you prefer?
Lateral.
Lateral
position.
All right, thank you very much. Any other questions from anywhere? I think we'll go ahead. We'll have to change the order of cases a little bit. Dr. Sangeet was supposed to come, but he's stuck because there's a Mumbai marathon. There's a lot of traffic coming from down. We want to continue with the TIVA elbow, should I take? So what I will do is, my case which was there for non-union of humerus, I will take it now. It was supposed to be done last because the other faculty was supposed to come here, but they are stuck in traffic. They will join us by 12:30. Hopefully, in the meantime, let me just take my last case. So at the offset, I would like to make a little apology. This video is shot by a Samsung camera, so it's a little red. It's not a professional camera, but I think most of the vital steps will be seen quite clearly over here. So this is a 78-year-old person who was operated for a fracture clavicle. Not clavicle, a fracture of the distal end of the humerus 2 years ago. And the plate fixation was done by a posterior approach. Fracture was lower 1/3. We don't have the immediate post-op X-ray. He has an obvious non-union and a loose implant, and he is painful and non-functional. So that's the present X-ray which he has come to us with. As you can see, there is a plate in the distal 1/3 of the humerus, and you can see the classical windshield wiper effect distally where the implant fixation is not holding,
and the screws have caused the bone to be completely lytic. There are huge cavities here. The 3 screws distally are loose. Proximally, the 3 screws are holding well. So this is a problem with, if you have inadequate plate fixation, you have inadequate screws, and you mobilize them early, your plate will become loose either distally or proximally, and you will get this kind of bone loss. Now with such significant bone loss, you need to fill up that defect with some auto or allograft. In this case, I have chosen to use the fibula. There's a CT scan. There is a hypertrophy of the bone. There is an attempt to healing, but because it was not stable, that the bone has not healed. That's the orientation. This is going to be the entire orientation in the surgery. Your elbows towards the inferior side, shoulder superiorly. On the right side, you have the lateral, and left side, you have the medial. Now, you can see the scar of the initial surgery is healed up well. There is no evidence of infection, and that's the original scar. So whenever we are doing for a revision surgery, it's important that the radial nerve is completely fibrotic in this area, and that is your primary aim, is to identify and dissect out the radial nerve. The trick here is to start from the normal area. So take a longer incision, go right up to the middle and the proximal 1/3 of the humerus, dissect out your tricep from there, and then only identify the nerve. So so nerve is going to come from the medial side going laterally. That's the approximate direction of the nerve in a normal situation, but whereas where the patient has been operated, there might be the nerve in a. Can you put the volume also? Surgical volume? So that's the virgin area, the area where no surgery was done. So in any case of revision of humerus, you should always try and mark out where you expect the radial nerve to be, and take an incision longer than the original one, so that you are able to go from an area which is relatively clean and non-operated, and then go to your area where the plate is. Okay, patient also has a small bursa on this area because the plate is mobile and it is causing irritation of the soft tissue. You take a proximal incision. This is the area which is relatively avascular. This is the area which is fibrotic. This is the area which has not been operated. If you just retract the skin in subcutaneous and cut the fascia, this you can see part of the deltoid, and here the long and lateral head split was visible. You just exposed it, and what you see in the depth is the beginning of the nerve. So since it is very easily visible, where the patient has not been operated. Now as we go below, this will become more and more fibrotic, but now we have the origin of the nerve, so we can trace it down very easily. Okay, rather than hunting it in the fibrotic area, you should always find out where it is in the normal area and then go to the area which is operated. So now here the dissection is very slow. I'm not going to show you the entire dissection because to free the radial nerve it took me an hour. So now the nerve is entirely dissected from top to bottom. That's the entire nerve. So my first 1.5 hour surgery is spent only in identifying and isolating the nerve. You can see the nerve going laterally through the. So I identified right up to the lateral intermuscular septum. I may be freeing it more than what is required, but at least I know that the nerve is not now going to be coming in my way. That's the plate under the nerve. Continue. And our plate from top to bottom is fully visible. I have to put a longer plate, I will get space here. I have to put a second plate, I will get space here. So there is enough place for me to put in 2 plates. I don't need to go laterally. Even if I do, I will dissect out this soft tissue, subperiostelis, and I will be able to go laterally. Okay? So lateral and medial surface plus posterior surface is exposed. We haven't dissected too much soft tissue. Now we'll remove the plate. Give me a screwdriver. These distal screws are loose, absolutely. No part of the plate is loose. I have removed the top 2 screws. This is the cortical screw which is there proximally. First 2 screws were locking screws which came out easily.
It should walk out. All this is fibrous tissue around the plate. This is the area of non-union. We'll clean it up and then come back again.
So that's the plate which is removed, and at the bursa which I have excised, which was part of the distal portion.
Another 45 minutes to dissect out the entire area. As you can see, this is the non-union site, completely blocked.
There is a lot of sclerosis in this area. You have to use a drill bit to break that ledge of bone and then find the medullary canal.
Distally the bone is even nearby. Again, the medullary canal is not seen, it is obliterated. Not only that, you have 3 big holes here. This is for the 3 screws, 1 hole, second hole, third hole. There is full sclerosis over here, sclerosis over here. The canal is completely lost. We have also exposed the lateral surface of the distal humerus. This is the olecranon fossa, very close. So our plan will be to put a plate, which is anatomic plate.
We use the lateral anatomic plate.
And then go centrally on the central side. We'll align it, refurbish the medullary canal, put in a fibula inside. Hopefully our screws will get held, and the second plate we'll put either on lateral side or on medial side. Medial side there is a big callus, so I don't want to remove it. Maybe I will put it on the lateral side. The lateral side surface also is exposed. Nerve is here. That's the radial nerve in its entirety. You can make out here distally, it is going down this and exiting into the anterior compartment.
So any non-union of the humerus, I always use a dual plate.
The humerus. Now it's been almost 1.5 to 2 hours since we started our surgery, and now we come to the plating part of it. The exposure took long time as expected. I will make a drill hole here and find the canal, and similar procedure will repeat on this side.
So this part again I have skipped. This is the exposure of the fibula.
Will be here. This is the lateral malleolus.
So we take the middle portion of the fibula, about 10 to 15 centimeters.
10 centimeters of fibula. So we'll take a long incision. Fibula we harvest will be a little thicker for our humerus, so we'll have to split it up into 2. This is a knife. This is exactly in the middle. Maybe a little on the upper side, so we'll take our incision from here to here.
So there are 2 ways to harvest the fibula. You can do it with the periosteum or without the periosteum. If you are going to put the fibula in its entirety, the full thickness of the fibula, then you can keep the periosteum intact on the harvested fibula. So that will act as another vascular or additional vascular channel, because once you put it there, the blood vessels will go through the existing ones in the periosteum and then enter and incorporate the fibula. But here, because the humerus will not accommodate in the medullary canal the entire fibula, you have to split it into 2. So here I have taken it subperiosteum. I've kept the periosteum there and removed the fibula without the periosteum.
Just stripping off the fibers of the muscle.
So Pradip showed you do very gentle dissection of soft tissue. You use your periosteum very rarely. You just strip off the muscle fibers. This is how you harvest with the periosteum. Just strip off the muscle fibers, keep the periosteum intact, take one proximal cut, one distal cut, and the entire middle part. Sparing the muscles, you can take the fibula out. But here in this case, later, because I had to split the fibula, I have kept the periosteum in the donor area itself and removed only the bony portion of the fibula, not the periosteum. There is hardly any bleeding here. If you are careful, whatever penetrating vessels or perforating vessels, you can easily catch them. Blunt dissection helps us to identify where these vessels are, and then you can.
With the periosteum, when you're splitting the fibula, it doesn't matter whether the periosteum is there or doesn't, not there, it will ultimately go retraction. So I'll show you after the fibula is exposed fibula. You use
So that's the exposed fibula.
exposure because this thick fibula cannot go in the humerus on its own. We'll have to split it into two. So there is no point in preserving the periosteum. Periosteum will not be.
Another thing which you can do is, if you're splitting the fibula, you can make drill holes here itself before harvesting it. Otherwise, you harvest the free fibula and then make drill holes, the fibula tends to toggle when you're doing your drill on your table. So it can fly off also if you're not very careful. So I've just
about 10 centimeters.
measuring the fibula
For us,
about 10 centimeters, and then
we'll make drill holes over here and distally and we'll take it. So a drill bit when it's
I'm harvesting the entire fibula. I'm not taking part of the fibula, but I'm just making drill holes so that it is convenient for me to split it up later on once I've retrieved it on the table. So this is the proximal and the distal end. Here I'm using a thicker drill bit so that my osteotomizing becomes easier, or using oscillating saw becomes easier. The vertical split I have used a thinner drill bit so that I don't use so much more.
the cortex, so if I have to split the fibula, I can do that. It makes it a little easier to drill it when the fibula is in place rather than when it is outside. Otherwise the drill will constantly keep on separating. So I can use a saw, but here I think I'll use an osteotome. If there is difficulty, I'll use a saw.
So the anterior and posterior cortices are thick. You should ensure that you drill it anteriorly and posteriorly. If you use your osteotome very roughly, you can splinter.
But it will not go distally. Because distally the canal is still narrower and still flatter.
See, that the entire fibula I'm trying to put, but I am sure that there is no space.
So we will make a split.
You've done enough fibula for the humerus to know that the entire fibula will not go inside the medullary canal.
Posterior cortex or on the medial cortex or on the lateral cortex as an on
So the other portion of the split which remains, we use it as an on-leg. So the fibula is not wasted. That split is not. So I split the fibula now.
And the thinner one will
The thicker part I will put inside in the canal. So through the holes of the drill bit, through the holes of the screw, I have just punched it in.
Process, but we shrouding the fibula here.
I kept more fibula on the distal part because that's where the bone loss is there. I want some bone in that area.
And then we re-put it back. So this big hole, and these three big holes have been covered with the fibula. We'll just punch it in so as to get better alignment and better compression.
I'm docking the fracture fragments. As you could make out in the pre-op, there was hypertrophic non-union. The bone attempt to heal was there, only thing it was not stable. So I don't think healing is a problem. Even the bone ends were very vascular. There was pedicle bleeding all throughout. It's not an atrophic non-union.
There is good overlap over here.
So I have not used any cancellous grafts here. It's just the fibula, intramedullary and on-leg, and the remaining part is taken care of by stability.
Fibula available for us to be put here. So what we'll do is we'll put one lateral plate, one posterior plate, and an on-leg fibula also.
So again, I have not finalized where my plate is going to be. I'm saying lateral, but finally, you see I put it on the medial side.
We can put our plate. What we'll do is we'll use that lateral humerus plate to show you. So that's the humerus.
That's the anatomic contour plate. It sits posteriorly, proximally, and laterally distally.
Distally as possible and proximally. So it will go here.
In any non-union, use as long a plate as possible.
Very much high. Can you please? So the plate will not be perfectly aligned because the humerus is still wavered. But once we compress it, it will come back in place. Okay, sir, this side. The second longest plate, we have got a longer plate also. I'll see which one fits better and we'll put accordingly. We'll put a plate on the lateral side, coming as distally as possible. 1, 2, 3, 4, 5, 6, 7 screws distally, these screws going through the fibula. This is our fracture reduction. You can see there is very little gap here.
Some people would say fibula, single fibula and one plate is enough. Why do you need to put a second plate? Second plate is an overkill, but yes, in a non-union, I would rather err on the side of overdoing rather than underdoing.
Now we put this plate on the lateral pillar, we'll be putting an additional plate on the medial pillar. We'll contour it so as to accommodate this bump, and that allograft on the fibula which is there, the other part, we'll put across on this side. As we had planned, we put a posterior plate on the lateral side. This is the medial plate.
That's a recon plate.
Pointed it to accommodate the natural bump which the humerus has developed.
So I don't have to remove that callus.
It acts as a graft on its own. We put in 4 screws proximally. We put in 4 screws distally. You can see the screws coming out from this area. Some of them are behind the fibula. One of the screws, 2 of these screws are through the fibula. Okay, now what we will be doing, hold it this way, we will be putting...
So as you can see, I am flexible where I want to put my plate. It's not rigid. It's on the surface where it is available, where I get a good fixation, I can decide where to put it.
Omnilateral end of humerus, this is the distal end of humerus. We created a small groove here. So this fibula is sitting here very nicely.
So that's the remaining fibula sitting in a groove on the lateral side.
Either with a circlage wire because there is good stability, or we might put in one 2.7 screw here and one 2.7 screw here, and then put in a circlage wire. There is enough space for screws to go in. What is an onlay graft? We have a medial plate, we have posterolateral plate, and we have a posterolateral onlay fibula, plus there is a fibula inside. Small grafts we have, we will put it anteriorly just to cover this area.
So no separate cancellous graft. You can use allografts also in this.
And held it in position.
Your void is too much.
2.7 screws, they're just holding it there. It's quite stable. I don't require any circlage. Posterior plate, medial plate we've already shown. That's the radial nerve in its entirety. You can see it going here. Structurally, it is completely intact. Now we just need to close the tricep and the skin and subcutaneous tissue. Okay, we will take deep stitches to get the deeper part together, and then superficial stitches on the triceps to hold it together. That's the olecranon fossa over here, completely free. We got full extension, we got full flexion without any problems. Okay, thank you.
So that's intra-op. Try and put long plates, they really help to distribute the forces and lessen the force across the fracture site. That's the fibula you can see, intramedullary. The anteriorly there is that hypertrophic callus which I haven't removed, that's post-op. Radial nerve is intact, patient is quite happy and so am I. That's the fibula which was excised, and that's the post-op. This is about 1.5 months post-op. He's coming for follow-up. An X-ray is due sometime this week. So the fibula screws, as you can see, they are not tightened because they are just positional screws. I don't want to push the fibula. If I tighten it, sometime that can fracture. So then I'll be in trouble. So I've just put the screws to hold that fibula in place there. I have a presentation on non-union of humerus which I will take for the candidates coming for the course, where I have about 7 or 8 cases where I use dual plate fixation. Not all of these require bone graft. If there is a hypertrophic non-union, no bone grafting is done. Just provide adequate stability using dual plates and your fracture will definitely heal up. In cases where there is a bone loss or there is a long-standing non-union, I would use fibula as an additional strut. Okay, thank you very much. Questions can be taken now.
So the fibular strut you have used, does it perform a mechanical function or a biological or both?
It is both. I would say more biological rather than mechanical, because the fibula inside the medullary canal or the humerus, which is split, is not providing mechanical stability. It can still move inward and outward. So if you have the entire thickness and you have an interference fit, then it has a mechanical problem. What the fibula does is it does prevent angulation in certain directions, but I would not label it as a mechanical graft, I would label it more as a biological. What the fibula does is, it gives us space or it gives us bone for screw anchorage. So sometimes when you can pass your screw through the fibula, where there is no bone on the humerus, the portion of the humerus, the portion of the fibula and the other humerus will give you a better screw hold.
You use the split fibula, eh?
Here I had to use, most of the cases of the humerus, we have to split the fibula because the entire thing of the fibula.
So
will
what do
not
you
go.
do to the other split?
So I put it as an onlay graft.
Onlay graft.
Yeah. So if you have a burr, now what you can do is you can thin out the entire thickness of the fibula and see to it that you shape it to the humerus and then you can use it. But you have to do that very patiently. And then when you burr, now you lose that bone. Whatever bone you burred is lost, you never get it back.
Do you use teriparatide in such cases?
No, I don't use teriparatide for bone healing at all, though there are people who would not be happy with that.
What about shingling?
So shingling is absolutely must. If I'm putting cancellous grafts, I definitely shingle. In any case, if I'm using the fibula and I'm even not putting a graft, I would still shingle. Because the process of shingling itself incites bone formation. The shingling is an important aspect of any kind of non-union. Even if you're not putting a bone graft, you shingle till you get bleeding bone. That by itself is enough to incite new bone formation.
Guntur, any questions from your end? Any experiences with non-union humerus in Guntur? Unmute yourself, please.
Is there a question from Nagpur? Can I?
Yes, we'll just take the question from Nagpur after we finish with Guntur. Guntur, can you unmute? Unmute yourself and then.
Javeri sir, one question from Gwalior also.
Yes, definitely.
Hello.
Yes, sir.
Sir, only use cortical graft as a stud graft in non-union humerus. Cancellous graft.
You're asking me why I have not used cancellous graft and used only a cortical strut graft?
Yes.
So in cases where there is, in the humerus now you get two types of non-union. One is an atrophic type of non-union in chronic long-standing non-union humerus where there is a gap. If there is an atrophic non-union, now you require to use all possible kinds of graft, whether it is a cortical strut or whether it is cancellous, whether it is mixed with allograft, and you require to give absolute stability to that area. So if there is an atrophic type of non-union, I would use both type of graft. I would use fibula, or if now available, I use an allograft fibula with autograft cancellous bone. I want that area to be biologic and associated with shingling, it will help. In this type of non-union where there is a plate loosening and because of the loosening there is non-union, the bone is attempting to heal. You can see hypertrophic callus all around. So here the problem is not the healing part, the problem is the stability part. So here I would not require any graft. I have presentations which I can show you. In hypertrophic non-union, you put two plates, absolutely no bone graft. You just shingle the bone and the fracture will definitely heal. But this is only applicable for hypertrophic non-union. Just keep that in mind. It's not applicable for all non-unions.
Sir, in case of non-union, aged patient, osteoporotic patient, what is harm of add cancellous graft in this case?
There is no harm.
Sir, adding a cancellous graft to this, absolutely no problem. It is always an advantage. There is nothing lost. Okay?
There is nothing lost.
There is nothing lost. The hypertrophic non-union doesn't necessarily require it. That is what Dr. Harshad says. But if you add to it, there is no problem. Yeah. Let's move to Guntur, sir. Guntur, we are waiting for some comments from you. Your experiences of dealing with non-unions of the humerus.
Yeah, this is Dr. Sivakumar from Guntur.
Yes.
That case is excellently presented. I congratulate the speaker for the surgery. And we are confused about one thing, that is shingling. We
Yes.
could not understand what is shingling and what is its advantage. And can you please elaborate on that?
Shingling is using an osteotope in an oblique manner so as to create an osteoperiosteal flap
around the fracture site. So when you freshen the fracture edges, you remove the sclerotic bones at the fracture site. So around the fracture site, you use a thin osteotome, keep it at around 45 or 50 degrees to the long axis of the humerus and make small cuts. So you are cutting the cortical part of the bone and elevating it so as to expose the underlying bone below the cortex, and you do it in multiple areas all around, like fish scaling. It's called fish scaling. When you remove the scales of the fish, that is what you do.
Sir, shingling is a fancy word for decortication, where you just remove the outer cortex, exposing a little bit of the cancellous bone in order to promote osteogenesis in that area.
So it acts as a microfracture, and any microfracture of the bone, the body will attempt to heal that area. So in that process, it incites a biological reaction which ultimately would enhance vascularity and enhance healing in that area.
Yes. Bhopal, please go ahead.
I'm Dr. Vibhas Gupta, sir. Sir, how much maximum shortening can be permitted in humerus fractures, and how?
Yeah, so humerus fracture shortening is not a problem. Up to about 3 to 4 centimeters you can shorten. I don't have a one figure that you have to shorten, and beyond this shortening is dangerous. But the more you shorten, you remember you're shortening the muscle also. So it does affect the power of the elbow, flexion extension power, because your tricep and bicep both are shortened. Of course, you can't have a shorten of 8 to 10 centimeters, you can't do that much shortening. But in case if you have a large bone loss and you feel that the shortening is going to be significant, I would recommend that you use the fibula as a double barrel, put it in the intervening area. If you have enough bone distally to fix your plate, you use a fibula and then cover that gap. If the distance is too large for a fibula, or the distal fragment is too small, then you have to take help of your releaser or friend and get a distraction osteogenesis there.
So one question.
Yes.
Sir, in this particular case, you must have surely ruled out preoperatively the infective pathology.
Yes.
So in case when you open and you see any signs of infection over there,
yes,
because there is implant loosening in the X-ray.
Yes.
So how would you go about it? Would you go for external fixation, or you will put the stimulant, go with the primary fixation?
So if there is gross infection, then obviously it is visible pre-op because there is a discharging sinus. You are talking about scenarios where intra-op you open and find that there is some kind of collection or some kind of granulation tissue which you might point you to the possibility of infection. So here now you have to use a little bit of clinical judgment. If your initial ESR, CRP and all other infection parameters are normal, and then you found granulation tissue inside, it may not be significant as far as infection is concerned. But yes, I would be in the back of the mind that there is a possibility of infection. I will send that sample for two things: histopathology to confirm, and same sample I would send for a culture sensitivity. In the meanwhile, because my index of suspicion is low, I would still use a plate, but I would use antibiotic impregnated stimulant or any kind of drug delivery device there. In this case, I would not probably use the fibula directly, because I don't want that infection affecting the fibula and then resorbing it, and then I have no fibula to fix it. I would fix it with a plate along with a stimulant. The plate, I would use a titanium plate, so my chances of getting biofilm are much less. If there is a gross infection, and I know that somehow in the pre-op workup this infection has been missed, in that case what I would do is use a cement spacer, a block of cement with antibiotic, and I would stabilize this either using a tens nail so as to get an internal stability. I am not in favor of using an external fixator for the humerus because it's very cumbersome for the patient, and I have not had very happy results with the external fixator as far as non-union is concerned. Once the culture sensitivity gives me a good organism, and then I know which antibiotic is working, that antibiotic is given IV for 3 weeks and then oral for another 3 weeks, and then this normal infection protocol you follow.
As a general rule, in any patient who has a loose implant, a failed implant like that, irrespective of whether there is a preoperative evidence of infection or an intraoperative evidence of infection, would you still send tissue for histopathology and microbiology?
Yes, definitely would send for a histopathology. That's a good point which Gautam has brought up. A histopathology or even a culture sensitivity, you should always send for two reasons. Number one is that you are sure that what you have done is absolutely right and you have a medical legal coverage for your activity.
Muradabad, any comments from you? I'm sure you must be seeing on your part of the world a lot of humorous non-unions. What is the way you go ahead? Muradabad, any questions, any comments? All right. Okay. Any other? Yes, Chennai, please go ahead.
I have one doubt, sir. In this,
Sir, a question from Nagpur, if I may.
What we feel is we feel difficult for maintaining the rotational because of the contouring of the plate doesn't sit in the posterior aspect. So we thought in those cases, can we put the medial plate first and then go to the posterior plate? How do you go?
Yeah, so you're asking me which plate you want to put first, whether a medial plate
because
first?
of the rotation.
Because of the rotational element, yes. So, yeah, this is a good point which you make. If you feel that your cortices are not oriented enough to give you a proper rotational element, you can put in a small plate to get your rotational position right and then put the longer plate. But remember, here we are doing it in a prone position with the with the hand hanging downwards. So there's very little chance of it to have a mal rotation, because if you mal rotate, your forearm will also rotate in the wrong direction. Your humerus is stabilized proximally on the pillow and the distal gravity is stabilizing your distal fragment. So very unlikely that you will go wrong in rotation, but your point is well made. If you feel that one cortical alignment or one pillar alignment is giving you better rotation, you can use that small plate first and then go for your additional fixation. Just ensure that this small plate is not causing distraction. So when you're putting your final plate, there should be some amount of compression, and this first plate is not obstructing that compression.
Yeah, Nagpur, please go ahead.
Yeah, thank you, sir. So two questions regarding placement of a split fibula as an onlay graft. Is so should the periosteal side be facing the bone or outside, or vice versa? Is there any difference regarding that?
The medullary.
Yeah.
Okay, go ahead.
And the second question, while placing the inlay fibula graft, it's sometimes very difficult to get adequate distraction to get a adequate strut of fibula inside. So any tips and tricks, whether you insert in the distal fragment first and then insert proximally or vice versa, or any tips and tricks for that?
So that's an excellent point which you make, and this is what I was talking when Dr. Satish asked me whether the fibula is a mechanical strut or it's a biological device. So when you have the humerus ends which are close to each other, it is very difficult to push the fibula up and then push the same fibula down. Okay, because once you push it up and you reduce the fracture, there is no place to pull the fibula down. So for that, now what you have to do is push the fibula in one of the fragment and pull the other fragment open. You have to distract it a little bit and try and maneuver this fragment on that fibula, and then use an artery or a clamp and push your fibula up and down as much as it goes. There is a limitation to how much you can push and pull. At some point of time, the fibula will not go, and when you push, it may be more prominent in one fragment and less prominent in another fragment. You should try and put the fibula more prominent in the fragment where the bone loss is there. Here in this case, what we had done is, because there was a void posteriorly, the screw holes had made a big canal, I could pass it like a antegrade from the canal upwards. So that way I could hammer it up without breaking the fibula. If your fibula is too thin and you hammer it quite a bit, it might fracture also. But it doesn't matter. What it is doing is giving you biological stability more than mechanical stability. Another way of ensuring that your fibula goes inside proximally and distally is to make the fibula little smaller than the medullary canal. Then you have a possibility of moving it upwards and downwards using a K-wire or using a towel clip, pushing it up and down, and you have to create that pathway before doing the reduction. So you can use femoral reamers or humerus reamers to create a tract proximally and distally and then put your fibula inside. So that's the trick which I can share with you.
And the placement of the graft.
The placement, the fibula, the medullary part of the fibula should be facing the medullary part of the humerus. So the periosteal cortical surface is like the cortical surface of the humerus. It's facing you or outside. Yeah, so that was, you're right. So the question asked me whether the fibula is a mechanical stabilizer or a biological stabilizer. Because it is moving inside, it is not a mechanical stabilizer. It is. No, it is not moving. No, see, once you put your plate inside and your reduction is there, the fibula will not develop legs to crawl here and there. It is there only. It's not going to move up and down with movement.
Sir, in case of in an unfortunate situation where you find infection and you have to convert it to muscle, you said that you will use flexible nails. So what is the sequence you put the flexible nail from top or from the condyles, and then after you put it before solidification, or you during the solidification, how do you do it?
The sequence is to get your entire area debrided, clear it of all granulation tissue, you've reamed, then you pass your tens nails from below upwards or above downwards as available, and then you fashion the cement around it. First you pass the nail and then you fashion the cement around it.
Harshad, you
Sir, I
said
have a question. On hai nahi hai? Sir, a question from Bhopal. Can you
Yes,
listen me, sir?
Yes.
Hello, sir.
Yeah, I can hear you.
Yeah, sir, you use inlay graft, and there is a hypertrophic kind of non-union.
Yes.
But sir, suppose if there is a atrophic type of non-union, where the vascularity is already compromised, and it is clearly proven, sir, that there is a lot of problem with the inlay graft in incorporation. Matlab, onlay graft is much better than inlay graft as far as the bone incorporation is concerned, sir. So if we can do the 2-3 centimeter shortening, so in case of the atrophic union, will it be better to do a 2-3 centimeter shortening, put a cancer graft and then fix it? Or
So I do agree with you that onlay graft, because you're going from the normal area, bypassing the atrophic area and then going to the normal area distally, an onlay graft will incorporate faster and much more securely than the inlay graft or the graft which is inside the medullary canal. But as I said, when you're using a fibula and you're splitting it into two, you have the mechanical advantage of having both onlay as well as inlay. If you're not fond of doing an inlay, what you said is right, you shorten that much of humerus. The atrophic part, in any case, you have to excise. You can't leave the atrophic part there. So in that case, if you can shorten, you shorten it. If it is shortenable, matlab 2 or 3 centimeters, if it is a larger segment, then that intervening segment has to be filled either with a strut fibula in its entirety without splitting it into two, and then you do a dual plate fixation. Now this requires a longer degree of time for healing, because you have an intervening segment of bone where vascularity has to occur, the bone has to incorporate at both ends, and then the entire fibula will be incorporated into the original bone. Such patients you have to keep very careful watch on. They might break at the fibula, they might go at non-union at one end. So these are difficult cases and they need to be tackled, is as a long term. It's not a one-time surgery for these people.
Right. If there are no other burning questions, thank you, Harshad. And that was wonderful discussion we've had here. Let's move on to Dr. Prashant Kamble and on to the elbow from. उसका वो बाद में करेंगे ना. So we now move down from shoulder to humerus and now to elbow. And we've got Dr. Prashant Kamble, who is an expert in elbow and wrist and hand surgery from the KEM hospital in Mumbai, and is also a consultant surgeon at the Reliance Foundation Hospital. Over to Prashant.
Okay, so moving to soft tissue around the elbow.
So I'll be having multiple videos, so we'll see if the time permits each of them. So this is a lateral ulnar collateral reconstruction with the tendon graft. So this is the patient who works at our hospital. He had been diagnosed with something like a tennis elbow. He took already 3 cortical steroid injection, and with every injection the pain is reduced, but again it starts after some time. So this time he felt some pop, and he came, something is not right. So we saw him throughout the range and everything. We did the examination. So this is very something, the important thing that you should know, that it is not the tennis elbow, but something else that requires a high index of clinical suspicion and the thorough clinical examination. So what I'm doing is a posterolateral rotatory drawer test for the elbow. So for last almost now, it's been like 20-30 seconds, I'm not doing anything to the patient. I'm just talking to the patient, making him more confident, more relaxed, and after almost 40 seconds, I'm doing the test. See, my left elbow, my left wrist hand is holding the distal part of the elbow, and with the right hand, what I'm doing is posterolateral the test. Now, patient is saying something is knocking there. What is actually, it is the posterolateral dislocation of the radial head. The radial head is getting subluxated, and patient being more and more relaxed me to do this more prominently with just one hand. I'm not holding the distal part now, I'm just moving the proximal radioulnar joint. And he's saying, yes, something is knocking, that is actually a radial head grinding against the capitulum. So my elbow holding the patient's hand, forearm supported, and almost after 30-40 seconds, I'm confirmed clinically this is a posterolateral instability. So again, same, you do the investigation, and here you see that LUCL and with some part of the common extensor is completely torn off from the humeral attachment. So this patient had now lateral elbow pain, unstable elbow, and some part of the elbow because of the repeated instability that has become the arthritic. So 3 things to be addressed. So this is the patient position. The operating surgeon sits in front of the elbow, your assistant on the right, and the scrub nurse on the left side, and rest other monitors, whatever you need, you can keep on the opposite side. So this is the surgical technique. Patient is under block, and you mark your incision lateral epicondyle, and starting from there you go towards the subcutaneous border of ulna, approximately 7 to 8 centimeter, depending on how much exposure you want. So you go between the ECU and Encunius as a Cocker interval. Once you find the interval, you extend the elbow, you can get a relaxed Encunius, and you can get a more proper interval. Once you are in right interval, you will find a good plane. You will not be dissecting out the muscle. It is the interval between the muscles, so it will go easily. This is like a cold patient. When you have a traumatic, something like terrible triad, you just incise the skin and everything will, hematoma will give you the plane. You don't have to find out the plane. So now try to expose the ulnar border. Capsule is already fired because that's what is contributing to instability. And moment I see inside part of small, there is a cartilage defect, very small in the ulna. So since this was a deficient, so we harvested the palmaris longus. You need to check that preoperatively. Most 20% of the patient, they don't have the palmaris longus. You need to prepare for another graft, either hamstrings or whatever the source. So this is an animation where you prepare your ulnar tunnel. So you start at the distal part of the ulna, where exactly your anatomical location of lateral ulnar collateral origin. So make a 2 tunnel with a good amount of bridge between these 2 bones. Start posteriorly passing the graft. exit through the anterior and then come into the humeral tunnel. So what graft was going posteriorly in the ulnar tunnel will exit anteriorly in the humeral tunnel. So I'll repeat this in the next coming few more minutes. And then you tie over a bridge of a bone by docking the tendons. So that is a ulnar tunnel preparation. That was the distal part, and this is the proximal. Keep a good adequate bridge of a bone between these two. Connect these two tunnels. Make it a big hole. Otherwise, it becomes difficult to pass the tendon graft, or you may struggle in just passing that graft itself. So you have something, a suture lasso or whatever is available at your end that makes you to transfer that tunnel. So humeral preparation. Now how to find the isometric point, where exactly is the humeral attachment? Once you have a torn, some remnant, that is one guide that will tell you this is the humeral part, and how to check the isometric point. Because if we want that anterior and posterior band, this is like anatomical reconstruction. So with the elbow flexion and extension, it should stay stable. So you keep your suture at the isometric point. Take the elbow through the range of motion at elbow 90-degree flexion. The anterior band looks quite taut, and keep the same tension with the extension, and the posterior band also looks tight. So that is again you find your isometric point. So then just pass your graft. Palmaris longus is quite strong enough, and a small size also adequate enough to mimic the graft. So that posterior end exited through the anterior. Now the anterior part will exit in the posteriorly in the humerus. So you mark which part of the tendon will stay in the bone and the part of the suture which will exit, and you just make a knot there and it will stays. So look taut. So start passing the tendon through the humerus, humeral tunnel. So again mimicking the same what we did with the sutures, finding the isometric point. So the tendon which exited in the humerus from the anterior part of the ulna, that goes posteriorly, and the other end goes anteriorly, and you make a bridge over a bone. So that is one end hitting the forceps. So you have a good entry point at the humeral tunnel. So you just hit the forceps. That's a one end and another end. So that I'm just doing what is like, drilling that small cartilage defect, expecting to form a small fibrocartilage there. So this is again very important step. I don't want my graft to be intra-articular. So whatever left the remnant of posterolateral capsule, you make a provisional stitch so that graft can be imbricated in the capsule. So graft stays extra-articular but imbricated in the capsule. So this additional will also add on to the stability of posterolateral corner. So those two vicryls holding the capsule. So take out the anterior end of the graft, dock it. Now pull the tendon which was there in ulnar tunnel. Now the anterior part is docked, the suture is out, tendon is within the bone tunnel. Now mark the other end which will stay in the bone, and remaining tendon you can cut. So again, as I said, you will find difficulty in passing the tendon because the graft size and everything should match. Once you've done that, So you pull, I think I've released the tourniquet here because time was exceeded, and pull. The other tendon is also docked. Now this is what I told. Graft should not become intra-articular, should out, stay out, and here you tie those capsule. Once that is done, you just tie the other end of the grafts. Now take elbow throughout the range. Check for the stability. The range is good, pronation, supination is good, there is no overstuffing. And what we did pre-operatively, repeat that intraoperatively as well, once you've done that posterolateral test. So this, it's a good, stable, and you just close the wound. So post-op 3 weeks immobilization, patient start with the range of motion, hinge elbow brace. Once the 3 months are over, graft is stable, everything is taken, you can start with the strengthening or the athletic activity, whatever the patient's preoccupation status is. So it's got a good range post-surgery, full of a flexion, extension, and a good pronation and supination as well. So barely visible scar if you do a good closure. So again, this was actually a iatrogenic. Don't inject too many steroid thinking that it is a tennis elbow. So that is what I have. Thank you.
That was absolutely fantastic presentation from you, Prashant. Hello.
Yeah, that was a fantastic demonstration of lateral ulnar collateral ligament. I don't think I've ever seen an LULCL being repaired before. Open to the house over here in Bombay. Any questions? Yes, sir. Please go ahead.
Graphically show how you make the two tunnels in the central rotation.
So you start.
There is a diagram. Yellow. Here is that.
Achha.
Yeah, pen है ये रहा पेन इधर भी है उधर भी है.
So you imagine now this is a humerus, and this is the ulnar. This is like a lateral view. Okay, so your ulnar tunnels are here, and this is your humerus. So isometric point, as I've told, you will get some remnant of the LUCL there. So that is one way to find it out. So you start from here and drill it anteriorly and drill it posteriorly, or you start from here and go towards the isometric point, or from here posterior to anterior here. So you start your graft passing from here, that is one, through the bone, exit through the anterior, then enter in the humeral tunnel. So this part goes posteriorly, dock it here. Now you measure how much you want this part of the graft in the tunnel. So you mark here, and you start tying your sutures here and exit that anteriorly. So your tendons will stay in the bone and your sutures will be out, which you can tie a knot here. So that is an isometric docking of the tendon. And you adequately, you've done the tensioning and everything, you check the posterolateral.
Prashant, is there a way of identifying the point on X-ray? The isometric point, intraoperative Siam view?
But it is visible.
It is visible when you open always.
Yes, yes. You can use, but again, you are completely rely on that, and I feel that's too much of crushing of the tendon within the bone, but all the ACLs or anything is done.
Your grafts are short, so they are inside the canal. Your are only tying the suture outside.
Yes. So
Okay.
the graft should stay inside the bone, that
Okay.
where it will heal.
So you don't tie the graft over the graft from both ends?
No.
Okay.
Yeah, any questions from any of our centers? Guntur, sir, unmute yourself and we'll be happy to take questions. Chennai?
From Guntur, what is the diameter of the tunnel, sir?
So ideally that you have to measure the diameter of graft. So that can varies anything. So it is always advisable little bit oversized, because if you undersize, you will find difficult and struggling to pass the graft from one tunnel to another tunnel. Humeral tunnel always make little more wider, which I have shown in the video also with the widening of the humeral tunnel.
So question from Bhopal.
Yes, please go ahead.
Yeah, so for humerals part, instead of making tunnel, can we go for by using some suture anchor or maybe a knotless anchor for fixation of the graft at the humerus end?
Theoretically, yes, but that will not mimic like a anatomical reconstruction. So the graft should go within the humeral so that you can have a control on how much you want your graft to be inside. But yes, yes, you can do that.
Yeah, for knotless, I think so we can use some 20 or
Yes.
25. Yeah, so I had
Yes.
one case where I used a similar technique, but instead of making a tunnel, I just put the knotless anchor there. So
You can.
yeah.
Sir, question from Gwalior.
Yes, go ahead.
Sir, in this ulnar collateral ligament, you have reconstructed both anterior and the posterior part of the collateral ligament with the
Yes.
same. So it was unstable in both with both ligaments, or it was mostly we find it is usually anterior part which is torn off.
No. See what is, as I said, the doing surgical technique is just a technical part. To diagnose is very important. So you must know the anatomy very clearly. Like the LUCL, it has both anterior band and the posterior band, and each band contribute to the stability in elbow flexion and elbow extension. So that was a anatomical reconstruction. So you should mimic what is the anatomical structure, anterior and posterior. It is always both the things which will be contributing to the stability. On that part of it, the posterior capsule also will have an additional role of stability.
Prashant, what is the post-operative mobilization?
So 3 weeks I immobilize this patient in above elbow class, the plaster, and after 3 weeks I will start with the hinge elbow brace so that the elbow become till the 3 weeks capsule healed. For the ligament to heal, it will take additional another 6 to 8 weeks. So with that, we start the elbow range with the hinge elbow brace with the flexion and extension. I don't allow to do them this action, the forward thing, because the elbow will be anchored and it will be a little stress on the reconstruction. So with elbow flexion, extension, overhead activity, and at the end of 3 months, we can start with the athletic or the weight training, anything that patient wants.
Yeah, Gwalior, any more questions from your end? Yeah.
Yes.
From Jodh.
Yes, please go ahead, Jodhpur.
Sir, Prashant sir, what
Yes.
will we you do in acute scenario? This was like late and you reconstructed using
Right.
tunnels from,
So repair
an acute-
in acute scenario. You will find the ligament. There you can just pass a suture anchor and just suture it back.
So are there more chances of stiffness or something you have seen in acute
So
cases,
that
or whether
any elbow patient you are operating or touching, you have to explain. Elbow is such a shy joint. Even if you say high to elbow, it will show you 10-20 degree of flexion deformity. So that you have to explain by default to whoever is your patient that there will be some amount of flexion deformity.
so is there some literature which says that we can delay and then reconstruct? Which will be better, whether to go repair them in acute or later on go reconstructing them?
If you have diagnosed acutely, repair. If you have missed something like this patient where everyone was treating him thinking that is a tennis elbow, then you will have to reconstruct.
Lovely. Okay. Thank you very much, Prashant. That was very, very enlightening. We now move on to the next presentation. That is Dr. Sangeet Gawhale. He is going to talk about the humerus posterior approach and fixed plating. We step back a little to the shaft humerus from the elbow.
Thank you very much, President sir,
According to
the
your
convener.
will be open from now until 3 o'clock. March है चले जैसा आपने जने भी जरूर बोला.
Can we start? The shaft, what are the anatomic consideration what you require when you're doing a posterior approach for the humerus fixation? It extends from the proximal border of the pectoral major and it inserts at the supracondylar ridge. And the spiral groove is contained on the posterior surface. So the approach is simple, where you take a posterior midline approach. The incision can start right up to the posterior division of the axillary nerve, or the axillary nerve where it curves and comes out from the quadrangular space, and you can go down which is about 8 centimeters from the acromion posteriorly, and you can go down right up to the olecranon fossa. So that is the extent of humerus which you can expose when you are doing a posterior plating. Once you open the skin and the subcutaneous tissue, on the medial side you have the long head of the triceps, and on the lateral side you have the lateral head. Underneath the long head is the medial head of triceps. Now, when you want to start dissecting, the best is between the two heads, the lateral and the long head proximally, just below the quadrangular space. And you have two important structures there, the radial nerve, which is going to come in the spiral groove, and the profundi vessels. So while dissecting, you have to be very careful, and that is the only plane, intermuscular plane, where you don't require to incise anything. And then you follow with the finger you can separate that internervous plane or the intermuscular plane, and then open the interval between the lateral and the long head, come down distally where you have to incise the muscle, and lower down will be the aponeurosis which you have to cut. So once you go on dissecting distally, you'll have to follow the neurovascular bundle, that is the radial nerve, where it lies in the spiral groove. Distally, the aponeurosis has to be split if you have to reach, if you have a lower third humerus fracture. So once you start separating, you will be directly on the belly of the medial head of the triceps. You can reflect it directly by splitting it or erasing it from the medial side and then elevating it down. So the release of medial head of triceps from the bone should be done only in the area where you want to put the plate. Rest of it you can keep it intact, otherwise 76% of the humeral shaft is accessible via this triceps splitting approach. Now, where do we put the plate? The humerus has an anterolateral proximally for proximal fractures, a posterior and a medial surface. Complex reconstructive procedure on which a plate can be applied. So most of the mid shaft you require a posterior surface which is flat, and you can put the plate easily. More distally, where it forms a supracondylar ridge, you have to extend it distally, and similarly proximally you can go right up to the quadrangular space. The reduction part I'm not. Any questions till now? The extension of the same approach when you go down is a Garvin's approach, where you reflect the medial triceps, medial head of the triceps from the medial intermuscular septum, and then you have a exposure, reflect that laterally, and then you have a exposure of the entire humerus. नहीं ये नहीं है, बंद करो. पेन ड्राइव खोलो, पोर्टेबल डिस्क, सॉरी. बड़ा दिल है तेरा. कोई मोहंती साहब रहते तो हाथ नहीं लगाने देते.
SSDH correct.
Problem is in the SSD.
हे लैपटॉप नाही compatible.
So thank you, Prashant, for allowing me to touch your precious laptop. So with this exposure, you can have almost 76% of the humerus visualization. And when you are actually handling such combination, one has to be very careful. So once you are you doing it? Okay. So when you are handling such fractures where there is a butterfly which has a attached soft tissue, one has to be careful in dissecting the soft tissue of this butterfly fragment. You can leave lot of muscles, particularly the triceps which is attached to it. You can see the radial nerve there, which is being retracted not by a retractor, by a glove which is used, a cut glove which is used as a retraction, and distally when it goes inside the muscle, then you can retract that muscle entirely. And then you have to work on the fracture with reduction clamp, pointed reduction clamp, to get an interfrac screw preserving that attached triceps muscle, and then convert it from a 3-part to a 2-part, and then fix it with the interfrac and a neutralizing plate like this, so that the radial nerve is over it, and no, it is not pre-bent.
You need to copy it to the hard drive and then run. If you're running from portable drive, it may be a little slow.
So I'll transfer it to some other thing. Meanwhile, you can ask somebody to present. वापस hang हो गया ये.
So Dr. Pradip will talk about TY elbow fixations without doing an olecranon osteotomy till Sangeet sir sorts out the technical issue in his presentation.
So we discussed the TY humerus fixation without olecranon osteotomy, and why this topic has a separate heading is that because olecranon osteotomy is by far the the standard approach for TY humerus fracture fixation. So but TY, the olecranon osteotomy itself have some problems. We know that this osteotomy, doing the osteotomy has a problem. That osteotomy can kind of migrate in any of the area. Fixation again takes some amount of time in a surgery that itself takes some time, and there can be a fixation related issues such as non-union. There can be some steps and intra-articular steps that may be introduced because of that. That's why avoiding osteotomy is always a kind of a desirable goal. However, since the humeral head, the distal humeral articular surface is hidden under the olecranon, the reduction and fixation can be an issue. So this is the case that we are going to discuss. A youngish male, and he is roughly around 35 to 40-year-old male, and had a RT and had this fracture during COVID. And we're going to discuss the position and all these issues, and it's extremely important because each one of these can has problem. Before I start the video, one thing is the position. It's extremely important. The same patient has been positioned. It's extremely important that you have these two lines. The elbow should be below the level of the shoulder. That is number one. And the elbow should be completely out of the lateral edge of the support. If this thing is not followed, then the proximal part will tend to fall into external rotation, and that can pose a big problem in fixation. So this has to be absolutely followed, and that's why the support needs to be smaller in length, because some people have a smaller arm length. So that is extremely important. The second thing, that we should have a nice square support. We cannot just fold a pillow and something like that, and that will create a problem. So arm should be 90 degree to the body like that, and the elbow should be beyond the edge, and the elbow should be below the level of the shoulder, these things. So we can have a two approach, that is the paratricebral, avoiding the olecranon osteotomy, or with the olecranon osteotomy. So olecranon osteotomy, the gold standard, is give the best exposure, but certain fracture can be managed. However, one should not be hell-bent on olecranon osteotomy. Anatomical reduction is the key. So when can we do is this two-piece fracture like this patient, oblique or spiral fracture where you can get the reduction and assess it very well. Sagittal fracture line which are not in the trochlear groove, because trochlear groove is the narrowest portion. Good bone stock and big metaphyseal fragment. This should be the area where you can do it. Other areas such as interarticular comminution, sagittal fracture line, low fracture of aortic bone, we need to do olecranon osteotomy. In short, Musca case you can do it. In case it's a Manjan case, you do olecranon osteotomy. Sometimes even in Musca case you start having Manjan, you go and do a olecranon osteotomy. So let's go to the case. So this is the case, and this is the CT scan where we can see that the lateral metaphyseal fragment is big. We have articular cartilage and a big metaphyseal fragment. Medial metaphyseal fragment has the epicondyle, and there is a small comminution there, but I think that is manageable. That is not an issue. So that is the after positioning we need to get a CT scan. We get to see that our imaging is clear and nothing is coming in the way of the imaging. And we need to keep multiple clamps, pointed reduction clamp ready, because we never know what will be required on the table. And we require sleeve and most importantly the nice bending pliers. So the skin incision, we need to take straight, and we can curve slightly around that edge of the acromion to avoid wound problem, and then again go straight down. Like that, the skin and subcutaneous tissue is cut in line with the incision till the time we go and see the tricipital fascia. So at this time we see the tricep muscle fascia, and just when we see that thin layer of fascia, we need to dissect medially and laterally. We cannot dissect it above the fascia because that will devascularize the skin and can cause wound problem. So we need to go directly to the tendon. Just above the tendon there is a small layer of loose areolar tissue. In that plane we need to dissect medially and laterally. And this is the olecranon bursa that we need to dissect. And after dissecting it, wait till medial epicondyle and lateral epicondyle. I tend to suture the skin to the tag it to the medial and lateral edge so that the skin tag remain kind of retracted, and we don't need to crunch it, just enough to put back it in place, and they stay there. That same thing that we do medially as well as we do it in lateral and medial. So we take a small bite way medially and at this edge, and that will evert the skin and keep it in that position. Keep the surgical area open, reduces the frustration of the surgeon. Okay, after that we need to, next step is to dissect the ulnar nerve. So the best part of the ulnar nerve visibility is in the superomedial corner. Where you go superomedial, you just run your finger there and you can find that cord-like structure, and that will be ulnar nerve. So now we need to dissect the ulnar nerve. So we tend to do a very sharp dissection of the ulnar nerve. So that needs to be dissected proximally and distally. The question was how much proximally, how much distally. As much possible proximally, no problem there. More dissection will mobilize the nerve proximally. Distally we can see the nerve going into the flexor carpi ulnaris. Till the time it gives the first branching, I would like to dissect it. We can just sharply cut with the cut the muscle with the blade, and that's how we can do it. Okay, so once that is the nerve, we need to dissect lateral to the nerve so that the nerve can be easily pushed onto the medial epicondyle, slightly anterior to it. You don't want to transpose it, but the nerve should be kind of displaceable medial to the medial epicondyle. That much dissection that we need to do. And then we come to the medial septum. Sometimes there can be a bleeder there, so we got that bleeder that can be burst off. Then once that is been done, our nerve is now free and we are okay to proceed the next step. Now next step is to palpate the medial and lateral epicondyle. So I am further freeing the nerve, so that is the nerve. And then I am palpating the lateral epicondyle, so that is the lateral epicondyle. And that is the tip of the olecranon, and just 2 centimeter below the tip of the olecranon. So we need to run our cautery from 2 centimeter below the olecranon till the lateral epicondyle. So that is our cut onto the posterior musculature. Roughly there is the anconeus there. So onto that, and from there we run our cautery along the lateral intercondylar ridge, trying to stay more posterior. Same way we need to go medially at the same point, from there till the medial epicondyle we need to run our cautery. So this is like you are doing a olecranostomy, we're just not doing it. The same cut we will be taking for olecranostomy, but we don't do it. So now we are extending our dissection proximally. So this dissection should be done till the time we see the bone. Very gracefully we can do the dissection, peel off that tricep muscle from the posterior aspect. And we will encounter the posterolateral capsule over there. Onto the humeral side we can release the capsule all the way till we see the cartilage of the trochlea, the lateral edge of the trochlea. So I am doing it, and then we can go up roughly a hand breadth above the lateral epicondyle, where we'll, if we go above that, there will be a radial nerve, so we have to be careful. So we keep on exposing the posterior surface of the distal humerus where our plate is going to be there. So now we can see that we have got exposure. Same way we do it on the medial side. So protect the ulnar nerve. I do not want to put any kind of a cord around the ulnar nerve. I will simply retract it with the finger or the right angle, because that cord sometimes get entangled somewhere and can cause acute pressure on the nerve. So I don't want to do that. But yes, that is being described. Many people like that. So we do the same. Now we dissect it all the way medially again till the aspect till the time we see olecranon. Now here from lateral side and medial side, both the side we are seeing the olecranon articular cartilage. So this is articular. There we are going to see the olecranon articular cartilage, and that is the bare area of the olecranon. The notch there into the olecranon will be the this thing. Now from there I am cutting the posterior capsule of the elbow. It is the same exposure of the olecranostomy, just that we are not doing the olecranostomy. So we peel off entire tricep from the posterior aspect, because that is the place where we are going to put our reduction instrument and plate. So same way we do medially and laterally. That is the posterolateral exposure. We use the periosteum to expose the posterior aspect of the shaft as well. So same way we do on medial side. Now this is the medial side. Intermuscular septum needs to be elevated from the medial epicondylar ridge, and the posterior tricep should be elevated from the posterior side. So at this point, when we have done everything, we can now nicely pass an instrument underneath the triceps, and that is my instrument, and the entire tricep has been lifted from the posterior side, and from the olecranon, the capsule has been lifted. So this is our paratricipital this thing. So at this point I will pass a gauze piece and kind of tug it all the way below and try to pull it. My assistant kind of like it. I don't know to what he relates this maneuver to, but kind of like holding it in that way. Abhishek has a good laugh. Okay. Okay. So that is the next step. Now we pass another. Now this is very important that we need to pass two kind of a gauze pieces, because we need to lift the tricep like this. If you have only one, that will be problematic. So you need two, one proximally and one distally. And now we have got a very good space below the triceps. And that is how we have exposed now. The exposure is complete, and we now see that the lateral part is exposed like that. We can see the fracture site there. We can see the shaft from there, and we can see the medial side also, and we can see the fracture crater as well over there. So this is from lateral side. Same way we can see it from the medial side as well. Now this is from the lateral, so we clear the fracture site, all the debris from there. Now next step is to get an orthogonal control over the fragment. Now our fracture site is visible, so we get an orthogonal control. So we get 3 wires in each fragment. So this wire is going from lateral to medial, and I see to it that it is coming from this edge here, nicely at the fracture site. My direction is good, because I want to project it on that side, so I need to see to it that this wire is good. Next wire is the straight anterior to posterior wire. This is just a holding wire. So this is the anterior to posterior wire, a small wire, and this wire is a column wire. So I have 3 wires in each fragment, the X, Y, Z axis wires. So this is the column wire. This we need to pass right before you try to manipulate the fragment. The instinct is to, as soon as you see the fracture, instinct is to hold it and reduce it. We need to resist that temptation and first get an orthogonal control and prepare yourself for the further reduction stabilization. Now I got nice control, XYZ control over the fragment on the lateral control of the lateral fragment. Now we need to do the same on the medial side as well. So this is the lateral side, that we have got 3 wires on to the lateral fragment, and same we need to do on the medial side as well. So we have 1 wire going medial to lateral through the trochlea, 1 wire, the column wire, this is my column wire going through the epicondyle, and we need to use nice sleeves because we don't want to damage the ulnar now. So this is the second wire, and the third wire is directly bang on posterior to anterior wire, and now I got orthogonal control on medial as well as lateral fragments. So this is the picture at the end where we have orthogonal control on both the fragments, and this is how now the fragment is going to move. So that is now in front of us. This is me moving the lateral fragment, this is me moving the medial fragment, and now I am prepared to do a reduction because all my controlling wires are in place. Now we move this fragment and kind of reduce it, and once we reduce it, we put it with the clamp. Now once I put it with the clamp, what the clamp does is that it will kind of compress it at the articular level, and it may in fact open it from the other side, and that is a common problem that occur, that we apply only 1 clamp, and to avoid that, so this is applying the clamp. So we apply the clamp on this thing and it can open up this thing. So to avoid that, we need to put another clamp at the top. So 1 below and 1 on the top. So we get a circumferential nice compression of the distal fragment. At this point, we can, the shaft can sometimes come in the way, so we can displace the shaft anteriorly. Otherwise, it will come in the way of the fragments. So once that is achieved, now we have this radial and lateral K wire in place. So as soon as we achieve the reduction, we just pass these 2 wires across and we get a nice stabilization. Now we don't need to aim for in what direction we are going to pass because they are already in place. So my wires, and this is how we confirm the reduction. We see it from the posterolateral and posteromedial area, and we can see that the reduction is good. That is why I said that if the reduction is, the fracture is comminuted, then it is not good. But a simplistic oblique spiral fracture pattern, we can very easily see the reduction and confirm it. So this we can confirm from both the side, or whatever side it is best visible, and you can palpate it with the this thing. If you want, you can even take a C-arm. And after that, we just drive through the wires, and this is the C-arm picture, which is a further corroboration that we have driven the wire across, and our reduction is good. Now we can drive it all the way across also, like this, if you want, because then that will give you a good kind of a traction to reduce the metaphyseal area. Now, the most important factor in metaphyseal reduction now is this external rotation of the proximal fragment, and for that we need to use a nice bone holding forceps or a very thick shank spin to reduce that external rotation thing of the external rotation of the proximal fragment, and then we reduce the metaphyseal area with clamps. And then now your column wire also are in place, just waiting for the fracture to get reduced. As soon as your fractures are reduced, we can just drive our column wires up. We do not want them to, to aim that. And then this is the picture that you get at the end of the fixation, that we have 2 wires across and 2 column wires like that. And that's how we have fixed the fracture now moti. So next is placement of the plate. Now it is extremely important that the lateral plate needs to be sitting flush, and that is the problem. Most of the lateral plate, they do not sit flush because there is some rotational element, because the morphology is different for different fractures. So even the manufacturer have told to that you may need to bend the lateral plate. So you need to bend the lateral plate little bit to kind of make it sure that it sits, because this plate has this flange, and if the plate is not sitting well and you tighten the screw, the flange may fly off. Two problem it may cause skin problem, and it may, the screws that are going to the flange may not go in adequate direction, in proper direction. And that's why the plate needs to be sitting very nicely distal fragment like this, that it should be 3 millimeter away from the distal end of the articular cartilage, just by the side of the lateral cartilage groove of the trochlea, and the screw should be pointing medially. This is the plate, and this point we are pretty happy with the plate position, and then we can fix it temporarily with one screw, and one screw up, one screw down. The medial plate needs to be applied. Medial plate sits little bit proud, does not matter, because this is much more flexible plate. Once you put this cortical screw, that plate get crunched and entire reduction get achieved. After that, we complete the fixation. So you can see that this plate has been slightly bent here to make it sit properly, and then after our fixation is complete, and at the end of this thing, since there was some place, I have passed one fully threaded screw. Since the fracture is already compressed, we can pass a fully threaded screw, and that is the end. And the closure is pretty simple, because you have not done olecraноstomy. It's just the simple facial closure, and that is the picture, and that is the follow-up at the union. This patient has decent quality of range of motion. He's back to his waitressing waiter occupation. So issue is, if you have comminution, so what to do with if you have to do with olecraноstomy. So look at this case, we have comminution, and same way we need to expose. Only one thing we need to do is that we need to release the anterior capsule of this fragment. So in this case, this comminution was there, this trochlear piece was lying anterior, that we retrieved to the fracture site. But now how to fix it, because it is anterior. It is anterior, and we are not seeing anterior part, because we are seeing posterior, right? But we can release the anterior capsule, and we can evert the fragment. So now look at this. This is the place from where the fragment has come, and now we are everting the fragment underneath the olecraноstomy. We can evert it very well. It is attached to the soft tissue of the flexor, the common flexor origin, so don't worry about that. And then we fix our fragment to that area, to the area from where it has come back, and then retrograde you can pass K-wires. So it is fixed with K-wire retrograde like that to the fracture site, and then we do the fixation same way. Now the fracture is converted into two-part fracture, and you fix it, and on the K-wire you pass the screw, and that's how her fixation is. And this is her at the end of 1 year. They get pretty decent range of motion, because we are not damage any kind of the soft tissue. Sometimes we have very low fracture like this, which can alternatively be managed by paratricipital approach, but going anteriorly rather than posteriorly. And this fixation was done, reduction was done anteriorly, but not a posterior approach, but collateral approach. So we go medially and laterally and fix it in the same way. And since medial laterally, you can put the plate posteriorly even though you are exposed anteriorly. So these are the three ways by which you can manage the fracture without doing olecraноstomy. Thank you.
Nice talk. Questions for Pradip can be taken now. Must. Low fracture. Low is not a must, but yes, it is desirable. Yeah, so the question asked is, in what cases olecraноstomy is a must? Yes. So, if it is an osteoporotic bone, if it is an intra-articular comminution which you think you cannot manage without osteotomy, that is number 2. If it is a low fracture, then this fracture it is desirable to have osteotomy. In case you are starting doing osteotomy, but you cannot manage it, do the osteotomy. Because your threshold should be very low. Remember, articular reduction is the key. Avoiding osteotomy is not. So you must get a reduction. You can get it done without osteotomy, well and good. Otherwise, do the osteotomy and go ahead. By far, olecraноstomy is the gold standard.
Pradip, we've all read all the papers from Sean O'Driscoll, where he's talked about putting screws through the plate, both sides, going across all the way to the opposite side so as to interdigitate the screws, and longer plates on both the pillars. all these three things were not present in your stabilization. Can you like to comment on that?
Yes, sir. So there has been a revolutionary changes in the management of the TY, the distal humerus fracture, with the advent of well-contoured locking plates and the small diameter multiple screws. So the previous commandments for TY humerus fractures were that we need to have interfragmentary screw. There, all the screw needs to go to the plate. Preferably, there should be column screws, and the screw should be, inside that the medial plate use the lateral screw. Lateral will use the. Yes, if the screws are going in that direction, well and good, you can do that. But if you are using a nice kind of a fixation, these two or three screw on the lateral plate is okay. Medial plate you can have 3 screws because they go in a different direction, and that gives a pretty stable fixation. We have not got any problem. But again, the reduction is the key. If the reduction is good, even sometimes smaller plate does the job. But reduction is poor, then it falls apart, because the major part of the biomechanical stability is the reduction.
Yeah, any question? Chennai, you have a question? Unmute yourself, please. Chennai needs to unmute. From Chennai, we can go to Jodhpur for the question, and to Navi Mumbai. Yeah, Chennai, you are ready to go. Please go ahead.
So we also use similar techniques without orthogonal osteotomy, but this orthogonal KY is very, very good guide. So thanks for that. So my only question is, when you use 2 plates, is it mandated to use a bigger one on one side and a shorter one, or both sides same size plate is okay?
No, the recommendation is that the plates, especially if they are going way high, they should be at different level, because you don't want 2 screws at the same level creating a stress riser and causing a fractures. If you are using 2 small fracture for low TY fracture, then it's okay because the distal bone is too big, the screw are. But if the plate is going, let's say 4 fingers above the olecranon fossa, then you need to use 2 different length plates.
So, the third case I saw both the plates are in same size. Is it okay to give them like biomechanically, or is it mandated to use different size plates? That's what.
You mean to say the orthogonal versus the parallel plate?
No. The plate size are like the lateral and medial plates. Can it be both on the same size plates, or you mandatorily need to use different size of plates? Can it be on the same level?
Can it be at the same level? That's the same question you had asked earlier, is it?
That if the plate, like if you see the last, this thing was very low TY fracture. I didn't need to go very high. So in that case, if the plate is, the fracture is very low, we can use smaller plate. That is not a problem. But if you need to go high, then there should be, one should be shorter, one should be longer.
Right, Jodhpur, please go ahead.
Sir, Dr. Pradip.
Yes.
We get sometimes such fractures that we get combination at the just at the distal end of the lateral condyle or medial condyle. So that contoured plate also does not, distal screws are not having hold in that fragment.
Yes.
So what are your tips to manage them?
Yeah, so there are 2 different issues: the comminution at the lateral end and comminution at medial. They are entirely 2 different issues. The lateral end is a very cancellous kind of a bone, and it kind of whirls along with the lateral common origin as well as the LUCL. And if you see the last case which I shown, even after the fixation, there was a big void over there. And that was the avulsion of the lateral LUCL lateral common extensor origin. So you can complete the fixation without fixing that fragment, and at the end of the fixation you can put an anchor or use a transosseous suture to kind of even wrap that area around it, because no screw is going to hold into that kind of a bone. It needs to be seen as if a soft tissue avulsion fracture. Medial epicondyle fracture, on the other hand, has a very good bone, and you can use a parallel kind of a configuration, that new parallel plate that will go and encircleize all around the medial epicondyle, try to get that fragment. However, you may need to kind of, with a very sharp dissection, elevate the posterior half of the soft tissue of that medial epicondyle to get the plate all across.
Yeah. Ahmedabad, any questions from you? I can see you all are unmuted, Ahmedabad. No. Okay. Any questions here from the house? Any further burning questions? No? All right. Yeah, Sudhir.
Yeah, so if there is intra-articular communication such so much so that we cannot put the fragment
Sir,
back in place.
one question is from Gwalior.
Yeah, just 1 minute. He is answering one question, then we'll come to you.
Okay.
So we have intra-articular communication so much so that you cannot put that comminuted fragment back in place. Neither you can like jigsaw puzzle put it back and compress it. Neither you can fix it, put with a screw, and the void remains. So in that cases we can fill up that void with the graft. And if sometimes there is like a 3 different fragment, medial most, lateral most, and the middle part is like chura, then we can kind of put a block there to at least maintain medial and lateral articular cartilage and maintain the width of this, this thing, and you may have to do eyeballing there.
Right. So the worry is in narrowing, compressing the articular surface excessively. So that's why you put a strut graft over there. Yes, Gwalior, please go ahead.
Sir, my question is, can we just use a medial screw in place of plate after putting a lateral column plate and to compression screw through the plate in the intercondylar fracture and a medial screw? Because we have done a study on this type of pattern, fixation pattern, and we found very good results with that.
So if it works means whatever this thing, I have not seen this thing, but I would be pretty interested to see the study, because if it works, it will save one plate. Yes, definitely a desirable option. But again, the predictability of that thing needs to be studied. And if you are studied and happy, yes, that can be done.
Are you worried, sir, in Gwalior, whether the absence of another plate on the medial side, there will be a vast collapse of the...
No, sir. Actually, we put 2 compression screws from the lateral column plate and screw from the medial epicondyle. So it stabilizes the medial condyle is not that much stressed, or you can say though major muscle attachment are there. So it stabilizes with those 3 screws, I think.
Okay.
I think that is pretty interesting concept, but as you have studied and it works, then I think that saves the medial plate, yes.
We move to Navi Mumbai. Any questions? Dharsab? I can see somebody is standing there with a mic. Can you unmute and then ask? You all are muted. Yeah, please go ahead. No, you are still muted. We can't hear you.
Hello.
Now we can hear you.
Sir, Dr. Mangal Parihar sir has also recommended the same approach without oliguranostomy. So what is the difference Mangal Parihar sir's approach?
Same, paratricipital approach is same.
It is the same. It is not Mangal Parihar approach. It is a well-described approach in textbook called paratricipital approach, which also Dr. Mangal Parihar does.
Okay.
Thanks. And Pradip, how early you mobilize? Because intra-articular should be on...
Immediately.
So that is the basis of fixing both well.
Bhopal, any questions from your end? Nagpur? Yeah, you'll have to unmute yourself, Nagpur. No, you are not. Please go ahead.
Hello.
Yes.
We first appreciate that even the Manjan cases look Muska cases in your hands, sir. I am tempted to ask that in case of actual Manjan cases, can you give some tips on doing an ideal osteotomy and ideal way of fixing it?
Yeah. So as I said, the approach here, paratricipital approach, is just short of osteotomy. All your preparation should be such that that you are just about to do the osteotomy. So the convergence of the medial and lateral incision is 2 cm from the oligurine tip. That is from the outer aspect. From the inner aspect, we need to see that that convergence is at the bare area of the upper and lower part of the olecranon articular surface, where the articular surface is the narrowest. At that point, we can do osteotomy, and I do not use saw, I use the osteotome. I make small drill holes and osteotome to do it, because saw causes bone loss, and when we try to compress the fracture site, kind of opens up, creates a kind of dorsal closing wedge osteotomy. So to avoid that, I use multiple drill holes, and in between the drill holes we pass the osteotome and just gently crack it, so that we do not go inadvertently stray on the upper or lower half of the articular cartilage. But if you see that video which I have shown, we need to literally see the bare area of the olecranon. The osteotomy has to extend there. A too small osteotomy will just avulse the triceps and cause problem in visualization. Too low osteotomy can cause instability. So to avoid that, the osteotomy needs to be perfect exit at the waist of the olecranon. And it is the paratriceps approach is just short of the osteotomy. In case any problem, just do the osteotomy and go ahead.
Okay, thank you, sir.
That's great. Yes, any more questions? Gwalior, I saw you raising the mic. Was there a question in your mind or no? All right. Anything from Guntur? No? All right. Thank you very much, Pradip. As you said, that even difficult cases look like muska in your hands. What the gentleman from Nagpur didn't know was that we only show muska at the end when things have become muska. Whatever is not muska, we never show. Anyway, we move on to the next case, and we've got Prasad Bhagunde, who is going to talk to us about reverse shoulder replacement, which is nowadays become the go-to shoulder replacement surgery. And for practically all kinds of pathology, I think the only place where it is contraindicated is in a patient who has absence of deltoid, or if there is an infection already existent. Otherwise, reverse shoulder seems to be the way to go, and you'll see a very elegant demonstration of that over here.
Thank you, Dr. Gautam, Dr. Harshad and the BOS for this. So as the schedule, what was decided, so we'll have a quick case discussion for about 2-3 minutes, and then I will go with the video presentation. Okay, great. Okay, so I'll just start with the case. Then we will go to what I did on the video and the discussion. So 74 female, pain for 6 months. A typical, this is how it came, how the X-ray was there. And this is what we divide. So if you do an X-ray, as I tell you, this was a rotator cuff tear. I'll come to the details, but this is what we expect to see on the X-ray, what's happening to the X-rays over there. The MRI showed a large cuff tear, about 2.5 centimeters, with significant atrophy of the supra and the infra, and there was no arthritis. That's how we kind of evaluate the patients for looking for the muscle atrophy and the fatty infiltration. And a lot of these patients also undergo CT scan if there are any changes on the glenoid or the humerus on the bony side. So this patient had a normal CT scan. And this is how we evaluate the patients for any kind of pathology we are looking for. So we also do a Walsh and a Favart classification to look what's happening over there. So this patient had a large 2.5 centimeter cuff tear, and this how is we decide whether tear is repairable or non-repairable. So there is not a single criteria for this, but we can mix and match, and depending upon a particular score, we can decide whether this tear is repairable or not repairable. We can also decide the similar thing on your clinically and on radiologically. So if you have a patient who you are not able to do a tension-free repair of the cuff on your footprint, that's a arthroscopic way. And if you have got a very large cuff tear with significant atrophy and muscles and tendons, so that's your clinical picture. And also radiologically, we can determine if you have got, you also have a pointer there? Pointer. So you can also do it pre-operatively on your X-rays, your CT scan on an MRI to decide what's happening to there. So this is the way we can probably decide whether it's a repairable, non-repairable cuff tear. So that's my algorithm. So that's for the arthroscopic surgeons. And if I have got a non-repairable tear, and if you have an arthritis, it's straightforward reverse shoulder. And if it's absent, and this is about younger patients, then this is how we decide whether we're going to do an SCR or a tendon transfer. So that's a very specific, so every shoulder surgeon knows this is a very standard approach for a cuff tear. Okay, so I'll quickly go to the case what we did. And I can forward this? Yeah, but I can forward it there. Okay. So quickly I'll start with the case. A standard deltopectoral approach. We also sometimes do a superior or lateral approach, but a deltopectoral approach works very well. So once you have this approach, the first thing what you need to decide is what you do with the cephalic vein. You can take cephalic vein laterally if you're doing a glenoid surgery. But if you're doing a kind of a humeral surgery, you take the cephalic vein medially. So I'll just take interval pauses and I'll explain what I'm doing. So I'm going to put a spike over there. So you understand all these patients, they are patients, they are having a chronic, they also have a capsulitis, they have a lot of adhesions over there. So you need to do a lot of those subacromial release, subdeltoid release to get your spikes over there. So once your deltopectoral approach is done, you have your cephalic vein isolated. It is very important to understand the anatomy of the proximal humerus. So let it be reverse shoulder or any kind of proximal shoulder surgeries. And if you're going to do a lot of work on the proximal shoulder, it is very important to understand the proximal humeral anatomy. So I've just briefed what you need to be seeing, where I'm rotating the humerus. So that's your conjoint tendon, the coracoid process, and your CA ligament. So once you know this anatomy, what's lateral, what's medial, you can quickly start opening the shoulder over there. The second part is to identify the clavipectoral fascia. So you need to release your clavipectoral fascia from the lateral part of the conjoint tendon. You come all the way down, you don't incise, but you excise, and you come all the way to the lateral part on the subdeltoid space. I feel this is a very important step, like how Dr. Pradip mentioned, releasing that fascia part over there. So get this clavipectoral fascia out. And this actually opens your internal structures on the shoulder. So you just release some more clavipectoral fascia. That's your pec major. And you release your conjoint tendon and you start going more medial now. You understand that because you're dealing with a reverse shoulder arthroplasty, the importance of CA ligament is not there much. And you start releasing a CA ligament. This allows your more inferior translation of the humerus, which is important for your reverse shoulder. So you always keep on seeing where are you there. The next step is to identify the workhorse of any of the shoulder surgeon is a biceps tendon. So you release a part of the pec major. Once you release a small part of the pec major, that's your pec major there. And that's your biceps tendon. So you can use a mixture or an artery to deliver the biceps tendon. This is very crucial for any of the shoulder surgeries. Once you have identified, you run your cautery all the way proximal on the superior aspect of on the anterior aspect of the biceps tendon, and you go all the way to the shoulder joint. So if you see, the biceps tendon leads all the way to the shoulder joint, and this biceps tendon will allow us to identify the space between the GT and the LT. So that's what we have done over here is that we have released the subscap bursa now. The first was the clavipectoral, now this is a subscap bursa. Once you release that subscap bursa, you identify your three sisters. So get this anatomy right over there. So you identify three sisters, that's getting rid of the subscap bursa. These are the anterior circumflex humeral artery and the vein. So once you identify this, so proximal is the subscapularis, these are your three sisters, and down is the axillary nerve. So this is the landmark, so your dissection should not go below this point. So this will also help to identify what is the lower extent of your subscap incision, and you are quite far away from your axillary nerve over there. Once you have done this, you need to deal with your subscap tendon. So even if you're doing a hemi shoulder or a total shoulder or any kind of surgeries where you're going to require subscap, we also preserve subscap in reverse shoulders now. So this is the way how you are going to release your subscap. So you can release your subscap in multiple ways. You can do your subscap split, you can peel, or you can do a lesser tuberosity osteotomy over there. Majority what is accepted is the subscap peel. So release your subscap, go all the way till the rotate interval where the biceps tendon was there, and inferiorly till the anterior circumflex arteries, and then your humerus is delivered out. So once your humerus is delivered out, every shoulder surgeon or someone who is doing kind of cuff repairs or doing reverse shoulders will understand the next important step over here is the identifying the posterior inferior cuff. So if you see, that's the humerus there, articular surface, that's the tuberosity, and that's your posterior inferior cuff. So if you don't have this cuff tissue available for whatever reason, your reverse shoulder is not going to be successful. You will have an instability post-operative. So the next step is to identify your posterior inferior cuff. So you should have some tissue of infraspinatus and teres minor present. They are always there in majority of cases, but you need to go and see them. And if it is not available, probably you need to change your plan. So once you have done that, you have done all soft tissue releases, you do some more soft tissue releases down, you get your inferior capsule out, you remove your remnant of subscap. The next step is to how are you going to enter the humerus. It's very simple. You identify a bicipital groove, you go about a centimeter posterior and medial, and that's the standard approach what we also do for our humerus nailing. So it's standard, you go there, you start with a small K wire, then drill it and go over the inside. So set on that, you start using sequential reamers over there. So you can use your 5, 6, 7, 8, and whatever reamer you're getting the best fit. Like example, you're doing a hip surgery, how you get the best fit over there. So that's your humerus size, you're going to accept it. And once you get that humerus, you reach to that marking point which is there, already there on the implant. You get rid of this handle. And this is your humeral cutting jig. So get this cutting jig over there. So this is typically 135 degrees. We also have 145, 155 available. What you use typically is 135 degree. You get your sleeve over there. You get your wires specifically between your articular surface and non-articular surface. This height adjustment is very critical. We don't want to go too high so that you don't want to have a tight joint at the end of the surgery, and you don't want to go too low, because if you go low, your probably chances of cutting your rotator cuff tissue is very high. So get this humeral head out. Definitely this was a non-arthritic humeral head we were doing for a large cuff tear. But once you have done this, you get your humeral out. Whatever remnant of bones at the inferior and the posterior aspect is removed, so you have a flat surface over there. So once you have done that, the next step is glenoid exposure. So is the glenoid exposure. It is important to identify where are you going to put your retractors over there. So you are going to have your fucodas at the back of the glenoid. Your anterior spike retractors, the TCAR retractors over there, you're going to have a playboy over there. So you're going to have these 3 specific retractors exposing your glenoid. So once you have a glenoid exposure is done, the next step is to identify the right entry point on the glenoid surface to enter the maximum bone at the glenoid vault. So over here, so you can just look at the picture in the left. So that's your glenoid picture, face view. And the entry point is, so we draw a vertical and a horizontal line on the glenoid surface. And the best point is about 2 centimeters posterior and inferior on the glenoid, which gives the maximum approach to your glenoid vault. So get your wire inserted. At this particular time, I always use I use a C-arm. So I use a C-arm over there. That's the glenoid surface. If I see added about 15 or 20 degrees of superior inclination or inferior inclination over there, go about an inch inside, and I try to also get hold of the medial anterior cortex of the glenoid. So if I'm having a good hold over there, you start sequentially reaming. There are 2 kinds of reamers which are typically used. One, we have an internal reamer. This reamer is used to get rid of the cartilage over there, and and also having a good smiley appearance over there, kind of called a smiley face, and then use an external reamer to get rid of the soft tissue. The next step is your glenoid base plate. So these are various kind of base plates available. So over here, because the glenoid was not affected, we use the standard 4 millimeter lateralizer base plate. So these are different kind of base plates. You can have base plates which are no lateralization, 2 and 4 lateralization. We can also have base plates, some companies make to up to 6 and 8. You can also get augments over there or wedges over there depending upon your glenoid retroversion or bone loss. So this was the standard glenoid. I used a 4 mm lateralizer. So once you've accepted the base plate, this is the central screw. So this is the central screw. Because I reamed about 2.5 centimeters, I'm going to use a similar size central screw. You have this kind of instruments available to fit it. So they become 1 inch, one block over there. So that's a specific reamer for the central screw. So once you have reamed that, the next step is very, very crucial for any reverse shoulder surgery. This is the most important crucial step. So you're going to go very slow. You're going to use your C-arm as your guide, and you're going to use this device to hold that base plate. This is where the maximum problem can happen in these kind of older patients. Always use a C-arm there. If you see, I've added that inferior inclination there deliberately. And then once you have done that, then that's the next step is to where are you going to insert your screw. So you have 4 screw options in this particular implant. And if you see, we don't keep the base plate right 180 over there. We keep it slightly tilted anterior so that we get this good screw position over there. So we aim to pass 4 screws. 1 screw, the superior screw pointing towards the coracoid process, the inferior screw towards the inferior spine, and the anterior posterior screws depending upon how is the width of the glenoid. The next step is that once you have got the humeral head out, we check the size. It's not the width, but the diameter of it, and we use the best fitting glenosphere over here. We tend to go to a little larger size glenosphere as against the hemi where we'll go smaller size, but I will tend to go a little larger size glenosphere over here, a size above. Once you have decided you're going to use a 33 or a 36 or a 39, you are going to use that glenosphere, and then this is a soft tissue, that's a soft tissue reamer where we take out all the soft tissue. If you see, that's a trial glenosphere what we've inserted over there. That's only single size, but the final ones are of multiple sizes. So if you see, that's what the glenosphere is there. It's a various cut of different sizes. So this is a half circle, this is less than a half, this is more than half, and that's again more. So that's, you can decide what cut of the circle you are going to use to increase the lateralization. So once you have done with your trial plastic fixation of the glenosphere, you can just use the screw to fix it temporarily. The next step is your humerus. So 2 things in humerus. One is your humeral cut, and second is the version, whatever version you're going to do. The most common version what you use for the patient is about 20 degrees, but it's not universal for reverse shoulder. You can use version as low as 0 and can go to 40 depending on what is the demand of the patient. Generally it is said for the left side we require a lot of perianal activity, so that we can use about lesser version that we want more internal rotation, and for the right hand side we want more external rotation and we can increase the version. The second aspect is that we now have shifted from 155 original Gremont to about 135 degrees. So these are the two things on the humeral side. So once you get your humeral implant inside, you get your trial implant inside over there. So that's the second thing. Once you have got an implant, you have to decide are you going to use an inlay or an onlay component. And inlay component is where the liner stays away, but the implant goes completely inside. And in the onlay component, the component is proud on the humeral cut surface. Both has got advantages and disadvantages. The system over here is a flush lay system, which is a midway between the onlay and the inlay. So once you have done your reaming over there, you put your final liner of the implant of the humeral and do your trial reduction. This is a little difficult in reverse shoulder because definitely the glenoid is too large to accommodate this. So you give a lateral traction, give an inferior traction, and then you try to push your implant there against the glenosphere. Once it is reduced, you can check for the stability. You do something like a shuck test. You do a bed shuffle test and a lateral humeral distraction. So once you're happy with that, you do a shuck test. You try to do multiple maneuvers over there. So once you have accepted a trial implant and you're happy with your glenosphere size and the lateralization, you get your glenosphere back again. You put your glenosphere over there. And get yours. And you lock your glenosphere with a screw. If your glenosphere is mal-positioned, this screw will not go inside. There are certain implants which are available without the screw, but I prefer to use a screw over here. Then you start drilling your holes for your further cuff repair, essentially the subscapularis. So get those wires over there. Because it is osteoporotic, I decided to cement the implant. I always prefer hand packing for this. It gives me, it is no difference, but I'm very happy doing hand packing. And this is what I have learned from Dr. Sangeet Gawhale sir, where you're going to put your sutures over there. You move the sutures before the cementing takes place so that your sutures are free to move. So you have your 135 humeral stem over there. So once you have done that, that's the liner. So there are various sizes of liner where you can add more lateralization to it. There are sizes available are 3, 6, and then you have a spacer of 6 and again 3, 6. So you have about 4 various permutation combination over there. So once you have done that, so this is all done during trial implanting. So once you have done that, similarly, you get hold of your subscapularis and all your cuff tissue over there. And you have your glenosphere final implant and your humerus there. You use the similar maneuvers to get your implant reduced. And that's what you do. Again, so this is your bed shuffle test and this is your lateral humeral distraction. So you try to get these various maneuvers and check for your stability. This is very crucial because we don't want the implant to be loose, tight. You can also check what's the tension on the subscapularis and on the deltoid after doing your final implant. After I finish, I always try to repair the subscapularis over there. It gives me an advantage of some anterior stability and it also prevents hematoma formation. We check under C-arm what's the implant position and what's stability over there. So that's my video. The patient over here, so that's the post-operative X-ray. At the end of 3 months, and at the end of 6 months, this patient has regained about more than 90% of the function, got about abduction of about 150 degrees, full forward flexion, and great rotations. So if you follow all the norms of the principles of the reverse shoulder, you can expect very good results in this particular patient. Thank you.
Okay. Thank you, Prasad. It was a very nice demonstration of reverse shoulder.
Thank you, sir.
Just one question.
Yeah.
Regarding the placement of your glenoid base plate,
yeah.
means how much of angulation is acceptable and what is the logic behind it, that inferior angulation?
Right. So there are two things. One is the inferior placement and inferior inclination. Okay. So your base plate has to be on the lower two-third of the glenoid. That's very important. You can even go about few millimeters below that. One. Two is that how much angulation is very important. You have to understand the entire purpose of the reverse shoulder is deltoid recruitment. Okay, so the entirety of deltoid recruitment, because you have a dysfunctional cuff, the more amount of deltoid you recruit in your implant design, you are going to have better range of motion. Okay, and the essential thing is that you are actually changing your COR. You are changing your center of rotation from the more lateral to more medial versus. So that medial can have various variation, but because you are changing your COR more medial and inferior, you are recruiting more deltoid. So the more you do it without compromising the stability and without adding too much stress on the surrounding structure, that's what the aim of the surgery. Yeah.
Yes. Please go ahead. Rajan.
You're talking about, no, so you're talking about pre-operative counseling of patients about, so what are you worried of?
The range of movement after this thing.
Should we allow full range of movement, because is there a chance of dislocation with any particular movement?
No, I think so. See, the idea is that once you follow all those biomechanics, I think so these patients get fairly good range of motion. They will not get 180 or all those things, but they will at least get 70 to 80% of function, 100%.
And second,
and tell your physio not to push too much.
Okay.
So that what will happen is that because these base plates are uncemented metal back implants, so the weakest link over here is the osteoporotic bone and the base plate. And because it's not like a TKR or a THR, here a patient is getting about 60-70% of range, very happy doing it. I think so you tell the physio not to push too much.
secondly, in osteoporotic patient, can we do this thing?
100% you can do it.
And
100%, yeah.
in that,
A lot of patients are about all are osteoporotic
and
predominantly.
in that we have to cement that.
All glenoid base plates are uncemented. So it's on the day one fixation. They are all uncemented implants.
Okay.
But so if you see the designs, if you see the glenoid vault over here, if you understand the anatomy of glenoid vault, the implant base plate is designed in such a way that it has a good fixation.
And why it is called as reverse shoulder arthroplasty?
Okay, so you have a humeral ball and a glenoid socket. So you're making the glenoid into a ball and the humerus into a socket.
Exactly opposite. Yeah, thank you.
Thank you.
Any questions from across?
Sir, can I ask?
Yes, of course. Please go ahead. Jodhpur.
Dr. Prasad, can you elaborate more on the position of the screws of the glenoid plate and their direction where we should aim ideally and their sizes approximately we get?
Okay. Okay. So your question is that if I'm going to put a glenoid base plate, okay. And, so what is my? I can start my laptop also if required. So the question is
You can
what
explain on the board also.
Okay.
Yeah.
I think so. I have got something. So basically,
You want to show it here?
This is there. You have a camera here?
Yeah. Camera.
Fantastic. Okay. So that's the glenoid. That's your coracoid process over here.
Anterior, posterior.
Okay, so that's anterior, posterior. Okay.
We cannot hear you properly.
Okay. Okay. So that's anterior, that's posterior, that's inferior. Okay.
So your base plate, so if you start, you're going to draw a center line over here and over there. So on a standard glenoid, we are going to divide the glenoid into three parts. So upper one third, middle one third, and the lower third. Okay. So your base plate is this. This is not a center point now. This is a pear-shaped glenoid. Now you're going to take your lower 2/3 of the glenoid. Okay, 2/3 of the glenoid. So in this particular glenoid, the center point is over here. Okay, it's approximately just at the 2/3, 1/3 level, the lower one. Now your center point is going to be, as I mentioned, is not exactly over here. You're going to start about 2 millimeters posterior and inferior over here. Why this? Because this will give the maximum purchase of the glenoid vault. Now once you have this, you have a base plate, you have got 4 quadrants. Your coracoid process is over here. So your base of coracoid is over here. You have a spine of scapula over here. So your first screw, if you have got these 1, 2, 3, 4, the superior and inferior screws are non-locking. Anterior, posterior are locking screws. So this screw is going to point towards the base of the coracoid. This is about 10 or 15 degrees superior and anterior. The inferior screw, if you understand, if you look at the shape of the scapula, you have got the best bone going inferior. So it's about 15 degrees inferior and posterior. This is the lower screw. Okay, so your superior screw is going to be, this is got a maximum bone over there. So you're going to point towards the base of the coracoid, is about 10 to 15 degrees anterior and superior, and these screws are going to be 15 degrees inferior and posterior, where you get the hold of the spine of the scapula, of the inferior part of the scapula. The anterior screw generally goes straight. The posterior screw, you have got a spine of scapula. We don't want a very longer screw over there, because if your screw touches the spine of scapula, you can fracture the spine. So yeah, these screws are shorter. These screws are about 20 to 25, but not touching the spine of the scapula. Your anterior screws are about 16 to 20. Your superior screws are about 34 to 40, and similar is about, these are about 34 to 40. So these are the longer screws, and the anterior and posterior screws are about, the anterior screws are the shortest, and the posterior screws are about 20-25, not touching the spine of scapula. Okay, anything else?
This is perfect. This was very nice. Anybody else has any other question? Nagpur?
Can I ask one more question, sir?
Yes, please go ahead, Jodhpur.
Dr. Prasad, what I got from a video, you tried to lateralize also in this case. Why you did?
So yeah, so I did lateralize. Okay, I did not. So basically, if I understand, lateralization can be a glenoid lateralization, humeral lateralization, and a global lateralization, where you add both here. Here, I did not add any lateralization on the humeral side, frankly. Yeah, whatever lateralization was
on the glenoid side.
On the glenoid side, exactly. I did a 4 millimeter glenoid base plate because I needed to add some lateralization. So that was my decision. Yeah, I can even gone for a 2 millimeter. Every case, yeah.
Every case you will lateralize on the glenoid side.
There are certain implants which you can design only on the humeral side. There are certain implants we can lateralize only on the glenoid side, and the certain implants we can lateralize on both the sides. The most preferable lateralization is on the glenoid side. If I have an option to lateralize, I will lateralize on the glenoid side for the very fact to prevent the scapular notching, which was the problem with the previous reverse shoulder. So if I have an option, I will always lateralize on the glenoid side. So I used the standard glenosphere, and I used a flush lay humeral slide, humeral component. So I did every lateralization on the glenoid side.
Okay.
Yeah, thank you.
Hello.
Yeah, please go ahead.
From Bhopal, sir.
Yes, please.
Sir, how to manage glenoid fracture if we got intraoperatively?
Okay. So I had one episode of where I was passing that central screw and the entire glenoid came out. So that particular patient, we abandoned the case. Okay, We came out. We went next step. We went and did so. It was a horizontal split. We plated the glenoid anteriorly, and then we came back again after about 6 months to do a reverse shoulder for that particular patient with implant removal. So that was definitely this thing. But I'll tell you what, glenoid fractures are very, very rare. The problem over here in this patient is the base plate. Once you pass the central screw, the base plate starts getting shaky. So that's the problem, more commoner problem if you are talking about the glenoid problems on the reverse shoulder. Glenoid fracture is very, very rare.
Sir, Dr. Laksh from Jodhpur.
Yeah, you can ask the question here.
Sir, do you find any advantages of VIP of Arthrex and blueprint of Striker?
Standard patients, like, where the glenoid involvement is not much, there is not much retroversion or glenoid bone loss. Standard cases you can do this thing. But if you have a patient of about more than 20 degrees of glenoid retroversion or more than about 15-20% of posterior bone loss, I think so VIP system, which I use personally, is very good. Because it gives me an idea. See, the entire concept of this surgery is to get the hold at the center of the glenoid and getting the maximum purchase of the central screw and the peripheral screws and the glenoid vault. If you have a patient who has got a very high level of arthritis with significant loss and version, then it is very difficult to get that eyeballing over there. This is the patients where you can use the VIP system to identify what is the center of the glenoid vault and what is their position. So VIP system I personally use, and it is quite beneficial for high-end cases.
Ahmedabad.
Yes.
Unmute yourself.
You need to unmute yourself, please. Ahmedabad. You are muted. आपका आवाज नहीं आ रहा है.
Sir, contraindications for reverse shoulder arthroplasty.
Dr. Gautam just mentioned dysfunctional deltoid, that is axillary involvement, and definitely infections. But I think so a lot of patients, and definitely what I mentioned was absent posterior inferior cuff. So example, you have a significant fatty infiltration of the infraspinatus and teres minor, and the patient does not have any external rotation or a typical hornblower sign. So those patients, you should avoid reverse shoulder or you do a tendon transfer.
Yeah, Ahmedabad, go on.
If there is a loosening of the implants or dislocation, persistent dislocation, how do we manage this?
I did not get the question. Can you repeat the question, please?
If there is loosening of the implants or a dislocation of the this shoulder joint after this accident, how do we manage this?
Anyone got the question?
If there is a dislocation of the shoulder joint or loosening of the, how do we manage?
I think he's asking if the reverse is dislocated, then what do you do ahead?
Okay.
Sir, are you asking that if the reverse shoulder is dislocated, how will you manage it?
Yes, sir. And at the same time, if there is a loosening of the
Okay, so your question is that what happens if you have an unstable shoulder? Is it so? Unstable shoulder. You have done a reverse, and now your humerus is, now your reverse is unstable. Okay, now it's a completely different topic. Okay, so instability per se is very, very different topic. Instability can happen at the level of the glenoid, at the level of the humerus. It can happen at the level of your lateralization. So it's a completely different topic, and probably it's a complete different discussion. Probably it requires a complete new webinar for that, or a kind of session for that.
Okay.
Okay. You can just put my slide over there. So this is what you answer, the question which was asked. How are you going to pass your screws over there? So this is a very important study I found over here. So if you see over here, your Okay, so if you see this glenoid face view, that's the inferior part. And if you see that the component is not exactly 90-90, it is, 110-80. So you're tilting the base plate a bit. Because of changing the base plate a bit to anterior posterior, you will have got, and your coracoid is anterior, and your posterior inferior bone of the spine is below. So by just tilting this about 5 or 10 degrees, you have got a very good purchase of the bone anteriorly, that is superiorly and inferiorly. And also posteriorly, if you see, your spine of scapula is going to be over here. So here you are going to get maximum hold on the posterior glenoid without touching the spine of scapula. By just doing this one step, you are actually improving your purchase of the 3 screws on your glenoid base plate. And that's these are the various angles what you can pass over there. And they have also described the orientation, what is the orientation over here. This is a very nice particle, everyone wants to go. There are these 10 technical aspects of base plate fixation. This is the paper you can go through. All the information is available on this. Yeah, thank you.
If there are no other questions, we will move on to the next presentation. Thank you, Prasad. We now move on to an exhibition of total elbow arthroplasty by Dr. Mihir Patel.
So very good afternoon to all of you all. I thank Bombay Orthopaedic Society. I thank President Sir, Dr. Argekar to call me and give the chance to present the little work that I have on total elbow arthroplasty. A relatively rare surgery, very few indications that we encounter. So basically I'm going to very fast go through a little case discussion. The steps that we do for a total elbow, 2 different approaches I'm going to show. So basically this was a 78-year-old male who presented to us with a non-union of the distal humerus, a very low non-union. He came with an elbow which was non-functional, pain and instability. Now this was the X-ray. So if you can see on the X-ray, it's a very distal non-union of the humerus. The elbow is almost dislocating there, and he's 78 years old. That's his CT. You can see everything is distorted. So when you see this kind of CT scan, you start thinking whether you can go in and fix this kind of fracture in a 78-year-old male with the kind of bone quality we'll have, and then whether he'll have to rehab, what if the implants cut off, what if it fails, and what do you do? So in this case, we decided to go ahead with a total elbow arthroplasty. So one of the indications for a total elbow would be these late presenting osteoporotic, very low non-unions. The other indication would be an arthritic elbow. Typically we see in the rheumatic women. So these are usually the 2 main indications that you would come. And the third indication would be a failed distal and radius ORIF. Again in an elderly patient, you have to understand that like the reverse, a total elbow is meant for the low demand patients. These implants, like the reverse, are not meant to do laborious work. They will just give you a normal ADL, they can do their household activities, they can do their personal hygiene activities, and that's it. I don't think they can pick up even more than 10-15 kilos with a total elbow implant, because there are very flail implants and very constrained implants, and more the constrained, the more the chances of them failing at the implant bone interface. So very simple, like what we do for a posterior elbow approach, that is the kind of position. A tourniquet is tied, is hanging down. So that's the approach. All of us know this approach. It's a posterior midline skin incision. Then you create your medial and lateral flaps. Your first step now is going to start looking medially for the ulnar nerve, and you want to release the ulnar nerve right proximally from the arcade of Struthers till it goes into the FCU until its first motor branch. So the ulnar nerve has to be very free during this process, because you will be twisting the elbow medially and laterally when you are doing and negotiating the canals of the humerus and the ulnar. So that's the ulnar nerve exposed. The next step is handling the tricep upon neurosis. Now you can do it 2 ways. Number 1, you can elevate the entire tricep, and in this process you can see the little tongue is kept attached to the olecranon, and the remaining tricep is split off from the humerus. The other way is you can even manage these fractures without elevating the tricep from the olecranon, which I'll show you in the second video. The idea is that the entire distal humerus has to be separated from all soft tissue. So because it's a hinge implant, you don't need any medial lateral collaterals, and you dissect off all the soft tissues of the distal humerus. So you basically need to disconnect the humerus from the ulna. So you can see here the tricep tongue is attached to the tip of the olecranon. And now you see this is the kind of picture you want. The entire distal humerus right looking at you without any soft tissue attachments. And after this, then you can start your bony preparation of the humerus and the olecranon. Now these are the instrument sets. Very simple. It's like any other arthroplasty. You have a proximal component, so you have a humeral rasp, you have an ulnar rasp. There are some trial implants. Most of the time these implants are cemented because you're dealing with osteoporotic bone. Now these are the implant specifically. That's the humerus implant. And it has a little flange anteriorly, where you can put a little bone graft specifically in these rheumatic women where the anterior cortex is very weak, so that whatever bone you exercise, you can crush it and put it in between this flange and the anterior cortex, so it incorporates and increasing the strength of the bone. That's the ulnar component. It's a pure hinge. And then there are some male and female pins which just lock the two together after you fixed it on the humeral on the ulnar side. So once you've exposed, the first thing you have to do is you have to cut the olecranon tip off, because that is going to offset your entry into the ulna. So you excise the olecranon tip. You can either use a nibbler, you can use a power saw, whatever is your choice. And the next is your entry. It's exactly at the base of the coronoid. That is where your implant is going to enter. So you want to take a little burr or a little nibbler or a little drill bit. You make a little hole where the coronoid base is. And from there, you cut off the tip of the coronoid so you can get a direct angle of attack into the ulnar canal. So there, the little opening that is made, and these instruments are offset so that you can offset the olecranon tip. Very gentle raspid. You're not using a lot of hammers. You're just using your in and out motion, because this osteoporotic bone can fracture. Many times these rasp may even penetrate the ulnar cortex. You may not realize. So please keep your C-arm standby, and you're holding the proximal forearm here. You're feeling if the implant is going to cut off of the ulna, and you can feel it or not. So that is the kind of rasping you do, very gently, very softly. And then you put your trial inside. And basically the trial has to be here. So the center of this trial has to be in the circle the sigmoid notch creates. So that's the position of the implant that you want. And it's very easy. Once you prepare it, you can put it in. You don't need a very tight fit implant. These are non-weight bearing joints. So you need a very implant which goes in very loosely. Finally, you're going to fix it with cement. Then next you go to the humerus. So you remove the central part of the humeral condyle. You basically have to get access to the humeral canal. So from the roof of the olecranon fossa, you create entry into the humeral canal. So that's the roof of the olecranon, and you enter the humeral canal. So you remove this central bone. And once you enter you keep an entry rod which goes into the humeral canal like so. Again, very gently you have to take it. You cannot be hammering it, because these are all osteoporotic and can just cut off any time. The next step is you have to take your implant cut or the box cut like we do in the knee. So these companies have these ready-made boxes available. They are site specific. Depending on which side you're operating, you just have to fix the knob on that side. The box touches the distal articulated surface, and that is how you take a cut, because that's the shape of the implant which is going to go into the distal humerus. So you run the saw along it, and all that bone comes off. The entire block of bone is then removed, and you see this little notch which is created over here. And then again, they have the rasp. If you go very gently, you are hardly using any hammers here, because you're opening the canal. Understand the humeral canal is way broader than the entry. And then you take your trial implant, just push it hand, you can gently tap it so that it touches the distal articulated surface. And once this is done, you can on table articulate the ulnar and the humeral component, fix it to the pin. So this is what is done. You articulate, and there's a male pin and a female pin which goes in, and it just clicks and locks. And that is how you get the articulation of the two components. It's a pure hinge. You're not dependent on any soft tissue except for the tricep and the anterior musculature. There are no ligaments connecting the two components now. So that is how you just place it back. The male pin from one side, a female pin from the other side. And you lock it back. So this is another case where I've not elevated the tricep at all. You see, this was the fracture case. The tricep is completely intact. I released the tricep from medial and lateral, and simply turning it internal externally, you can get complete access to the distal humerus and the ulna. So that's the ulnar component going in. And I'm just checking the position of the ulnar implant with respect to the height of the olecranon on tip. You remove any anterior osteophytes of the coronoid because the only thing that you want to avoid here is any impingement, because impingement is going to not allow range of motion. The patient is going to move, the forces that get transmitted to the shaft and creating fractures there. So that's the humeral component going in. So from there, that's the box cut already taken the humerus. The humeral component goes in, very gently tap it back into place, and then you do a trial reduction as I just showed you in the first case also. You put the male female pin, it clicks lock. Do gentle range of motion to see whether it's not prominent, and then you start the cementing process. So cementing, usually because the canals are very narrow, you would need some narrow device to introduce the cement into the humerus and the ulna. And this is what I use. I use 5 cc syringes. I cut the top off. I pack it with liquid cement. And I use the syringes to push the cement into the humeral canal and the ulnar canal. And once the cement goes in, you hand fix both the components. You can either do it in one cement packet, you can do it in both, but I feel you can very easily do it in one cement packet because a lot of time. The 12 or 14 minutes is a lot of time to fix both the humeral and the ulnar side. A simple hand push. You see the height of it. If you want, you can gently tap it down. There are instruments available in the sets to tap your components back into place. So gently tap it back into place. You have to keep your hand here. You expose the ulnar cortex here because many times we just cut out at any stage. So you want to know these things are happening or not. Once this is done, you go to the humeral side. Again, I'm pushing the cement using that syringe 5 ml. 2 or 3 full syringes can be pushed up into the humeral canal. And then the component is taken and pushed in with your hand. Very gently tap in it nicely gets locked in the socket that has been created in the distal humerus. And once the cement dries up, you articulate both the humeral and the ulnar components. And you lock it. And then on table, you can see your knee range, your elbow range of motion. Very stable. With no soft tissue attachment except for the tricep posteriorly and your anterior musculature. So that's the C-arm picture immediately after surgery. You can see the elbow, the height positioning is also perfect because the circle of your range of motion should be same as what it was of the elbow. You're also confirming there is no cutout of the implant here because this is where the cutouts occur. Specifically if your entry point is anterior, so you need to go as posterior as possible so you can enter into the ulnar canal. So that's the fracture case. This was the kind of fragmentation that had come out. Now, so this was when it came out. Fixing this, Pradip, I don't know, at 78, would you try to fix it? This is powder. There's no hold that you would get. And that is what we felt that what we did this for a 78 male was correct. That is the X-ray. What I said, so in rheumatic bones, this flange which is an anterior, you can pat bone graft there. But because this was a fracture case, the bone quality was not osteopenic that you see in rheumatism. You don't need to put bone graft. You see the canal, that's the cemented implant, the humerus going up, and that's the articulation at the elbow. That's the immediate kind of range of motion that you see. They're usually very happy because they start getting their movement almost immediately. After about 1 or 2 weeks of sling immobilization, you start active assisted, and there is very frankly not too much therapy is required. And the only thing you have to tell them that the only thing they're allowed is your ADLs. You cannot be doing farming activity, you cannot be doing a lot of carpentry kind of thing. It's a very low demand implant, and you just let them be happy and give them a stable elbow and send them back home. Thank you.
Thank you, Mihir. That was nice.
Thank you.
Seems no jigs, No, nothing. Looked very crude to me, not your technique, but the implant per se.
No, so it doesn't require the kind of balancing the knee joint requires. It doesn't require, the only thing you have to maintain is your tricep tension.
Yeah.
So it's a very straight process and a very uncomplicated implantation. The only issue is if you don't follow the basics, you don't enter the ulnar canal properly, it can perforate, and that is where the problem starts.
Right. Now, open to the house. Any questions from anywhere?
So from
Yeah,
Jodhpur here.
Yeah, please.
Hello, Mihir. Dr. Hemant Jain here.
Good afternoon.
In trauma cases, when the condyles are damaged, so what will be the difference in technique? Because in this, what I see in your video and what I have also done, the center part is removed and both the condyles are remaining. So does that make any difference?
No, so first thing is if the condyle is fractured, would you opt for a total replacement? Because if your condyle is fractured, I would typically go for a fixation because I have some bone chunk left where I can capture with some screws. Unless you're talking about a completely arthritic elbow with a condyle resolved, is that what you're talking about?
I am talking about the same scenario as you mentioned, non-union old osteoporotics, 80-year-old, but the fracture is such that the condyles are broken on both the side, medial side and the lateral side. What will you do?
So basically you have to understand that this is a purely cemented implant. It is not taking a lot of distal humeral contribution. You put a longer shaft inside and you fix it with cement. And if you feel that the condyle is fractured, I would opt for a fixation, because the reason in this case I went for a total elbow because it was absolutely distal and there was no point fixing this kind. When there is a condyle, even at 4 months, I think we can attempt fixation. So please understand that this total elbow cannot be a replacement or an easy option out for a fixation of a distal humerus fracture. I think even today, if I can attempt, I will definitely fix, because that will definitely give a better quality of life than a total elbow. So then you are looking at tumor prosthesis. If there is a lot of bone loss, then you have to do the design. You tell these companies to design and you make those boxes which then touch the distal shaft after removing the condyle. So then suddenly you go into the tumor arena where you have these very customized implants. Again, all of them are cemented. And even there we know that even tumor prostheses are basically just giving a normal ADL to the patient. You're not expecting a lot of function out of it.
In the same way, I want to ask a question. Can I?
Yes, please go ahead.
In the same way, there is a side sweep injury in a young patient where the distal humerus as well as olecranon process has gone. Then we can use this implant in a young patient also?
No. So this is absolutely, for me, a young patient, I will do anything to fix it back. In fact, in a young patient, even a bag of bone concept.
Everything is gone.
No, you mean a very distal humerus fracture where it is completely crushed. In a young patient, you cannot do a total elbow, because if you give him a total elbow, his elbow is not going to have any kind of power to do any weight lifting or any kind of hard work. So for me, this implant is not for a young patient.
Besides, what is the survival of a total elbow?
Yeah, so that is what I was coming to. Please understand that it looks very good immediate post-op. Very typically, what I have seen that these patients start losing their range of motion after 2 to 3 years. So what on post-op video you are getting almost complete range. Typically after 2.5 years, they come down to only about 50-60 degrees, which your young patient is never going to be happy. A young patient will definitely get that much range, even if you follow the bag of bone principle. You just give a ligamento-taxis, let it heal, he will still. So a young patient is going to require a stable elbow. Please understand, these total elbows are not stable. They can just break open not at the joint but at the bone implant interface. And we have seen a lot of complications like this where the ulnar component is cut off and then it is a complete soup, because it's a cemented implant. In an osteoporotic bone, you remove the cement and there is no bone available there. You understand? So this implant is not meant for young patient. For me, this will be only after a 70-75-year-old patient, and that too very clearly only a household worker. A household family worker.
Yeah, please go on, Gawhale.
Sir, my question is, we have a female of 40 years around age, and she is arthritic elbow, and it is fixed in almost 90 degree of flexion. Now she has got a fracture in supracondylar area. So should we go for total elbow or should we fix it?
No, no. So the very fact you tell me that the elbow was ankylosed, probably she was rheumatic and she has been living like this. She's been doing everything. And now if you got a distal humerus fracture, I think you should do everything to fix it. At 40, again, this implant doesn't become implant of choice. 40 is very young. That lady would want to do some heavy weight either at home or at her professional place. This implant is not going to survive.
Yeah, Rajendra. Bone graft. Bone graft.
Bone graft. So I'll tell you. So one of the main indications for a total elbow is a rheumatic elbow. Rheumatic elbows typically are very osteoporotic. In this case, this was a trauma situation, so we did not put bone graft. So in a rheumatic elbow, when you take your box cut of your distal humerus, your anterior cortex is very osteopenic. So basically you put bone graft there, you don't need to roughen. You have to understand that the entire distal humerus is stripped of all its muscles and that's enough sharpening fiber elevated, that's enough bleeding there for that thing to heal up. You don't want to irritate that distal cortex because you don't want to weaken it further. You just place bone graft there and let it consolidate the way it wants to consolidate.
Right. Yes, sir. You had a question?
Again from Jodhpur, yes.
Yeah, please go on.
What about Dr. Mihir?
Hello.
What
Yes.
are the intra-operative complications? Have you faced any, and how did you come out of them?
So the main intraoperative complication is your stem penetration in the ulnar component. The humerus component is relatively straight, so we don't have a problem. The issue is your ulnar component, when you are pushing your ulnar component or your rasp, there is a very high probability of penetrating the dorsal cortex. So the first thing, if you see in my second video, I have split the dorsal muscle on the ulna, my finger is there, and every time my instrumentation goes, I'm seeing it and I'm feeling it, whether it's penetrating or not. And you do that every stage. Yes, if you have an inadvertent penetration, then the only thing of bailing out is a longer stem. You have to, bypass the stress riser and go for a longer stem. I have faced a situation where I have been referred a patient, where at the first stage, when a total elbow replacement done, again, relatively, 55, 60 principal kind of patient, the penetration was done, and then they build the entire humerus with cement. The tricep avulsed off, so they try to fix it with a suture anchor in the ulna, which was nothing but cement. So you have to understand that these things are going to be problematic. So if you feel that your tricep is going to avulse, please elevate the entire thing like what you do in any distal humerus fracture, and keep your longer implants ready, because you cannot put any plate fixation because you have an intramedullary implant inside. The only thing that you can do is a cerclage. Also understand cerclage in the region of ulnar humerus is absolutely risky. All your neurovascular bundles are there. So first thing first, very sharp selection. Okay, for me a total elbow is a no. Nothing works, then it's total elbow. So a total elbow will never be like your first choice. If not to be fixed, nothing available, then a total elbow. And then when you are going in, go very slow. I usually take 2 to 3 hours for this procedure. It looks very simple, but you have to go very slow, very delicate bone. That's the only thing you can do.
Mihir, are all the prosthesis similar to what, I think this was an Indian implant that you use. Are there better implants available
definitely.
in the market?
So let's go through the evolution. The first thing was the sloppy hinge, Bucksky's elbow that came in. And it was not a pure hinge. It did give you about 5 degrees of varus valgus mobility also. That is why it was called a floppy hinge. But the problem in the floppy hinge was the locking of the component was extremely difficult. They had a grub screw or a grub nut, and you would finish your implantology in about 1.5 hours. Putting the grub nut would take another 1.5 hours, and that is why it fell into disrepute. This what we are doing is the Conray Murray type. It's a pure hinge. So we are not doing anything, we are not reconstructing the distal humerus, we are not reconstructing anything with the radial. Now we have even better ones where, like the total knee, where you have these articulated surfaces, you have these articulated surfaces, so you size them in AP and lateral plane, you fix it with your rod and then fix it. So it's actually recreating your native anatomy. And at the same time, there is scope of also replacing the radial head and the capitulum. So that basically gives you more stability at the joint surface. Thus, less forces go to your bone implant interface, and hence those things do better. But in India today, this is what we have. Yeah.
Right. Thank you. Any other questions from the
hello.
On the online? Yes, please go on.
Have you tried 3D printed implants?
No, I have not tried 3D printed implants.
And in cases of severe myositis ossificans, the patient starts demanding something because he says he has been ankylosed. So what do you advise, excision arthroplasty or you're talking of total elbow?
See, so when a myositis patient comes to you, he comes with you with a stiff elbow, and I'm assuming this is matured myositis.
Yes.
So if the patient is going to demand, you can't do an excision because you're going to give him an unstable elbow. And if the age criteria fits, then you do a total elbow. And the total elbow, there is no rocket science. You just have to try to remove the myositis, because the myositis gives a very sharp plane between native bone and the myositis excision. But please understand, your tricep has to be intact. Now, while excising the myositis, the tricep is going to be damaged. This complete process is going to fail. So converting a myositic elbow into total elbow is a completely different discussion, very challenging. And usually these myositis patients are young, where as it is for me, it's a relative contraindication. So I don't think I would let the patient be happy with the myositic stiff elbow, because we don't have a lot of options available.
Thanks.
Thank you, Mihir. That was wonderful. We move on to the next case, and that is again from stiffness to mobility. We have Dr. Prashant Kamble, who is going to show us how elbow arthrolysis and mobilization.
संगीत तेरा हो गया रेडी या तू एक कर दे फिर उसको लास्ट में सर मास्टर को लास्ट में या go and bring it in.
So the common problem that we see either post-surgery or post putting the cast is a stiff elbow. And how does it matter? Like, you can have loss of function and there could be multiple causes: implant, intra-articular adhesions, HO formation, or combination of all those things. So this is like, in general, intrinsic, extrinsic, and the mix again, the duration. So this is the patient who had a radius ulnar fracture and somebody put him in a plaster cast for 2 months, and at the end of almost 6, 8, 9 months he did physio, rehab, everything, and it's plateaued out. So there is a functional range, if you have seen, is from just 30 to 90 degrees. So there was no, movement happening, anything. So the patient is under general anesthesia. I what commonly do inject pre-operatively is, before taking the incision, almost for 10-20 minutes, is the cocktail, is a saline, adrenaline, and some of the lignocaine and the bupivacaine, so long-acting anesthetic. So that reduces the post-operative bleeding, especially for these kind of a patient. I don't inject around the ulnar nerve because it becomes difficult to find the nerve. And for this patient, there was no any bony abnormality, it was just a soft tissue contracture. So you start with the posterior approach. First step is to identify the ulnar nerve, preserve, and just keep it in place. Unless and until it is subluxating at the end of your complete release, then you take a call whether to transpose it entirely or stay where you have decompressed. So be careful and start releasing or in situ decompression of the ulnar nerve. So as a part of stiff elbow, the tricep is stuck to the entire posterior part of the humerus, including the olecranon fossa. So as a ulnar nerve. So free the ulnar nerve first. That is a step number 1 for release of the stiff elbow. And as I saw, the nerve is also quite edematous and swollen, although the patient don't have any preoperative complaint. So from there, go paratricipital, clear the olecranon fossa, remove the posterior joint capsule, the fat, whatever is adhered to the posterior part of the tricep. So clear entirely from the posterior surface of the humerus, lift the tricep up. So same you go on do on the radial side. So that is something you will get more range. So lot of fibrous tissue in the olecranon fossa, and the tricep was completely plicated to the posterior part of the humerus. So use any instrument that will just take off the tricep from the posterior part. So I'm now trying to create the the radial side plane. So tricep is completely off, and the olecranon fossa, once is clear, can go on the radial side. So again, take the incision there. So that will complete your posterior compartment, rather the posterior part. So once you inject, it is little difficult to identify the plane, especially on the ulnar nerve, so I don't inject there. So once the lateral side is clear, now you need to go anteriorly, because as you see, the range is from just 90 to 30 degree. So you need to clear off the anterior joint capsule. So this is ideally for soft tissue, best is done with the arthroscopic, but here, since we have used the open procedure, so create an anterior window just anterior to the common extensor origin. To some extent you need to knock off the part of it. So gradually, slowly make a window. You don't have much of the space since the joint is contracted. Clear off from the anterior part of the distal humerus. See, just stay between the capsule and the anterior part. If you go beyond the capsule, you will be landing up into the brachialis, and probably if you go a little more anterior, you are likely to damage the neurovascular structure. So you can extend the incision a little more proximal, clear off all the anterior structure, that is the capsule and the intra-articular adhesions. Part of common extensor origin. So I'm slowly going and seeing the anterior joint capsule. I've seen a little bit of white. Once I remove it completely, you may be able to see the anterior capsule. So one retractor is holding off the brachialis, and this is what I'm holding now, the entire anterior joint capsule, so which was preventing the full extension. So put your finger, see anteriorly whether you have release or not. So I can pass my finger from medial to lateral side completely, and it is completely off. So at the end of entire release, I took this elbow into the full range of flexion and extension. So there was a complete extension, but at the end there was some terminal restriction of the flexion. So I did this pie crusting of the tricep since it was a long standing, and that helped to regain the complete flexion at the end. So this is what we got at the end. Full flexion and extension. So whatever range you get intraoperatively, you must explain that you will lose this range 10 to 20 degree in the post-op period. So while doing this, I found that ulnar nerve was subluxating anteriorly. So I decided to transfer it anteriorly. Otherwise, had this been staying in place, I would have not transferred. In just in situ decompression is enough. So two slings of the common flexor origins are elevated. The perimysium from the common flexor origin, and I have transposed this nerve anteriorly, creating an adequate bed, and sutured the slings over each other so the nerves stays anteriorly forever. While suturing also, make and ensure that proximally and distally nerve is not getting kinked. So check again once you have sutured the sling, check proximal and the distal entry point where the nerve is getting kinked anywhere. So again you have to release that. And while even suturing also, put some forceps or mosquito over those slings, so there should be no tension over the nerve, and it should be glide smoothly between the slings also. So again, same intraoperative full range. So explain patient has to start the rehab as soon as the pain swelling subside with the good analgesics or whatever is your post-operative protocol. So I typically put them if they are staying in hospital. So I'll start with the. So here I want to tell about the brachial plexus catheter, that is one, or you can put a buvular patch so that they can start rehabilitation immediately. So here is a protocol that you must focus when you have a stiff elbow. See whether this is a soft tissue contracture or there is any bony block. If there is a soft tissue contracture, conservative treatment, rehabilitation, splintage for at least minimum of 6 months. And if there is no improvement further, then offer the surgical treatment. If there is bony obstruction, the surgical option is the day 1. Now, depending on the location of the ulnar nerve, whether the range is below the 90-degree, pathology is extra-articular, multiple previous surgery, that if the answer to all these is no, arthroscopic arthrolysis as I mentioned. If yes, then open surgical procedure. Now choice between the lateral or the medial approach depends on the location of the ulnar nerve. So if lateral approach is more, everyone is very well, it would be the first choice. If the pathology is more medial, ulnar nerve decompression is needed, previous surgery is medial side, then medial side is your approach. Or posterior global approach, where through which you can go anteriorly also, medially also, you can use 360-degree. So stiff elbow, we feel we know everything. We to put on stiff endomethacin, radiotherapy, and we feel that we are like this mountaineer where we reach the summit, and the moment you reach the summit, you feel summit is somewhere else, and the journey continues. Thank you.
Thank you, Prashant. That was a stiff elbow, a very common problem that all of us see in practice, especially post-injuries. And sometimes it's difficult in young patients. You need to mobilize the elbow surgically or otherwise in order to give them a good result. So Prashant has shown us a very nice demonstration. Any questions from the house over here? Anybody? Yeah, Rajendra? Endomethacin post-operatively, do you advise in these patients?
I usually give for HO formation, if I am doing that for HO formation, 25 milligram twice a day for 3 weeks, that is what has been mentioned. But even you can get away without that also. Even I have given for those patients whom I have removed the HO for 21 days, again they have recurred. So practically that's like whatever you can give to prevent. Yes, there are literature which shows that is useful, but practically I don't find that is doing any purpose practically.
Anybody else? Any question? Okay, thank you very much, Prashant. We now move to the last session of the day, and we've got Dr. Sangeet Gawhale, who had earlier had some software problems, so he could not continue with his talk. He is now going to start. I think, are you going to continue with the humorous shaft or you're moving to the other? Move. So he's going to present two cases, one back to back. One is on radial head replacement and the other is on plating. Yeah. So I am sure that you all are going to have a good time. Let's see.
Or we want to take coronoid first.
Take coronoid first.
Okay.
It will be nice.
Because that is a long topic. So we all must appreciate and clap for the president. He's a spine surgeon, and his enthusiasm till now, from 9 o'clock till 3 o'clock, must be appreciated. And in between, he's the one who's leading questions. Being from a spine specialty, he has left general orthopedics, I think 25 years back. But still his questions must be appreciated, which are as good as any practicing trauma surgeon. So coronoid fracture, how do we deal with them? It's a small piece of bone and the tip doesn't have any attachment. It has only some capsule which is attached. If you go still distal to it, it has an attachment of biceps brachialis muscle, not biceps. Biceps is attached on the radial tuberosity. And on the medial side is the attachment of the medial collateral ligament, the anterior band, which is the most important structure. Okay. So what is at the top from the lateral epicondyle to So the out of the three structures on the medial side. Okay. So out of the three ligaments, the most important is the medial collateral is the anterior bundle, which runs from the epicondyle and gets attached to the sublime tubercle. So this is the one what we have to reconstruct, we have to repair when you are repairing the medial collateral ligament. The anterior bundle of the ulnar collateral ligament, the UCL, the anterior capsule and the brachialis muscle are attached to the coronoid process. The radial head prevents, it's a primary stabilizer of the elbow joint. It helps in preventing a valgus instability and the coronoid helps in preventing a varus instability. So there are three types of instability related to coronoid fracture. Isolated, it is very rare. Type 1 are the fractures which are usually associated in terrible triad injuries. Type 2 are the one which are associated with varus, posteromedial rotatory instability. Dr. Prashant has shown that case. It is the extension of that would be a coronoid process fracture. And type 3 are the one which are associated with transolecranon fracture dislocation. So that is the one. So this classification you are all aware of. The coronoid process, the tip can be involvement of the anteromedial facet, anterolateral facet or a base. So out of the three, the one which is at the base is the most difficult and it is associated with instability because it has the attachment of medial collateral ligament. So the approaches in dealing this coronoid fractures, it can be approached by four different approaches. From the medial side directly, from the anterior side, from the lateral side and from the posterior side, and each have different indications. So I'll come first to the anterior approach or the medial approach, sorry. So here is a case who had this dislocation and you can see here the coronoid process on the medial side appears to have displaced, and it's such a small fragment. Will it give rise to any instability? Let us see. Now when you see the 3D CT, so it has the facet fracture of the coronoid process. That is the anterolateral facet. So that is not really important as far as the stability is concerned. Then you have the anteromedial facet, which is again quite big and displaced. And what is attached to it is the insertion of the MCL, the anterior bundle of the MCL. And that insertion is on the sublime tubercle, which forms the base of the coronoid process. And look, ये वीडियो नहीं चल रहा है. Can you play this video? Yeah. So you can see in the X-ray it was looking quite stable, but now you can see the amount of instability it has. Right. So the incision is on your left is ulna, on your right is humerus. The olecranon is here, and it's a medial approach directly over the epicondyle, proximally, extending proximally and distally. There may be a small chip fracture. So once you take the incision, go down through the subacute tissue and remain anterior so that you're not injuring the ulnar nerve. And once you expose, you will have these structures running over the epicondyle. And try to find out posteriorly the ulnar nerve. It is easier to dissect from proximal to distal. So there you can see that shiny structures at the proximal end of the incision. Retract the soft tissue posteriorly. Extend the elbow so that your dissection and the space available is more. So distally, you can see the two heads of the flexor carpi ulnaris muscle where the ulnar nerve disappears. That is the distal extent of your incision. And protecting the nerve with a 15 number blade, try to erase part of the flexor carpi ulnaris, because that is where your flexor carpi, that is where your coronoid process is. Right there. And once having dissected, you reflect that, and you have opened the joint now, the hematoma is being drained out, and then carry on the dissection till you see the fracture site. You can see the trochlea getting exposed there, and there you have exposure of this is the anterior band of the MCL, which is intact, which is inserted distally on the sublime tubercle, and we are completing the exposure of the fracture, that is that small fragment. And we'll try to fix it. Since it involves the medial facet, if you fix it to its bed, that is all what is required as a temporary fixation. So one wire proximally, there is one more distally. So you can manipulate with the small fragment as a joystick. So that single wire fixing that facet is enough for fixing. So ideal plate is not available. You have to reduce the length or use a different type of plate which will fit a particular coronoid process. So there's not a uniform plate which is available for fixing this fracture. And once having fixed adequately on the medial side, you can see what was the instability previously, and the instability later after having fixed that medial collateral ligament. So that is the important of that anteromedial facet, how you should fix it, and that is the medial approach, right? So that is the MCL, anterior band. 2 screws fixing that coronoid facet, and then distally 2 screws in the shaft. That is the post-op X-ray. So this was about the medial approach. Another approach is from the lateral side, that is a Cocker's approach, where you have a facet which has to be fixed as a part of terrible triad on the anterolateral side. The facet involved is the anterolateral side. So this boy is from Thane, the very place here. He's a pilot trainee, had this injury where there is a comminuted fracture of the radial head. That is the only injury, but he was not comfortable. And his job involved brake and the gears what are required a complete extension. And you can see here the ecchymosis which is seen, which is a telltale sign of the area of which ligament is majorly involved. So on the medial side, if you don't see ecchymosis, probably MCL is, you can consider or you can say that the MCL is intact. So that ecchymosis is quite extensive whenever you have MCL injury. That is the 3D CT, which shows us the comminuted radial head fragments, and you can see that radial head fragment, and what is anterior is the anterolateral facet of the coronoid process. And on examination, you can see again how much is the instability he has just because of this small fragment and the radial head fracture. And that is the additional anteroposterior instability. The sequence of fixation in a terrible triad is standard. Fix the coronoid first, then the radial head, and come out and fix the lateral collateral ligament. Deep to superficial. So a Cocker's approach, that is those fragments are of radial head, what are seen, and then you go inside, that is the coronoid process, which has attached capsule, okay, and this is how it can be fixed by a pull-through suture. We have to take sutures at the level of the insertion of the brachialis on the coronoid process or the capsule. Brachialis is attached much distally here. So what you see, soft tissue which is what is attached is actually the capsule. And make 2 drill holes on the posterior surface so that they emerge out over the coronoid process like that, and then pass with any instrument thread through one of the hole, withdraw it, or you have taken the bites of this capsule, they can be withdrawn from the posterior holes of the olecranon, and then you tie it. So this is how we are taking a stitch on the attached small fragment and the capsule. I am a right-handed surgeon. I have inverted the video, that is why it appearing that I am operating with the left hand. So having taken the stitch, you can see the K wire which is drilled at the footprint of the coronoid, through which we would be withdrawing one of the ethibond suture. So we are completing the suturing so that it doesn't cut out. So we have 2 ends which will be withdrawn from the posterior surface of the olecranon like that. So this is an instrument or a needle or anything you can use. This is a small biopsy forceps, a grasper. No. Okay. So it can go through and it can be pulled out. That one end is pulled out already, and then you follow and do it for the other second side. So you can see that when you pull it out, the capsule comes as a buttress on the coronoid process. So these are the alligator forceps which the urologist used to remove the stone, and that 6 franc is equivalent to 1/3, that means 2 millimeters. So that can go through a 2 millimeter drill hole, or you can use a simple needle or whatever instrument. So the second thread is then again grabbed and pulled through the other hole, or even you can use that nitinol wire. Yeah. Okay, so now we have 2 pull-through sutures grabbing the capsule and the part of the tip of the coronoid, which is an anterolateral facet. So that is how it gives a buttress effect once it is reposed back. And then lastly, the LUCL, somebody has asked what is where we should attach and what should be, I think Gautam has asked, what is the isometric point for attachment of the, so you need to take a good lateral view where you see the capitulum as a round circle. So the center of the capitulum is an isometric point. Just 2 millimeter anterior to the lateral epicondyle is usually, that is where your suture anchor should be while reconstructing the lateral collateral ligament. And see, you can see the comparative 2 pictures after having reconstructed the coronoid, the lateral collateral ligament and the fractured radial head, and that is how he gets his complete extension. Okay. So that is his 10 months X-ray and his function at the end of 10 months. He has gone back to his pilot training. So third entity is the one which has a larger fragment where the sutures are not enough. We need additional screws. So here is a case where he had such a large fragment involving both the facets, and that has been fixed by a screw. What you see here is, this is the capitulum, Cocker's approach. On the medial side is the trochlea, and here you can see that much exposure in an undislocated elbow because the common extensors are already avulsed. And you can see the top of the screw, headless screw, and that is the coronoid process. So this fracture has been fixed by a single screw. In addition, we use suture wires. So this is how the elbow is stable, just by fixing that coronoid process with the help of a K wire, and then we are putting a cannulated screw over it. And this is at the end of the fixation, a complete flexion and extension, and the radial head which was fractured had also been fixed. His complete pronation and supination, and that is how his post-op X-ray looks like. And that is his flexion and complete extension, and he gets back his pronation and supination. The key is mobilizing them early, and mobilizing early requires a good repair. Okay. So the third approach is the one where you have this fracture dislocation, the transolecranon fracture dislocation, and the recommended approach is a shotgun approach. Any idea what is a shotgun? So here what is done is we go through the fracture, and the top of the, or the tip of the olecranon is pulled out so that you can work in the space and then fix the coronoid process, okay, with the help of a screw. So you open the elbow, you completely flex the elbow, pull the olecranon process superiorly as if you are opening a shotgun to fill the bullets, and with a hook or something, then reconstruct the coronoid process, fix it with screw, and then add a plate posteriorly like this. And that is how we get back. So this wire and the screw is holding that coronoid process. And that is the radial head which is communicating or articulating with the lesser sigmoid notch. That is the post-op X-ray. And last approach for coronoid process is a direct anterior approach, where you take a straight longitudinal incision over the coronoid process by palpating it or seeing it on the C-arm. You will come across these structures. On the medial side will be, or the lateral side will be your biceps brachialis. On the medial side will be your neurovascular bundle. You retract them. The floor is the brachialis muscle. You incise the brachialis muscle over the coronoid process, and then you can use a small plate like this or screws to fix that coronoid process fracture. So that was all about the 4 approaches what are required for coronoid process, treating the coronoid process fractures.
Let's just open it up to the house over there.
Can you use anchor in place of those who has pull-out sutures?
So the best hold of anything, any implant in the proximal ulna is the coronoid process itself, the tip of the coronoid process. So even if you want to put a plate, there has to, one screw should pass in the coronoid process. So that is how the coronoid process remains stable. So if you pass those anchor sutures through the fracture inside that cancellous bone and you try to pull out, the hold is not as good as a pull-through suture which are coming from the posterior side. Got it? So the sutures, the pull-out is anterior, and for the pull-through, the suture is antero-posterior. That is much better than, because it is grabbing the coronoid process itself. We do not want to reconstruct we do not want that fragment to be reposed back. So it is a capsule which we are grabbing and holding it as a buttress against the inner dislocated elbow, right? The fragment is immaterial. It doesn't have any attachment. It does not require anatomical reduction. If it is small tip, if it is a large fragment, then it has to be reposed back at its footprint. Anything, whatever is required. It is not mandatory that you use XYZ implant.
So there was a question from the audience whether you could use metacarpal plates, and that's why Dr. Sangeet said you could use anything. The important thing is to reconstruct the capsular attachment. Any other questions from the house over here? Can I open it up to the online anywhere else? Gwalior, Bhopal, Guntur, Nagpur.
Sir.
Hello.
The coronoid fracture is a difficult fracture to approach and fix, and it has often been missed and mistreated, and that's why this talk was extremely vital and important. Let's start with Nagpur, and then we'll go down to Jodhpur and Gwalior.
Hello.
Nagpur, please start.
Sir, good afternoon, sir. Sir, I wanted to ask, while doing the lasso technique, when do you tie the pull-through suture, sir? Immediately after?
So you are asked, yes, good question he has asked. Now, when you're doing it in a terrible triad, what should be the sequence of fixation, right? So, was that your question?
Yes, sir. Yes.
Yeah. So, first fix temporarily, take the sutures through the coronoid, bring it out on the posterior surface of the ulna. Then you fix the radius either with plate, screw, or if you want to replace it, then pass the sutures, but don't tie them in the for the lateral collateral ligament. And once you have done all your work, start tying from the coronoid, then reduce the radial head in a reduced position of the elbow, then lastly the LUCL sutures. Have I answered your question?
Yes, sir. Yes, sir.
Thank you. Gwalior, please go ahead.
Sir, I want to ask, what is the size of those canals you make in for this suturing, pull-through sutures?
2 mm,
2 mm, sir.
2 mm.
And if there is associated MCL also injured, you repair that also along with
Ye-
the
Yes, which is separate approach. That would be medial, and that is at the end of having fixed all these three structures.
Okay, sir.
The question was related to terrible triad. Am I right?
Was the question
Or
related?
was it related to isolated coronoid process?
No, it's terrible triad.
Okay, yeah.
Yeah, Jodhpur, you had a question. Please go ahead. Can you unmute Jodhpur? We can't hear you.
Sir?
Yeah, please go ahead.
Sir, so good afternoon. Very nice presentation, sir. Sir, you
Is-
showed all the approaches.
Is Rahul
So,
sitting next to you? Is Rahul sitting next to you? Hi.
Yes, sir, very much next to you. Good afternoon.
Sir, so in nutshell, what I have understand, I just want to confirm. So for the anteromedial fragment, you are using the medial approach.
Yes.
For the
Or
lateral fragment, you will be using the lateral approach.
yes.
And for the posterior split fractures, you will be using the Top Gun approach.
Yeah.
And,
Transolecranon, a posterior approach.
So when do you use the anterior approach mainly?
Isolated coronoid, which is where both the ligament, you are ensured by checking it in the C-arm, both the ligaments are intact. You don't have to repair the ligament. The coronoid process is quite a large fragment. In that situation, you can use an anterior approach.
So are there any complications more common
yes.
with the anterior approach? Stiffness?
No. Only thing is going distally. There is too much of dissection required, and intraoperatively you have to be very careful in retracting the neurovascular bundle.
Okay.
All right. Okay, thanks. That's we are now going to soon go on to the last presentation of the day. But before I let Sangeet continue with that presentation, I would like to do a small vote of thanks. At the outset, let me thank the two organizers of the meeting, Dr. Harshad Argekar, the convener of this show. A small gift. This is a personal gift from me to him. This book was given to me by Dr. Marvin Tile when I finished my fellowship with him in Canada. And I passed this on, since it has no use to me. I passed this on to Harshad, who has done enormous efforts in this year as a
Chief convener.
And as a convener of this course. Not only that, but as part of the writing the monographs and a lot of other events across the year. And of course, my very hard-working BOS secretary, Dr. Ashish Fadnis, who has put together this program. Thank you, Ashish. So he has all the 4 live surgery symposia that we have had. He has been solely responsible for convening them, coordinating them, getting everything together. And of course, he's been doing fabulous work for the Bombay Orthopaedic Society. So thank you, Ashish. The third person I would like to thank is Intas Pharmaceuticals. Intas Akila, Vice President, Mr. Jagrup Singh. I don't know if he's watching. Prabhakar, and the entire Intas team in Bombay and from across India, who have put together such a fantastic show in each of these locations. Our first webinar which we had was in April, at which time there were 21 centers who had joined us. The second webinar had about 17, and we've been having these symposia. This is the 4th one in the lot. and in each of them we have shown about 15 to 17 surgeries. For those of you online who have missed these surgeries, they are available on OrthoTV and on the BOS YouTube channel. So please feel free. The first web symposium was on live hand surgery. Second was ankle foot surgery. Third was pediatric orthopedic, common pediatric trauma, etc. And today, of course, all of you know, was on shoulder and elbow surgery. So it has been great. And the next person I would like to thank is the coordinators of at all these centers. They all have spent, and all the delegates at all the centers across India and in Bombay, who have spent their Sunday coming, and of course learning is a great incentive, but still to give up your Sunday, the only holiday that you have from your family, is a great sacrifice for learning. So I hope you all have gained from these seminars and are able to utilize these for your daily practice. Finally, last but not the least, all the faculty, they all throughout the three symposia previously and today, they have prepared such wonderful videos and presentations, spent their time teaching us about all these things. And the audiovisual team of Ivan they have done flawless telecast for all 4 symposia. There has not been a single problem on the audiovisual end, either in Bombay or at any of the other centers. So congratulations, Ivan and team. Thank you very much. And now I would request Dr. Sangeet to continue with what will be the last presentation of the day. I'm sure knowing Sangeet, it will be very exciting and interesting.
And also the host hospital, Ashish, Jupiter Hospital, for providing us a good atmosphere, ambience and the food. And all that was managed by Ashish, courtesy Ashish. वो बाद में है मेरा, इसके बाद, by the time I finish this. So radial head plating, he is a photo artist. He had a dislocation while he was climbing down the stairs and had this radial head fracture and an elbow dislocation. That was reduced in emergency, but again it redislocated. And so in the X-ray, he had this radial head fracture, which got in position after reduction, but the elbow is dislocated medially, and there is some fragment which is seen anteriorly. So whenever you want to take X-ray where you want to see a good radial profile, this view is very important, where you angle the forearm is on the cassette, you angle the beam at an angle of 45 degrees, and then you will be able to see a radial head and the neck profile along with the shaft like this. So that gives you a good idea of how many fragments the head has, whether there is associated neck fracture or what extent it is going distally, so that you can plan your implants. So all elbows, whichever you are considering surgery, CT scan is mandatory. It is available everywhere at even small places. What you must ask is subtraction of the distal humerus from the olecranon and the radial head, so that you get a clear picture of whether from the top of the radial head, whether there is a neck or the radial head fracture, and secondly the coronoid process, which we have already discussed, where it is fractured. Now the plan here in this situation is whether one should go ahead with radial head excision or fixation, and how do you treat the associated injuries. And for this neck fracture, having identified there are no radial head fragments, it's a purely neck fracture, and you can see there is a comminution on the lateral side. So whether tripod screws which are going obliquely are good enough, or that needs an additional plate, is a debate. So this can be approached by different ways, either by a Cocker's approach, Kaplan's approach, extensile Cocker's approach, and does the radial head replacement or a number of fragments of the radial head decide which approach you are going to choose? Very often we plan with a simple Kaplan's approach, which is when the lateral collateral ligament is intact. We go anterior to the lateral collateral ligament, where we have to fix the capitulum fracture or a radial head which has single fragment with a headless screw, or plating is usually difficult when you're doing in a Kaplan's approach. So if you have to do a plating or a replacement, you need a Cockers or extensile Cockers approach. But very often in them, radial head is not an isolated injury. It is always associated with a terrible triad or avulsion of the lateral collateral ligament, and along with that, the common extensors are also avulsed from the lateral condyle. So our job in getting a plane is much easy. We get enough space to fix the radial head neck or do a replacement or a plating in that situation. Yesterday we have already discussed how to protect the posterior introitious nerve, which runs just around the radial tuberosity by pronating the forearm. So the incision is, I am right-handed again. I have reversed the video so that it matches the X-ray. So the Cockers approach, centering at the epicondyle. The soft tissues are then incised, reaching the epicondyle in the center. On your right side is the humerus, on your left side is the wrist, below posterior is the olecranon. So then you try to develop a plane in a Cockers approach, but very often all these structures are avulsed, and once you reach the supracondylar ridge, you'll be able to peel them off, or they just come off, and the hematoma starts draining out. So you can see this is the lateral collateral ligament along with the muscles which are avulsed from the lateral epicondyle, and you can see it running from the epicondyle. The epicondyle is here. So the lateral ulnar collateral ligament runs from the epicondyle to the supinator crest. So it runs like that, it gets attached here. So if you pull it up, okay, so that is how it retracts, and that gives a stability to the elbow. So once having confirmed and having a good exposure, then we come to the fixation of the radial head, and that depends on how many fragments the radial head has. This was a neck fracture, so this is not correlating to that patient. So they can be fixed either with the temporary K-wires. You can assemble them outside if they are comminuted. More than 3 fragments or more than 4 fragments, but if they are good large, they can be fixed. But if it is comminuted more than 3 fragments, the rule is you have to replace them. So the capitulum acts as a mold on which you can reconstruct, or once having assembled them outside, you deliver it inside again and then fix it with a screw or a plate. So here in our situation, we had temporarily stabilized it with a K-wire as it was a neck fracture, and then used a plate to fix it. The only problem when you are fixing the neck or the radial head is you tend to give a valgus, and the key is you use a joystick in the radial head. You use a joystick in the radial head so that it comes in opposition to the capitulum. The capitulum acts as a mold, and then you temporarily fix it with K-wire, or then you put a plate. Otherwise you'll end up in an excessive laxity on the lateral side because of the valgus positioning of the neck. So having ensured in a proper AP and proper lateral view, you need a complete extension and a complete flexion so that you see whether you have not ended up giving a valgus. So this is not a proper AP view, that is why it is appearing like that. And second, your plate has to be at the center of the head, neck and the shaft. So if you completely pronate, even beyond or up to the radial tuberosity, you can go and fix the screw. Preferably 2 screws are enough Don't go beyond that. Don't extend your plate that long enough. So if you have a fracture which is going in the metaphysis, then preferable is to take a Wöhler-Henry's approach to fix the radial head. So what are the tips? When you're plating this, there is a screw which is going obliquely, and that screw is very important because it is a longer screw and it goes across, even if it doesn't have hole proximally in the neck, but it should reach the opposite side. It is longest and has a hole on the radial head. So oblique screw is again important when you're plating and positioning. So how to improve the cortical contact and rotation? Second important thing is whether your radial head is sitting in the lesser sigmoid notch. What is a lesser sigmoid notch? So this is, the olecranon is a greater sigmoid notch. Okay. What articulates with the radial head in the ulna is the lesser sigmoid notch. So there is a small semilunar notch on the lateral side of the ulna. So your radial head should be positioned in that so that patient gets a good pronation and supination. So that is what I was talking about. The radial head is, there is no space in between the radial head and the capitulum. So on pronation supination, you can see there is a good contact between the capitulum and the radial head, and on pronation and supination at the end, the plate is not impinging on either side, and probably it is difficult to see that lesser sigmoid notch. Since the movement are smooth, our screws are not piercing the opposite cortex, and probably the radial head in it is in the notch. So there are two possibilities which can arise. Either I have shortened the radius or I have lengthened the radius. So how do we check that? In an AP view, you should look for an equal joint space. That is, on the medial side, the distance between the trochlea and the olecranon, and on the radial side between the capitulum and the radial head. So these spaces should be equal in a supine AP. Okay. And in a lateral view, the tip or the top of the articular surface of the radius should be just at the level of the coronoid process. So that ensures I have not lengthened or shortened the radius. Okay. So this is not a true lateral view again. So you can see that angulation in the radial head, and that is normal. Okay. So the radial head should be at the level of the coronoid process. So these are the two key things whenever you are adjusting the length of the radial head. This is the 4 months post-op X-ray. This is 1 year, and that is his complete flexion and extension. Okay. So this is how the plating can be executed. The next is a radial head replacement. Should I continue or stop? Ivan, is it? Yeah. I have. So as I said, the indications would be so he's a lecturer in medicine, this boy, and sustained this fracture where the elbow got dislocated, the radial head is fractured, and even the coronoid process is fractured. We relocated him, but it was unstable, and that is his CT scan, where you see the radial head. There are multiple comminuted fragments, okay, and even the tip of the coronoid is not seen here. Probably it is displaced on the medial side or lateral side. And the 3D CT, it gives you a good information of what is the size of the coronoid